हेलो, वॉल्यूम बढ़ा दो।
Hello, can you hear me?
यार टीवी लगाते थे ना। वॉल्यूम तो बढ़ा दो।
Satish sir, can you hear me?
Yes, yes, feeble.
Feeble, but
Yeah. We are correcting this.
after that we can start. Okay?
Sir.
We'll have a small introduction. After that we can start. Okay?
Sir.
A very good morning to everybody. Welcome to the 9th edition of MAGENTA, MA Gopalakrishnan ENT Academia, hosted by AOI Malappuram Chapter and the MAGENTA Society. I invite Dr. Mansoor Kurikal, the organizing chairman of this conference, to deliver the welcome address.
Good morning, ladies and gentlemen. As the organizing chairman of MAGENTA 2022, first of all, let me welcome our chief faculty, the one and only one, Dr. Satish Jain. I'm also extremely happy to welcome our scientific coordinator, Dr. Shibu George, and our two home faculty, Dr. Vinod Felix and Dr. Vivek Shashindran. I am also very happy to welcome all the delegates who have assembled here and also hundreds of other delegates who are participating online. And I also welcome all the surgical companies who are cooperating with MAGENTA 2022. Welcome to the management and staff of Hotel Ridges in our venue, and the Digital Infotech Mumbai, the audiovisual team, and Nextcare Hospitality, our event team. Once again, thanking you all. Jai Hind.
We are starting our scientific session for today. As the saying goes, the success is not mere a luck, but a consequence of utmost integrity, determination, and dedication. Yes, the living example for the statement is our own Dr. Satish Jain, an innovator, researcher, and surgeon par excellence. We welcome you, sir, for the live surgery session. We're very honored to be part of it. The session will be chaired by Dr. John Panikar, past State President AOI Kerala, Dr. Sharfuddin PK, Director, Ascent Group of Hospitals. I would request Dr. John Panikar, sir, and Dr. Sharfuddin to chair the session. Over to you, sir.
Hello. See, we planned a surgical live demonstration from Jaipur. Sir has already admitted 7 patients, I believe, including petrosectomy, everything. But unfortunately, we all know that there is a strike going on in Rajasthan, but it is intensified today, from today onwards, I believe. So he cannot demonstrate the live surgery, but equally good unedited videos he will be showing, and there will be lectures in between. So if there is any chance of strike withdrawal, we'll start with the live surgery. Till then, we'll go ahead with the recorded videos. Is that okay, sir?
Yes, sir. Thank you.
Yeah, over to chairperson. Chairperson, Sharafu is there and John Panikar sir is there.
Good morning, Dr. Satish.
Good morning, sir.
Good morning, the chairperson, Dr. Mansoor, AOI President, Dr. Prabhakaran, other senior leaders of END in Kerala, and delegates. Actually, it's always a pleasure and honor to be attending a conference in memory of Dr. M.A. Gopalakrishnan, who was probably the most ideal ENT surgeon we ever had in Kerala. And also, he was very, very close to me as well as to Dr. Sharfuddin. And both of us are really honored to be chairing this first session in memory of a conference in memory of Dr. M.A. Gopalakrishnan. And also, actually, we are supposed to introduce Dr. Satish Jain, but I am sure it is quite superfluous. Still, he is just one word, that is, he is the probably the most versatile ENT surgeon in the world right now, and probably one of the most excellent teacher. And every day he comes out with a teaching video or a talk or anything. And I don't know. Actually, he's really a miracle. And we are proud to say that Dr. Satish Jain happened to be an ENT surgeon. And with this thing, I just handing over my mic to Dr. Sharfuddin, just to say about a few words about the present subject of autosclerosis and staphylectomy.
Good morning, everyone. Good morning, Satish ji. Good morning. Good morning. After a long time, again,
Yes,
you are here in front of us. We are all waiting for you, your magical hands for the demonstration of the surgery. But unfortunately, of course, I was telling Shahji, even without live demonstration, Satish ji can do wonders. So we are all here to hear from you. So over to you. Thank you.
Thank you. Thank you so much for inviting me again and giving this opportunity to be with you for this interaction. And I'm really sorry for not conducting live surgery today, to be part of the protest going on in Rajasthan for the unfortunate, untimely demise of Dr. Archana Sharma. And the entire Rajasthan unit is strong to fight this for the justice for Dr. Sharma. And we are all part of it. So thank you once again, but we'll be conducting this as a recorded video with a lot of interaction. And I think this is a good concept to invite more and more question, answers, and interactions. So I would request everyone to bring out with all your suggestions, ideas, questions to make it more and more interactive. Feel free to interrupt me any point of time. Thank you so much. And we'll be, as per the previous plan, we'll be going through various surgical procedures. So as discussed, I am starting with the autological process. And we all know one of the finest surgery in the ENT is stapes surgery. So our discussion starts with the stapes surgery. And we all know, let me share my screen first. Are you getting the screen, sir?
Yeah.
No, which screen? Screen share. Is it going? Are you getting some audiogram on the screen?
Yeah, we can see the audiogram. Yeah.
Yes. So once it comes to stapes surgery, we all know the stapes patient for his autosclerosis surgery is diagnosed mostly on the clinical grounds. And you all know, I know in Kerala, almost all autologists are doing stapes surgery to the best. And we all know everywhere, this disease is almost always diagnosed on the basis of clinical findings. And it is confirmed intraoperatively whether the stapes is fixed or not, and then go ahead. And these patients are classical in terms of presentation, mostly females, mostly bilateral, soft-spoken, with a good normal tympanic membrane, absolutely normal tympanic membrane, and yet hearing loss. When you put your tuning fork, Rini is negative, and that gives you a suspicion of autosclerosis. Then you get the audiogram done, and you find this kind of a audiogram. This is a patient which was operated on the other side earlier, and this for the other side, and see this kind of a picture with a dip in bone conduction, moderately severe conductive hearing loss, with a classical dip at the bone in the bone conduction at 2000 frequency, and that is classical of autosclerosis most of the time. This is all clinical diagnosis, as I said, and you have to confirm intraoperatively whether it is because of the fixation of the stapes or not. So, first of all, audiologically, we may not always get this classical Carrat's notch. But yes, once you find, this corroborates your diagnosis much better. And then we get the tympanogram done. And tympanogram finding, we all know, is a classical, type A, sometimes a shallow kind of a tympanogram if we get, that is more corroborative. But again, that is not always, something you look for the diagnosis. These are all corroborative findings which are not diagnostic at all. So first of all, for the audience, why Carrat's notch we give so much of importance? This is physiological to understand the process of hearing. We all know when we hear through the bone conduction hearing directly stimulates the bone and then the cochlear fluid. That is a direct pathway of bone conduction. Besides this, there are two more theories of bone conduction which contribute to bone conduction to some extent. As the skull vibrates, the ossicles also vibrate in relation to the vibration of skull. And if those vibrating ossicle in relation to the vibration of the skull transmit sound or movement in the cochlear fluid, that is another part, and that is the inertial component of the hearing that comes from the inertia of the ossicle in relation to the skull, because these ossicles are suspended in the skull, bones suspended within the bone. So they vibrate in relation to the skull vibration, and that, partially deflects to the cochlear fluid. Vibration of the cochlear fluid results in hearing. If this vibration is lost in otosclerosis when the stapes is fixed, and this leads to a small amount of, bone conduction loss, which is maximum at the inertial frequency of ossicle, that is 2000 hertz. And that we classically see in many of the patients with otosclerosis. This was initially described by Karat, and it's very, very, important sometimes. This is a big advantage because many of the patients, sometimes we find them as a sensory neural hearing loss, a dip in the bone conduction in otosclerosis is sometimes seen as a sensory neural hearing loss, because this is not the sensory neural hearing loss. This is apparent sensory neural hearing loss, which looks because of the fixation of the stapes, and it improves after stapedotomy once this fixation of the stapes is overcome by this bypass procedure when you put a piston, and this improves. So after stapes surgery, you get some apparent improvement in the bone conduction, that is known as Karat's effect, and that is something to be kept in mind. That's why when we finally measure the outcome of stapes surgery, your bone conduction improves. Bone conduction, your final air conduction sometimes may be better than the previous bone conduction, and that is known as the over effect of the stapes surgery. And that is something to be kept in mind, that the bone conduction improved because it was false reduction in bone conduction. It was not true bone conduction loss, and it was apparent loss in bone conduction, and it improved. So this is one thing. Secondly, about the tympanogram. Tympanogram is not always a diagnostic thing, but yes, we need to understand the theory of how the impedance is important, impedance works, and impedance is measured by the electroacoustic vision instrument with a probe inside fitted with two channels, one to give sound to the tympanic membrane at certain frequency, and the other is to change the pressure in the external aortic canal. So this is basically to measure the admittance, how the the overall medullary system behaves with the change in pressure. That is impedance audiometry. And what we see, if the impedance of the overall medullary is increased, impedance can increase. What the function of the medullary is? Impedance matching some, then it passes through the chain of ossicles to the inner ear, preferentially through the chain of ossicles to the inner ear. If that component of the middle ear where the sound is traversing to the inner ear, if the impedance of the system is increased, you can find a change in the admittance, and you will find the difference on the this printed report, where the not a direct diagnostic test. Sometimes, can you hear
some break in your audio?
me? Hello?
Yeah, now we can hear
Am I
you.
audible, sir?
Yeah, audible,
Break
but
in audio.
feeble, and some interruptions, some disturbances.
Because of network interruption, because of the internet.
Yeah, now.
Line
Some
other line.
unwanted
So
sounds.
what
Some
you see
external
on
sounds are also
impedance
coming.
audiometry is to
But you were audible.
Hello. Can you check your net? That is very low, I believe.
Still interruption?
No, no, no. Now it's clear.
The sound is low? Hello?
Now it's okay, sir.
Okay. I hope it is good now.
You can hear right now. No problem.
Okay. So what my submission was, the impedance, what we check in impedance is actually the compliance. Because of the stiff middle ear conduction mechanism, because of the fixation of the stapes, it may become less compliant. And what you see on this graph is the compliance level less than normal with the normal pressure, normal middle ear pressure. That is, goes again, something goes in favor of, stiff middle ear system. This is not directly attributed to the otosclerosis. This could be because of anywhere fixation in the ossicles or in the thick tympanic membrane, tympanosclerotic tympanic membrane, whatever, anywhere stiff middle ear system. And clinically, once you see in a patient with a normal tympanic membrane, with a classical Carhat's notch, with this kind of a less compliance, that again corroborates more towards the diagnosis of otosclerosis. So this is all clinical, this is not diagnostic. And what all is, finally confirmed intraoperatively by means of exploration. So there are so many other tests described, for the diagnosis of otosclerosis, which are normally not required on clinical basis. Yes, tuning fork is very, very important to confirm your audiometric finding. And another test which we nowadays always get done is a CT scan. CT scan is done not for the diagnostic purpose, for that matter. CT scan is done to see the anatomy of the tympanic membrane, which can complicate your surgical process, or for to rule out any misdiagnosis resulting in conductive hearing loss, which you are not seeing clinically, and which can warn you before you operate to make your results better, to make you prepared to deal with some abnormal anatomy, difficult anatomy, or some different diagnosis, and which can help you improve your results. So CT scan is definitely important. Otherwise, you can get surprises. If you don't have a CT scan and you get such kind of misdiagnosis, and that, let me take you through that. Otherwise, you may get into surprises. So, am I audible clearly now, sir?
Yeah.
Hello? Hello?
Can you hear me?
Hello?
Can you hear me?
Hello?
Hello?
Hello? Hello?
Can you hear me now? Hello? Hello?
Hello?
Communication.
Hello?
No. Hello? Can you hear me?
Am I audible now, sir?
You are audible.
Okay. So my submission was for diagnosis was an audiometry with tympanometry and speech discrimination score. Rest other sophisticated tests are not required for diagnosis always. If you have some doubt, you can get all other tests done. CT scan is one thing which helps us, surprises intraoperatively, help us prevent surprises intraoperatively. It gives you complete anatomical information for the area you are operating for to prevent you reaching some misdiagnosis, or it makes you, more prepared to deal with some difficult anatomical situation if you are there, which can complicate your course of stapes surgery. So our submission is there's no harm in getting a CT scan done, a good high resolution, fine section 0.4, 0.5, 0.6 millimeter, whatever CT scan done to get complete information, related to the otosclerosis and the stapes surgery procedures. So are you getting the CT scan there on the screen?
Yes.
So quickly, what all to be seen on CT scan in reference to otosclerosis and stapes surgery? CT scan of the tympanic temporal bone is conducted for various pathologies, and you need to look at certain aspects when you look for the autosclerosis. So let me take you through what all to be seen which are relevant from autosclerosis diagnosis and stapes surgery point of view. First of all, we all know phenomena of superior canal dehiscence syndrome. Superior canal dehiscence. What is superior canal dehiscence? Let me show you on CT scan where the superior semicircular canal. The first structure, I am coming in the axial section from top to down. See the first structure, the superiormost structure in the temporal bone, important structure is superior semicircular canal. This is the dome of the superior semicircular canal. If I go down, then you will see the anterior, ampullary end, and this is non-ampullary end. This is very, very important to understand why it is so important once you talk of autosclerosis, because I'll give you certain examples how we face this difficulty after operating upon those patients. Because many a time patients, some may get confused in this phenomenon of superior canal dehiscence. What actually happens? This gives you a third window from the labyrinth. Labyrinth normally has two windows. Sound preferentially comes through the ossicular chain to the oval window. The oval window goes in, the fluid, perilymphatic fluid mobilizes, it gives vibrations, and the round window comes out. And that's how this baffle action of the oval and round windows gives you a sort of hearing sensation, because it generates the action potential for the hearing. Now, if there is a third window anywhere in the labyrinth, the sound will dissipate, and that will give you a fake or a false conductive hearing loss phenomena. Whatever sound going to the stapes is not actually completely involved in generation of action potential for the hearing, because the sound is getting less. And this is what happens if there is any dehiscence in the superior semicircular canal. This is a known phenomenon, not very uncommon, I would say. And there are hundreds in publications depicting this. And we also found some cases. The first case, let me give you an example, which came after we operated for a patient, and there were no autosclerotic finding, entirely normal middle ear, all negative finding in the middle ear, ossicular chain mobile, everything mobile, and that patient had a conductive hearing loss. We went back. After we operated that patient, post-operatively, patient became dizzy, had all vestibular symptoms, classical symptoms of superior canal dehiscence syndrome, because before the surgery, the foot plate in autosclerotic patient, when you operate, when the stapes is truly fixed and there is a third window, what happens? It acts as only two windows and doesn't give you many a time symptoms of superior canal dehiscence. Once you put a piston, once you do the stapes mobile, whatever, then the symptoms of third window manifest. So it uncovers the symptoms of third window sometimes when you operate upon such patients. So that is something need to be kept in mind. Now, how to look on CT scan about this phenomena, whether the superior canal is dehiscent or not. So as I told you, the role of CT scan is to rule out some other misdiagnosis. Let me tell you, to be best seen on coronal scan. How will you see on coronal? See, this is your labyrinth. This is your vestibule. These are all three semicircular canals. This is the lateral semicircular canal. That is the posterior semicircular canal. And this is the superior semicircular canal. If I run this, see the superior canal. There is a thick bone over it, normally which remains. The thick bone over it. And then this is the non-ampullary end. So this is non-ampullary end. And this is the dome of the canal, and this is the ampullary end opening into the vestibule here. That's a lateral canal. So what you see normally is a thick bone over the superior canal with no superior canal dehiscence, you can see. Yes, if it is along with autosclerosis, the moment your stapes is mobile, the third window symptoms may appear. So third window, how will it present? Mostly they present with otological as well as vestibular symptoms. Audio as well as vestibular symptoms. The pressure change onto the middle ear can lead to the vestibular symptoms of vertigo and dizziness, can lead to otological symptoms. and all this is responsible because of the superior canal dehiscence. You can easily pick up. Sometimes if your stapes is truly fixed, these symptoms are masked, and the moment you put a piston, all these symptoms become apparent, and that is how we diagnose. Or one of the case wherein the patient was asymptomatic for the superior canal dehiscence and become symptomatic later on.
Dr.
So
Satish,
what you need to
Dr. Satish, can I just interrupt? Have you seen bilateral superior canal dehiscence?
on CT scan if this kind of hello.
Excuse me, Dr. John Manikar, just I want to know, have you seen bilateral dehiscence of superior canal?
Yes, sir.
Hello?
Me.
Have you seen bilateral dehiscence of superior canal?
I have seen unilateral dehiscences, not bilateral,
Okay.
so far. And
Generally, otosclerosis usually bilateral, generally in conductive deafness. So if it is a bilateral conductive deafness, still you have to go for a CT scan to rule out this dehiscence.
yes, if there is superior canal dehiscence, if you are planning any surgery for otosclerosis, it's better to rule out this phenomena, which can complicate your post-operative procedure. It can, it may not allow you to achieve your hearing results if it is because of the superior canal dehiscence. So what happens normally in this phenomena, your vestibule, your inner ear become more sensitive to the hearing, and many a time these patients you will find easily. Now, what symptoms, what can
We are missing your audio.
clinically for thinking? What is the problem with audio now? Is it still interrupted?
No, now it is okay. Yeah.
It's okay.
Yeah.
So what I was telling, clinically you can, if you are very conscious, if you are very, clinically conscious to diagnose such conditions, there are certain reasons, certain signs, symptoms by of which you can have a suspicion of diagnosis of superior canal fistula, like audiological symptoms. These patients are more sensitive to sound, and you will find they will hear their own sound so easily. Whenever they swallow, whenever they do anything, they will hear their own sound. Even they will hear the movement of the eyes. That is becomes. You do a tuning fork test, even if you do your
Bangle. We are losing your
tap your
audio
tuning
again.
fork on your hand, sensitive. So that is one sound, one symptom which can give you suspicion. Another is on audiogram.
We are not hearing you.
Mostly the bone conduction, even in minus, there is more sensitive because of the super sensitive bone conduction. So these, if you can reach to some suspicion of superior canal dehiscence, and then
Also, the tympanic reflexes will be present, unlike the otosclerosis.
it is can done to confirm whether it is. If it is alone,
Hello.
hello.
Yeah, now we can hear.
Yes. So there was some interruption. So some changes required for a moment.
Yeah, some changes required, sir, but it's often getting interruptions. We can fix that problem, I think.
Yeah. I think it will sort out in a moment.
Now we can hear your audio very well.
Dr. Satish, since we have a... Hello?
Hello?
Satish,
Their volume is not coming. Hello.
Satish?
Yes, sir.
Yeah. Just in between, just one regarding the etiology. We know mainly it is genetic, but is there any immunological issues in the etiology?
Sir,
Hello?
fine. Hello.
Yes. We can.
Yes, sir. I can hear you better now.
Yeah. Just in between, just one question regarding the etiology.
Yeah.
See, other than the genetic factor, is there any immunological reason for? Because nowadays, at least in Kerala, the incidence of autosclerosis is coming down. And is there any other reason to explain? Also, as we know, it is more in females. So, is there any other reasons other than the genetic?
See, there are many diseases which are more common in females. And regarding the etiology, there is no such single etiology one can propose. There are so many theories proposed, right from genetic to acquired to the measles, and so many theories proposed for the occurrence of autosclerosis, but no one has been accepted as a sole cause of autosclerosis. Yes, there are so many theories proposed. So still, what we conclusively say, the cause of the autosclerosis is still unknown, except some genetic causes.
Yes. Okay. Thanks.
So what we were discussing about the superior canal dehiscence. So in case clinically you have a doubt of superior canal dehiscence, coming to your last question, whether the superior canal dehiscence, if you find clinically, radiologically, would you operate? Now, if there is associated autosclerosis, we should avoid operating superior canal dehiscence first. We need to correct the superior canal dehiscence first before doing any autosclerosis surgery. And if the superior canal dehiscence resolve the problem and there is no associated autosclerosis, nothing is required to be done. But if there is associated autosclerosis, then we can correct the autosclerosis by means of stapes surgery. So that should be the protocol. And secondly, on radiology, there are certain parameters which we follow would not give post-operative problems in an undiagnosed case. So suppose you have an autosclerosis patient along with a superior canal dehiscence, which goes unnoticed, you operate and the third window symptoms appear. So what are the cases which you should avoid operating if you find an autosclerosis with superior canal dehiscence? Mostly presents patient with a large dehiscence or dehiscence close to the ampullary end are those patients wherein we should avoid operating at all. We first correct the dehiscence. If the conductive loss persists, then only we should pursue with the autosclerosis surgery. Otherwise, we should avoid autosclerosis surgery in those patients. Yes, sir. Any questions after this on this?
In the differential diagnosis of third window syndromes and the autosclerosis, the WEMB and the tympanic reflexes will also help us, no?
Yes, because in a sole superior canal dehiscence, your stapedial reflex may be present if the conductive loss is not so much. If the conductive loss is high, even in any given situation, whatever the diagnosis is, the reflexes may be absent. But this is one of the ways. Third is, if you have a strong suspicion, then you can get the WAMP done.
Yes.
WAMP is classically absent in autosclerosis. But yes, if it is present, it rules out the diagnosis of autosclerosis. So those tests are required only if you have a strong suspicion, otherwise not required to be done.
And also the OAE will be absent in autosclerosis.
Yes.
Yeah.
In normal autosclerosis, in a case of confirmed autosclerosis, the OAE is absent. So any conductive hearing loss will result in OAE absent. That is
not classical to atherosclerosis, I would say.
Dr. Satish, is there any role for MRI in diagnosing autosclerosis?
Not in diagnosis, but since you have asked about the MRI, let me tell you, MRI has importance, and we are doing a huge study on it and got some encouraging results to get the MRI done. There are two indications of MRI, if you ask me. Can I answer this?
Yes, please.
One indication for which we are working on is to diagnose subclinical endolymphatic eye drops. You know, many patients in autosclerosis surgery, you do a good surgery, come out after putting a piston, yet you get sometimes profound sensorineural hearing loss without any single, lacuna in the surgery or anything. Because many times you don't know what reason was responsible for, profound sensorineural hearing loss. And one of them is a subclinical endolymphatic eye drops. You never know the grade of the eye drops. You open the vestibule and your piston happens to penetrate the membranous labyrinth and can result into sensorineural hearing loss. Then how do you get to know? The CT scan doesn't differentiate into the soft tissues behind the stip.
Hello. Again, we lost the audio. We are not hearing you, sir.
Satish ji, what happened? Satish, can you hear me? Satish ji? Satish? Hello? Hello, Satish, can you hear me? Satish? Hello? They are changing the internet. Within 2
Hello.
minutes, they will change that
Hello?
internet.
Hello, am
connection.
I audible?
Yeah, now
Yeah, yeah.
audible.
Yeah,
audible.
yeah. Was sorry for the interruption
no.
as they changed to a different, internet speed.
Oh, great.
Really sorry. So, what I was discussing about the subclinical endolymphatic eye drops.
Yeah.
So, if it is clinically apparent, endolymphatic eye drops, the patient would present with some sort of vestibular symptoms. But many times, in spite of having endolymphatic eye drops to a, lesser level, maybe good amount of eye drops, but not clinically apparent, and with a conductive hearing loss suspecting autosclerosis, if you operate upon such patient, it can be a disaster. In spite of a good surgery done, it can result into a complete, profound sensorineural hearing loss. So how to pick up those patients of, subclinical endolymphatic eye drops? The investigation required for that is MRI, which is proven to be so useful in investigation. MRI is in those situations which can pick up ongoing subclinical endolymphatic eye drops. How? What sequence MRI we get done? We give gadolinium IV, and after 4 hours of the gadolinium injection, we take a MRI. The contrast MRI after gadolinium, after 4 hours of gadolinium injection, will show the gadolinium picked up in perilymphatic space. Gadolinium is never picked up in endolymphatic space. Kya hua? Is on? Am I audible?
Yes.
Yeah. So what happens after 4 hours of injection? If you take MRI, you will find the gadolinium picked up in perilymphatic space, and there you can easily pick up the areas which are where the gadolinium is not there, that is endolymphatic space, and we can easily see whether there is high drops of the endolymphatic space or not. If there is high drops of the endolymphatic space, then it is something I would say. Let me show you some pictures if I have to show you. Yes, I might be having here some pictures of the high drops. Yes. Can you see this?
Yes.
This patient, see this perilymphatic space is occupied by the gadolinium, and you don't see any endolymphatic space. Now here, see the gadolinium is taken out of the perilymphatic, and the endolymphatic space is enlarged. The dark spots where there is no gadolinium is enlarged, and see in this patient, the endolymphatic space is much bigger, which is not taken up the gadolinium, much bigger than the perilymphatic space, and this is a classical high drops. The patient is absolutely, asymptomatic from vestibular point of view, yet having endolymphatic high drops, and if it is not known to the stapes surgeon, can result into a disaster, because in such patients, your saccule is dilated and comes close to the foot plate, and you happen to, perforate the foot plate, can result in perforation of the saccule, and that is a disaster. So your MRI can pick up and prevent this disaster from setting in by means of picking up such cases and avoiding autosclerosis surgery in those patients. That is one very important role of MRI, I would say.
Okay.
Number two, and more than that, such patients, because why this is important, in spite of a best surgery done in stapes surgery worldwide, you will find up to 1% incidence of dead ear or profound or whatever degree of sensorineural hearing loss in the best hands in the world, because that is beyond the control of the surgeon, because everything what is going on in an inner ear is not known to anybody. So this is one thing which can be picked up by MRI, and MRI is so useful. This is relevant because most of the litigations in otology is such vast. CSOM is a vast disease in our country. In spite of being the autosclerosis as a disease with less numbers, majority of the litigations in autology are directed towards the stapes cases or towards the operated stapedotomy cases, and this is one of the reasons we have to be very, very careful, because these are the patients who come with conductive hearing loss, and it is unacceptable to everybody when the patient goes back with a dead ear or a profound sensorineural hearing loss. So we have to do something to pick up those patients which can result into such situation, and MRI is one of the way to find out those hidden subclinical endolymphatic eye drops. Another role of MRI, now I would say, is, let me tell you, is for other medical reasons. You know, the medical therapy earlier was fluorides, and nowadays biphosphonates have come up with more vast, more, I would say, effective than the than the fluorides in the medical management of autosclerosis. So medical management, there are certain questions unanswered. What cases require medical management? How do you monitor the results of the medical management or the effect of the medical management? And here again, the MRI can be one of the most useful investigation. And nowadays in our clinical practice, we have found this MRI to be useful as a guide for medical therapy. Let me put how it is important. See, this is the spatial sequence we get for this medical therapy. Clinically, what cases require medical therapy? Patient with some sort of mixed hearing loss, some sort of inner ear, changes due to autosclerosis, some who have cochlear autosclerosis, which have already given sensorineural hearing loss, some early patients of autosclerosis who have a family history. So there are a number of indications for, medical therapy. Now, how do you objectively see this, whether it is required or not? See, there's a 3D flare fluid inversion recovery sequence on MRI, which makes your CSF or whatever fluid absolutely dark. Which makes your fluid dark, fluid as a dark signal. So when we see in the inner ear fluid will appear dark. Inner ear cochlea and vestibule will appear dark, containing fluid on 3D flare. If there is any proteinaceous changes in the fluid or the biochemical changes in the fluid, they will appear bright. In a known case of autosclerosis, this kind of appearance of the bright signal in the cochlea and the vestibule shows biochemical change or shows proteinaceous alteration in the inner ear, which gives you an indication that the autosclerosis has affected the inner ear and need for the medical therapy. This is the principal guide for us now to initiate the medical therapy for autosclerosis patient. Number two, when you give a contrast, and this kind of changes coming after the contrast, that means your contrast is going into the endolymphatic space now, which otherwise is restricted by the blood lymphatic barrier. Now, once the blood lymphatic barrier is gone and contrast is accumulating into the inner ear space, that gives you a strong doubt your autosclerosis has affected the inner ear quite badly, and these are the cases which require medical therapy. And not only the initiation, not only the indications for the medical therapy, these patients can be monitored after the medical therapy, whether it is effective or not. And the serial MRI after the initiation of the medical therapy, after months, according to the clinical condition, you can get periodically done to see the response of the medical therapy. Besides the clinical response, this objective response you see on the MRI is amazing. So MRI, your question was the need for the MRI in autosclerosis is different aspect, not for the diagnosis of autosclerosis. Our CT scan was initially indicated not for the diagnosis, but for the operative point of view, to see any difficult intraoperative conditions one may come across, otherwise may result into surprises. So I hope this answers your question for the need of the MRI.
Yes, yes, absolutely.
So the other reasons, yes.
Yes. Actually, this is a new information for all of us. Thank you.
See, autosclerosis patients are most demanding patients, I tell you. patients coming with chronic suppurative otitis media or for other pathologies for tumors and all are not so demanding. The otosclerotic patients are majority young patients. They are demanding for the hearing. They're present with conductive hearing loss. This surgery requires highest level of diligence. We know we deal with a structure with a weight of milligrams, and this requires a highest level of diligence, and nobody can afford the sensorineural hearing loss in such patients. So we have to, evolve all those methods to prevent the sensorineural hearing loss in these patients. And that's how the radiology has come up as in a big way to identify misdiagnosis, to identify regions which can, you can predict by means of which the future sensorineural hearing loss possibility. So MRI, CT scans are important because this is technology, and technology is evolving much faster than any other thing in the present era.
Satish, sir, can I ask one question? Dr. Vinod Felix here.
Yes,
sir, when we ask for MRI for the Meniere's disease, they ask for the radiologist say we must go for a 3 Tesla MRI. 1.5 Tesla wouldn't pick up an eye drops in.
I know 3 Tesla is always better. Yes, you can pick up in 1.5 Tesla, but yes, the resolution in the inner ear with 3 Tesla is much better than the 1.5 Tesla.
Okay, thank you.
Sir, so what all other things to be seen on CT scan from otosclerosis point of view? One was superior canal dehiscence. Number 2, I'm going from upside down. Number 2, many of the patients we have seen, any stapes surgeon in the audience who have done number of stapes may have come across sometimes the gusher. And gusher is one thing which has a negative impact on the overall outcome. And if not picked up before surgery, can be a disaster. And by means of CT scan, we can easily pick up the future gusher. How? The gusher means connection with the CSF, direct connection of the inner ear fluid with the CSF, wide communication with the CSF spaces, wherein you perforate the foot plate and the CSF gushes out. And you can pick up on CT scan by certain signs. Number 1, if you have a wide intra-auditory meatus, bulbous intra-auditory meatus, see the dimension of the intra-auditory meatus I can measure here to be in the middle of the course is around 4.18. See, this is normal. If it is wide, bulbous, you can expect an indirect, direct communication, wide communication with the inner ear fluids, and that is something warns you to avoid a stapes surgery in those patients. Number 2, lot of things people propose the cochlear aqueduct as a cause. See, this is the basal turn of the cochlea, and this is the cochlear aqueduct coming from here. Cochlear aqueduct has been proposed as one of the causes for the CSF gusher, but has never been proven. So forget about the cochlear aqueduct, which is rarely responsible for the direct gusher. Number 2, which can result into some sort of gusher, or I would say not true gusher, then oozer, is the dilated endolymphatic duct. See, this is endolymphatic duct. You can pick up on CT scan. I hope it is visible.
Yes, very much.
See, this is endolymphatic duct, and this, if I run, this is connected to the medial part of the vestibule. This is vestibule. This is connected to the medial part of the vestibule and emerge at the petrous surface. So if it is dilated, can result in some sort of oozer, high pressure in the endolymphatic system, endolymphatic hydrops. It has all negative impact on the overall outcome of otosclerosis, and such patients should be avoided for otosclerosis surgery. Because what happens if your endolymphatic or the inner ear pressure is much higher? It can give you clinically on audiogram and all these a sort of conductive hearing loss in spite of the foot plate not being fixed. A persistent high inner ear pressure Inner ear hypertension can restrict the mobility of the foot plate, which can result into a conductive hearing loss. And if it is because of the dilated vestibule, dilated vestibular aqueduct or endolymphatic hydrops for whatever reason, and such patient is taken up for stapes surgery, can result into a disaster. So we have to be careful on radiology what cases need to be avoided to prevent disaster. And here CT scan gives you an amazing, pre-operative details of all these, possibilities to be prevented. So first semicircular canal, then the gusher, and third thing, very, very important, is the facial nerve. Many a times what we have seen, couple of times, the facial nerve descends, facial nerve prolapse, facial nerve completely obliterating the oval window. And how you can pick up? By means of CT scan very well. See, let me show you the course of the facial nerve. This is the labyrinthine segment of the facial nerve. That is the first genu here.
Yes.
If I go down, see, this is the greater superficial petrosal nerve. Going down, this is the tympanic segment of the facial nerve, and then is the vertical segment. Now, how to know whether the facial nerve is prolapsing on the foot plate to make our stapes surgery difficult? We have seen in our series grade of prolapse of the facial nerve in a different way. What you need to see is an upside down view so that you can see from above. See this at this level. See at this level. This is, let me show you the ossicular chain. Malleus, incus, includostapedial joint, and the stapes crura. Can you see this?
Yes, yes.
And going to the foot plate. This is the foot plate here. This is vestibule. All these canals connected to the vestibule. So this crura going to the vestibule. See here. And what is there above? This is facial nerve. In this upside down view, you can see how much facial nerve is descent, how much it is overhanging, and how much it can obliterate your space to put your piston. It's very, very important to know pre-operatively, otherwise you may get surprised intraoperatively. You being an experienced surgeon, still without this information intraoperatively can manage. But it is always better to know pre-op this phenomena, this abnormality, to discuss with your patient, counsel your patient much better, because nobody is going to afford any sort of facial nerve palsy coming across after this surgery. So this is very, very important. You can see whether it is descent, how much it is prolapsing, you can see how much it is coming down. Simple. We have seen prolapses partially occluding the foot plate, completely obliterating the foot plate, and we have seen a case of complete agenesis of the foot plate with maximal conductive hearing loss. And this can be verified genetically also, because the development of the foot plate and the development of the facial nerve are together in 6th, 7th week of the embryo together. The stapes suprastructure coming from the second arch join the inner ear development, the inner ear, vestibule development together. At the same time, the facial nerve is developing just above it. If it goes down, facial nerve, that time, it will prevent the fusion of the suprastructure to the oval window and can result into atresia of the oval window and a complete facial nerve prolapse over there. So all these things can be corroborated, and what you need here intraoperatively before any surgery to know kind of facial prolapse there. If there is a slight or some significant prolapse with little space on the foot plate down, still you can manage by, pushing gently the foot plate, the facial nerve up to acquire some space. And if you can make a fenestra over there, you can put a piston. Generally, this piston, even little bit, pressing on the foot facial nerve, impinging on it, doesn't really give facial palsy. So all these things are important. A CT scan will guide you all these things. It can prepare you pre-operatively whether it is required or to deal with or not. So this is third thing which we should know on CT scan, which is very, very relevant. It's not very relevant, it is very, very relevant, and this information is really useful if you have pre-operatively. Now, there are any questions so far, sir? Please.
No,
Hello?
No, you can continue.
Yes. And the fourth thing about the ossicular chain, What happens? I told you the CT scan is not required for the diagnosis of autosclerosis as such. But yes, in certain situation when the cochlea and other things are affected too much, you can diagnose on the CT scan also the magnitude of the problem, the autosclerotic foci, if it is too big and affecting the cochlea. See this on CT scan. This is your stapedial crura. Can you see?
Yes, yes.
This is your foot plate. This is your vestibule. Normally, the first, foci, autosclerotic foci, come just anterior to the foot plate. That is here anteriorly, and that will show as a hypodensity. Autosclerosis is what? Demineralized bone with vascularity appearing as a hypodense bone as compared to the rest of the cochlea. So you may find a small focus anterior to the foot plate. I can show you in some of the slides. Let me give you an example how it looks like the autosclerotic focus. See this. The autosclerotic focus, you can see. See this hypodense?
Yes, yes.
Foci anterior to the foot plate, that is classical autosclerosis. You can confirm your diagnosis if you get this. Now see in this patient, a different gauge. The foci is almost completely occluding the foot plate. This is obliterative foci. See this, the thickness of the obliterative foci, you can measure. You can measure from right here to here, must be around more than 1.5 to 2 millimeter. And if you have this kind of a foot plate, if you have this kind of a foot plate on radiology, what will you tell your patient? The results are not going to be as straightforward. The surgery is not going to be as straightforward as a thin foot plate. And this is something need to know before, so that if it is there, you can discuss with your patient, as there is obliterative foot plate which requires lot of drilling, and then fenestration and this thing, and the results of obliterative autosclerosis are always inferior. You can go through the entire series published so far, that the results are the obliterative are much poorer than the results of a normal foot plate. So it is important to know if there is obliterative foci. You can pick up on your CT scan very well, and you can be much prepared. An experienced surgeon can still go ahead with obliterative focus. You can drill and all that and give good results. But this is something which has a significant impact on the overall outcome. And it is always better to know before, to be prepared to deal with that, and to counsel your patients, because results are relatively inferior. So this is one thing. You can see this, how thin the foot plate is. Can you see?
Yes, yes.
On a good cone beam CT scan, we can measure even 0.3 mm thick foot plate very clearly. And this is an important factor to know whether the foot plate is obliterative or not, whether there is hypodense foci there, and whether there is diffuse involvement of the cochlea. Because if there is diffuse involvement of the cochlea, the indication for the medical therapy comes first. You need to start medical therapy immediately to arrest the progress of the autosclerosis, which can result into further hearing loss otherwise, sensorineural hearing loss otherwise. So this can be directed on the basis of the CT scan. Then rest of the ossicular chain is important to know. Why it is so? See, this is stapes, this is incus, this is malleus. Many a times we have seen fixed hyalinized anteromalleolar ligament, or converted to a bone completely fixing the ossicular chain along with autosclerosis. I have seen in my practice 2 cases with complete, ossified anteromalleolar ligament, the bone. And if you don't correct that, there is no point in, thinking of good results from autosclerosis surgery alone, as the lateral chain is fixed, and you can get to know pre-op very well. This is anterior-posterior view. This is anteromalleolar ligament extending from the malleus towards the anterior wall, anterior canal wall. And if it is ossified, you can think of drilling that away and releasing the ossicular chain and getting good results. So all these things are important. Another important thing you must have seen in our practice as well, we have seen couple of times more than the anteromalleolar ligament ossification is the superior fixation of the malleus into the atic. What happens with the superior fixation of the malleus into the atic? The malleus will become fixed into the atic, and the lateral fixation of the malleus will never result into sound conduction and conductive hearing loss will persist. So it may or may not be associated with otosclerosis. Sometimes it can be a sole finding resulting in conductive hearing loss, and the patient explode assuming otosclerosis, and this can be very well picked up. See, if there is ossification or anything in this coronal picture, you can easily get to know.
Yes.
Got my point?
Yes, yes.
So all these are abnormal findings. Misdiagnosis you can correct by means of CT scan. So I said it is not mandatory, it is useful. It makes you it prepares you for difficult situations to deal with, for misdiagnosis to deal with, and so on. And another thing which can complicate your course beside this, relevant to otosclerosis, if there is any cochlear carotid dehiscence, because that can also act as a third window like superior canal dehiscence. It's the same thing. Anywhere dehiscence in the inner ear can manifest as a third window. Regarding the jugular bulb, if it is too high, we have seen patients with the jugular bone bulb coming even onto the foot plate, and you can see that is rare, but you can pick up very well at what level the jugular bulb is there. See, this is the level of the round window, this is the level of the foot plate, and there is no jugular bulb coming over there. So these are uncommon things, but you can find. Another questions, we have got just one line, simple online question about diagnosing the persistent stapedial artery. In my practice, I found 4 or 5 cases of persistent stapedial artery. How you can diagnose? See, this artery embryologically is absorbed by 10th week of life. It runs over the promontory and then passing around which the stapedial crura formed, the obturator foramen is formed as this vessel is absorbed, and then it passes through the facial canal intracranially. So normally it gets absorbed and it becomes a future middle meningeal artery. Now what happens in situations where this vessel is not absorbed, not obliterated, and it persists in adults? It can result into conductive hearing loss, it can result into tinnitus, it can result into creating problems during stapes surgery if it is associated, and then you may find as a surprise. There's a thin vessel, small vessel, you cannot pick up a soft tissue directly on CT scan, but there are some indirect ways, because if this vessel passes through the obturator foramen and then through the facial nerve, the dimension of the facial nerve will be much bigger than the normal tympanic segment of the facial nerve. That is one indirect sign. And second is if you see, this is the foramen spinosum through which the middle meningeal artery passes, that will be absent by and large. There are variety of persistent stapedial artery situation. The most common being where the absent foramen spinosum there are 4 varieties of persistent stapedial artery scenarios, and the commonest one shows then the abscess of the foramen spinosum. So there are indirect ways to find out, then your clinical decision whether to operate or not is yours, because most of the time this artery is small, you can coagulate and go ahead. If you don't, you can give patient a hearing aid, but tinnitus will persist, and there is no harm in a small vessel now coagulating. We have gone through the literature. If it is too big, you can get an angiogram done to see if it is responsible for any blood supply to the important brain areas or brain stem or somewhere, can lead to a problem. So otherwise can be coagulated well. So these are the quickly the clinical scenarios, the way what important things to be picked up on CT scan before any otosclerosis surgery. We'll go to the surgical part now. And any questions before we move on, sir?
The cone beam CT, because we have cone beam CT. For the last 1 year, we are taking all the stapes patients.
Yes, it's amazing.
Yeah.
Cone beam is amazing. You can get, see, here my thickness of the slices, you can see 0.7 millimeter. Cone beam, you can get even 0.05 millimeter.
Yeah.
On a good quality cone beam CT is amazing. Not only the the details, but it is with a less radiation, comparatively much less radiation, 16, 17 times less than the regular CT scan, much faster, can be done in any difficult patient because it is done in sitting position, in couple of seconds can be completed, and this is very, very useful. So cone beam, I would say, is the number one technology for CT scan of the temporal bone. High resolution CT scan, not contrast. Contrast cannot be given with cone beam.
Yeah.
Cone beam is useful for certain situation, not for everyone. No angiogram can be done on cone beam. But for this high resolution, yes, cone beam is number one. Any other thing, sir?
No, we will go to the surgical part. Yeah.
Okay. So I will run this one of the recorded video now. Let me pass this. Yes. So most of the time, the stapes surgery is done. Can you make it full screen? Yes. So most of the time, this surgery is done transmeatal. You know, the exposure is the key. And most of the time, the exposure required in the posterior superior quadrant of the mesotympanum is achieved better transmeatal. You can have a direct, alignment after removal of some sort of, curating some sort of overhang of the posterior canal wall. Kya hua? Internet? Done? It's good? Connected? Okay. So most of the time you achieve this exposure transmeatal. If you are finding any difficulty in any narrow canal, you can go ahead by means of, mini endoral incision to release and fix your speculum or whatever. But most of the time you can achieve this transmeatal. So that is one thing. Secondly, about the incision, see what I've been doing here. My incision is very simple. Our area of interest is the posterior superior region. So what we give is a horizontal incision first, a few millimeters lateral to the annulus. This is very important. There's a clinical judgment. You can't measure in millimeters as such, but yes, this incision should be placed a couple of millimeters lateral to the annulus. It should not be too medial, as you need to, remove a lot of overhangs sometimes, and this may fall short at the end of the surgery, and you have to graft this area to prevent that perforation. And it should not be too big. Too large a flap can be cumbersome to deal with. So flap should not be big enough to become cumbersome. So this is a simple horizontal incision, number one. You can see inferiorly is not our area of interest. So what we do, inferiorly, you will see, we'll make a release incision inferiorly. Superiorly is our area of interest. Superiorly, I will not, see, this is a curvilinear incision. We will continue superiorly till required. In case some anteromalleolar ligament fixation is there or anything is required to be done anterosuperiorly, I can further enlarge this incision superiorly. But inferiorly, this is inferior. Inferiorly, you are not supposed to go further, as you are not supposed to deal with the inferior part of the tympanum or the inferior quadrant at all. See now, focus inferiorly. This is the horizontal incision. This is inferior. This is superior. So now, inferiorly, see what I am doing is a release incision. This is release incision inferiorly so that the flap doesn't come in the way. See now the flap is being elevated. The posterior flapping is being elevated like for any other ear surgery. This simple raising the tympanomeatal flap in the posterior part. Simple in the posterior part. This is transmeatal approach. You can see and see your incision, the posterior incision now. And this is unedited. And see, this is being raised posteriorly. Inferiorly, we have given a release incision so it doesn't lead to flap tearing. Superiorly, the same horizontal curvilinear incision is on, which you can further, enlarge in case required to go far anteriorly. but interiorly we will limit it and reach to the level of the annulus. This is reaching to the level of the annulus. And now see superiorly, you can further extend it till required. Till required.
You routinely extend it anterior to the lateral fossa of malleus to see the AML, or only if required?
Yes. So what we do, generally we extend it up to 12 o'clock normally. And in case the AML is required to be dealt with, we can extend it further anteriorly to the 2 o'clock.
Okay. What about the anesthesia? Is there any indications for GA, like the juvenile, smaller children? With
Preferentially, we do this surgery under local anesthesia, which has various advantages.
Yes, sure.
Number one, with local anesthesia, you can check the improvement in the hearing on table. Number one, this is the biggest advantage. And if you have any doubts, I remember Dr. ABR Desai doing, our friend Dr. Ashim Desai doing, always doing intraoperative audiometry. They themselves do intraoperative audiometry to see the hearing improvement. In any slightest doubt of, lack of improvement, less improvement, they will again go on anteriorly, check everything, go anteriorly, check the anteromalleolar ligament, divide it, and see again the hearing improvement. Any change in size of the piston, length of the piston required, anything, readjustment are done, and again the audiometry done. So improvement of hearing can be checked intraoperatively on table. That is the biggest advantage for of doing this surgery under local anesthesia. See the exposure, the posterior exposure, the flap being elevated posteriorly, and then limiting antero-inferiorly. Posterior-inferiorly, see, this is being elevated posterior-inferiorly where we had given a release incision, so that the flap can be juxtaposed anteriorly. Yes. Without the flap being coming, again and again into the view. This is the chorda tympani. The glimpse of the chorda tympani you can see here. So one advantage of the local anesthesia is the feedback of the hearing improvement. Number two, very, very important feedback in case you happen to manipulate the vestibular end organs by means of, unwanted suction, by means of your piston being long, impinging on the vestibular structures, the patient will perceive vertigo. And that is something, a feedback where you need to stop and recheck. That is a very, very valuable feedback which is otherwise lost under general anesthesia. See, decision to do under local and general anesthesia is a merit-based. Nowadays, many patients are demanding to get surgery done under general anesthesia for their comfort. Comfort has become another decision-making factor nowadays, So comfort level is important nowadays from patient's point of view, and many of the surgeons for that reasons are doing this surgery under general anesthesia. But this kind of a feedback, what you get under local anesthesia, is lost under general anesthesia. So local anesthesia is always preferred. See now, see this flap is elevated till 12 o'clock, and the flap is just juxtaposed anteriorly. And now you see the glimpse of the incus. You see the glimpse of the incus here. Not anything. What you all need now is the exposure. You need a good exposure to carry out this surgery. We are operating on a foot plate. We need to have a complete all-around exposure of the foot plate before we deal with it to see any otosclerotic foci or any abnormality all around. So the entire foot plate must be exposed, and for that the obstacle comes is this part of the overhang of the canal wall, and that need to be removed. See now here I've been curating with the curating this canal wall. Your chorda tympani is just below. You have to be careful regarding the chorda, as it may come into your curate otherwise and can lead to changes, because preservation of chorda is important in this surgery, which may result into test disturbances, though majority of them recover over the period of time for various reasons. But yes, this is something, if you damage the chorda, it will manifest. Unlike chronic suppurative otitis media, where the chorda tympani is involved in the inflammation itself, develops neuritis, and the section of the chorda tympani many times doesn't manifest with the test disturbances. But here, there is an absolutely non-infective condition, and here the sectioning the chorda tympani has an impact on the test disturbance, and majority of the patient present post-operatively where the chorda is sectioned or stretched, not even sectioned, stretched, can present like this. So this overhang removal, this can be done like being done with a curate. It can be done with a micro drill very precisely. It can be done with a micro, gauze and a mallet. Our friend Dr. Ashish Bhumkar, Ashish Desai, they do many times very, very precisely with a micro mallet and the gauze and remove this required portion in one piece many a time. It comes out so nicely and it is very fast and very, very safe. So you can do the way you are used to, the way you are equipped, whatever. The goal is to remove the overhang for the complete exposure of the oval window from all around, preservation of the chorda tympani, and then move forward. See, this exposure is the key to the results. If the exposure is not good, the results are not likely to be. Nowadays, the endoscopic ear surgeons have, pitched in with the advantage of, endoscope in this regard, which requires, a good wide angle view. And they claim that this overhang removal is less required when you come with the endoscope. So endoscopic surgery has advantages at different level, but still it has not replaced microsurgery because that is binocular vision, not like endoscope. Yes, endoscope has advantage, give good picture, good panoramic view, require less curettage. The temperature is a big issue because at the with the endoscope being in the canal with temperature rise can be an issue. Uniocular view with no depth perception at the level of the foot plate is another view which has still made this microsurgery as still the gold standard for the stapes surgery. See now, more and more curettage being done for more and more exposure of the oval window. You can see now the oval window exposure much better. Now see the entire oval window in view. Entire oval window in view. This is promontory here. This is the fallopian canal above. Entire anterior to posterior the oval window in view. This is the stapedius tendon, and this is the pyramid from where the stapedial tendon is emerging, and the entire oval window in view. This is the key for a good surgery to have a good exposure. Exposure is completed when you can see all the structures around the oval window, the fallopian canal, the pyramid behind, and you have ample of space to maneuver your piston and your instrument. That is why the exposure is required. There is no single definition for a good exposure, and that you have to, decide according to your clinical judgment, your experience, that how much exposure is required for the individual case. Yes, by and large, you need to have ample of space to maneuver your piston and instrument into the oval window. You should have a complete view of the oval window to define your pathology and any other abnormality related to the oval window, like facial nerve and all that. So that's how the exposure is very, very important. Carry out this exposure by your own judgment, by means of the micro drill, by means of curate, by means of gauze and mallet, whatever. But the exposure is the key. That is most important. Dr. Shrafuddin, any comment you do differently? This any kind of exposure, or anything from the audience?
Exposure. I can say exposure for stapes surgery.
Yes.
Because most of the failures when we see, often we see it is inadequate exposure is one of the main reasons for the poor crimping, poor measurement to manipulate your instruments. Everything will be difficult if there is no adequate exposure. The only thing is that you should not expose too much, like you should not expose the body of the ingus, you should not expose so posteriorly so that there is a chance for retraction. But the adequate curating and the adequate exposure is mandatory for the stapes surgery, correct? No difference of opinion. You should see the facial canal, you should see the pyramid, and you should see the entire foot plate.
So this is very important. See now with little magnified view, the
Yeah,
complete view of the foot plate. Can you see?
Yeah, complete.
Yeah. Now, see this surgery, as I mentioned, is a surgery of diligence. Now you have to deal with a structure, stapes, which has a weight of on average 2.8 milligram. There are a lot of variations in the anatomy of the whole window and the stapes. And then fine movements are required at this level, and the clinical judgment is required in different, abnormalities at this level. So this part completes the exposure. Now, next is to check the ossicular chain mobility, to check the fixation of the foot plate, to check any other fixation of any other lateral ossicle, like the fixation of the incus, fixation of the malleus, need to be thoroughly checked at this point of time. If as I said on the CT scan, if your malleus is fixed in the atic, if your malleus is fixed because of the anterior ligament fixation, if your incus is fixed because of some other reason, or bony fixation or tympanoid sclerosis, that need to be checked here whether the ossicular chain is fully mobile or not, or whether the foot plate is truly fixed or not. These are the two important decisions before proceeding further are required at this point of time. This is very, very important. So the checking the ossicular chain, entire ossicular chain, is very, very important to establish the diagnosis of otosclerosis. Now this will be the key in establishment of the diagnosis. All clinical findings were in favor of otosclerosis, not the diagnosis, complete diagnosis. Now, after checking the mobility, will be the complete diagnosis of this situation here. And here now you need to assess a lot of things. The anatomy of the oval window and around, the anatomy of the foot plate also is very, very important. How the foot plate looks like, how the otosclerotic foci looks like. I can see the glimpse of the otosclerotic foci here, just anterior to the foot plate. If you see carefully, in this angle between the incus and the malleus, you will find the glimpse of the otosclerotic foci at the fistula antefenestrum, just anterior to the oval window, inferior to the processus cochleariformis. That shiny is the otosclerotic foci. You can easily observe microscopically at this point of time. You can see your chorda tympani running intact with some mucosa over it. You make sure it remains, it remains humidified. It remains, it should not get dry at this point of time to give any symptoms later on. So it should not allowed to be dried up. You can use some wet gel foam or wet something, gauze or some cotton gauze or something to keep your chorda moist all the time. Otherwise, it can lead to dried up chorda tympani, giving symptoms. And there's another, technique our friend Ashish Bhumkar has proposed, to keep this chorda along with the flap pushed anteriorly, to keep it connected with the flap, to keep it moist. This is another strategy to protect as well as keeping it moist. So chorda is important here. And now next is
often we need more stretching for that to keep it along with the flap. Sometimes we may need more stretching of the chorda. Sometimes, in some cases, to stretch it along with the flap and keep it and protect along with the flap. Sometimes we need more stretching of the chorda.
Yes. See now, boss. Yes, your point is right. Stretching. I'll come to it. See now, checking the mobility of the foot plate.
Yeah.
Let me show you again. This is very important. See now, push your angle needle underneath the malleus and lift it. To see the mobility of the malleus, let me show you again. See again.
Yes.
This is very, very important to check at both ends. First, the mobility of the malleus and the incus. See now, you should push your needle underneath the malleus, angle needle, and lift it to check the freely mobile malleus at this point of time. See the needle. This is coming again, the checking the mobility of the ossicular chain.
So that is the most important step to diagnose otosclerosis.
Yes.
Whatever our audiological, radiological, CBCT, CT, HRCT, whatever is there, the real diagnosis comes these tests.
Yes.
Yeah.
See this.
Yeah.
Angle needle, check the mobility of the malleus. See the incus mobile.
Yeah.
Can you see very clear?
Yeah, it's very clear.
So lift it up to confirm the mobility of the malleus and incus, and it is a pure clinical judgment on experience whether the mobility is restricted or not.
Or not, yeah.
So if on slightest doubt, on slightest suspicion, we have to do a lot of maneuvers.
Yes.
Now about checking the mobility of the stapes. For that, under vision, you can check the mobility of the, stapes itself, and checking the, by mobilizing the crura, you can check if the footplate is mobile or not. See this?
Yes, yes.
Fix. So this is one step, very, very important and crucial, and how to do it. To rule out lateral ossicle fixation, to confirm the stapedial footplate fixation. These two steps are very, very important in any surgery. Now the next step is disarticulating the incudostapedial joint. This is very, very important. Now, the steps are straightforward, we all know. The next step, you can see by mobilizing the malleus anteroposterior, you can get to know where exactly the joint is. Could you see that?
Yes, yes.
Let me repeat. That's a very, very important step.
Because the joint capsule is little inferior than we usually expect.
See now the incus is being mobilized anteroposteriorly. See this anteroposteriorly to look at the incudostapedial joint level.
Yes, yes, yes.
And then go to the joint level rather than severing the lenticular process. Could you get? This is very, very important.
Yeah.
If you don't see the incudostapedial joint level clearly, you can end up damaging the lenticular process.
Bleeding.
So the incudostapedial joint is, separated. Now the steps are very clear. The next step would be in a regular fashion would be to cut the tendon, to make the fenestra, cause your piston size, make the fenestra, and put your fistula. Oh, sorry, cut the tendon, remove the suprastructure, check your required piston size, make the fenestra and put your piston. These are the simple points to steps of the surgery for completing this surgery. Now, this step can be carried out by various means. This can be carried out by your mechanical instrument, or this can be carried out the way what I am showing here, which I have been doing for almost now 15 years, is by means of using this luminous laser for certain advantages. I'll enumerate why. Why so this laser is required for this surgery at this point of time. Not this point of time. This vaporizing the tendon is not a critical step. You can cut with your scissors simply without giving any complication. But here, just to show laser that the laser, alignment is good, the power is adequate, and you can vaporize in 1 or 2 goes this tendon completely. So now the next 2 steps in the stapes surgery are critical. The step of crurotomy and step of fenestrations are very, very important steps to prevent complications, because these are the 2 critical steps wherein an unwanted mechanical stress over mechanical movement can lead to sensorineural hearing loss. For example, see, this is a laser beam, yeah, through the micromanipulator. What I'm using is a CO2 laser through the micromanipulator. This is the aiming beam, and you have to, match the focal length of the laser with the focal length of the microscope. Match this and then vaporize. You don't want this aiming beam to go anywhere around to the critical structures like facial nerve or any other thing. This laser energy is absorbed by the structure where you are using. This laser has the advantage of being absorbed by the tissue as well as water content. This laser is absorbed by the water, being the biggest advantage of this laser for the stapes surgery. This is the number one laser for the stapes for this region, unlike other we'll discuss. So here the laser being focused, and now the tendon being vaporized at a lesser, energy. This is not a bone. It can be vaporized with much lesser energy. What we use on the luminance is 6 to 8 watts for the tendon to be vaporized with a aiming beam with a see this, the tendon vaporized easily.
Yes.
So now the critical step comes. That is chorotomy and fenestration. What can happen with the chorotomy with the mechanical instrument? What we want the crura to be out. Fracturing the crura is a gentle process. Go at the neck of the stapes and fracture gently towards the promontory. But what happens if this movement is not befitting? If the pressure is more than required, if the stapes is not completely fixed, it can result in mobilization of the foot plate. It can bring even the foot plate out. It can fracture the foot plate, and that is all disaster, because any such thing happens will bring in some sort of sensorineural hearing loss. How lucky you are. But sudden jerk of movement transmitted to the inner ear will definitely bring in some sort of sensorineural hearing loss. If you are lucky enough, resulting in a mild one, but it can even lead to a profound one with this sudden movement. So you have to be very, very careful at this moment. And here comes the role of the laser for which we bought, which we propagate. This is a pure, step where no mechanical movement is transmitted. And why laser is important here? Because out of the two cruras, the posterior crus is a stout one. Posterior crus is a stout one, which can result in all these complications. Fracturing the anterior crus is much easier. It is much fragile. You can easily break it without mobilizing the foot plate most of the time. Though in rare condition, it can be a thick anterior crus. That is a disaster if you don't know. So, but most of the time, it is the posterior crus which is responsible. So what we do now, see this laser beam again with little more wattage than the tendon, and we will vaporize the posterior crus at the lower end and thin out, vaporize it, fracture it, and bring it out after fracturing the anterior crus to make this step much safer. The overall goal is to do a safe stepedotomy, and this step is crucial, critical in terms of giving mobilization of the foot plate if you are not careful. Now see another safety. What we have kept is a gel form there. Can you see?
Yes.
Over the foot plate and over the facial nerve inferior margin.
Yes.
Because this laser energy can, or the beam, if it is misdirected, can lead to problems. We don't want this beam to be directed anywhere than the posterior crus. See, the posterior crus is being vaporized with a laser beam without firing here and there. The entire oval window and the facial nerve inferior surface is being covered with a wet gel form. In case even the beam misdirects, the energy will be absorbed by the wet gel form. Now see the perforation in the crura.
Yes.
Crura is being made, thin, perforated, vaporized, and one can easily, it looks like this crura is gone. We'll check and separate it easily now with the angled prick. angle pick. So this is how weakening, vaporizing, whatever you say, to the posterior crus. This is important step in preventing the mobilization of the foot plate at this crucial step. This can be achieved best by this CO2 laser, this luminous laser. Though there are various lasers one can use at this step as well. A lot of people using other visible lasers like KTP and other will discuss their advantage and disadvantage. But this is the biggest one with the CO2, as it is absorbed best by the bone as well as the fluid, and it remains safe as it is not transmitted beyond this. And this fluid works as a, I would say, the shock absorber for this laser, even if it penetrates a little bit in the vestibule. So at this step, the posterior crura is vaporized. This is very, very important. You can, if you don't have a laser, you can use your micro drill to thin out the posterior crust at this step. Got my point?
Yes, yes.
So see, the rest of the crura is being further vaporized. You can use your micro drill, but micro drill may transmit vibration. It cannot be as safe as laser. It cannot substitute laser, but yes, there's another alternative. You can thin out. Sometimes this crust is so thick to completely obliterate the view of the foot plate, and then you have to thin out to carry out your further step. And in the recent, workshop we did at a tribute to Dr. ABR Desai in Mumbai last month, our dear friend Dr. Ashish Bhumkar demonstrated that step so beautifully, thinning the posterior crust with the micro drill and improving the visualization of foot plate thoroughly, even without the laser, and that worked very well. So that posterior crust thinning, and what we believe, once you have a CO2 laser, this is like a, I would say, the tool at this step to vaporize the posterior crust completely. And see now, the foot plate is coming out. After the fracturing the anterior crust, which is fragile, the foot plate is coming out. And see, no mechanical energy is transmitted to the vestibule, to the foot plate at this particular step. That is what we want to achieve. Could you see?
Yes, yes.
Vaporize the posterior crust, fracture the thin anterior crust, and bring it out without mobilizing the foot plate, without transmitting any energy to the foot plate to get dismantled. That is the goal of, that's the beauty of the laser which we propagate. Number one. Now the next step, critical step after this, next critical step is the
Fenestration.
fenestration. Fenestration is such an important step. Again, if you are using the mechanical energy, maybe your micro drill, maybe your perforator, and if the pressure or movement or whatever energy you are using on it, it is more than required, can result in, again, into a floating foot plate, can fracture the foot plate, can even submerge the foot plate into the vestibule if it is too much the pressure is. If the foot plate is not adequately fixed around, many a times, because this foci starts anteriorly, anterior to the foot plate, the otosclerotic foci, and then the annular ligament is involved all around. Mostly, sometimes the annular ligament is not involved, and because of the foci, this foot plate is pushed posteriorly towards the posterior stapedial joint, fixing it. That is not a true fixation of the foot plate. And in case the mechanical movement is used in those situations, it can make it easily a floater. So in any given situation, this step is very, very important, and we are not supposed to use too much of pressure. This laser, by means of a dramatic way, by means of not using any mechanical instrument, can make the fenestra very, very precise of the required size. You can choose the size required on the laser parameters on the machine. You want a 0.4 mm, you want a 0.5 mm, 0.6, 0.8 mm, whatever size fenestra. Laser energy required you can use. By a lot of studies, it has been proven that a single shot of 20 watts is good enough to coagulate the foot plate, to perforate the foot plate. and not much energy transmitted with that particular wattage 20 watt to the vestibule further. If slight energy is transmitted to the vestibule inside, it is absorbed by the perilymph, the intact perilymph, which is, filling the labyrinth completely and protects from damaging the membranous labyrinth. So this is the idea behind using the CO2 laser at this step. This is very, very important to use the laser precisely. And in our series of thousands of step-piece surgery, this has proven to be very, very safe. You have to be very precise using the laser parameters. Now, there are a lot of, important questions arise here. Where to make fenestra, the piston length required, the fenestra size, all are important in, bringing in the good outcomes. So, quickly, number one by one, where to make the fenestra. The reason being, when you put the piston inside, your piston moves freely inside the vestibule. It can go in and out into the vestibule in extreme pressure situation, even up to 0.5 millimeter. In a normal situation, there is annular ligament around the step-piece foot plate. In a normal annular ligament movement, it doesn't move more than, 25 to 30 nanometers. Now, you're bringing a piston inside the vestibule that moves, there is no annular ligament, and it moves freely up to 0.5 millimeter in and out. Just a minute. The piston moves in and out freely and up to 0.5 millimeter, and that can be a disaster if it hits the membranous labyrinthine structure. So, in those situations, when you put a piston, it should be away from the membranous labyrinthine structures. And now see the laser beam directed towards the foot plate.
Yes, yes.
So the best spot for the laser fenestra or any fenestration in the foot plate should be central part inferiorly, because that is been proven to be farthest from the membranous, underlying membranous labyrinthine structures. Utricule is superiorly placed, saccule is anteriorly placed, saccule is anteriorly close to the surface of the foot plate relatively, but in the center it is away, and that is the safest place for any fenestra to be made, in the central part of the foot plate inferiorly. And that is the area where the fenestration should be done to stay on the safer side, as the movement of the piston can be up to 0.5 millimeter in and out into the vestibule. You keep a piston for a fraction of millimeter inside the foot plate, like 0.3, 0.4 mm inside, and further 0.5 millimeter can be a disaster if it hits the membranous labyrinthine vestibule. So this is important to make a fenestra inferiorly in the central part. Number two, the size of the fenestra has an bearing, as the movement of the perilymph, mobilize, has an impact on the hearing outcomes. It has been proven a fenestra size around 0.5 to 0.4 to 0.5 millimeter is adequate for a good hearing outcome. Though 0.6 mm fenestra, 0.8 fenestra are supposed to give a better outcome, but in terms of decibel, the difference is very less, and 0.4, 0.5 mm is adequate. Lesser the size of the fenestra, better are the hearing outcomes in the higher frequencies. Bigger the fenestra, or a partial stepidotomy or total platinectomy, will have an impact, negative impact on the higher frequencies. That is the something we need to understand. And for in the present era, in the modern step era, the safest stepidotomy, that's why the step-piece surgery is the stepidotomy with a small fenestra, which has a good, impact on the preservation on the inner ear function, particularly at the higher frequencies. So we do mostly 0.5 mm fenestra using a 0.4 mm piston inside. So the size of fenestra has a bearing to preserve the higher frequencies. If you make the fenestra smaller than 0.4 millimeter, may find inadequate in terms of hearing gain. So it should be see the fenestra single shot. Could you see?
Yes, yes, very much. Yeah.
Single shot fenestra. Let me show you again. Single shot fenestra at the central inferior part of the foot plate. With this laser, the fenestra size is 0.5 millimeter. You can see the laser beam, the size of the laser beam. Again, I'm rewinding it to show you again the size and the location and how to carry out the fenestra with the laser. This is single shot, small fenestra, and carrying out safely without any mechanical instrument onto the foot plate, and that we consider to be the, see now, see this?
Yes, yes.
What a discrete fenestra. Can you see the entire vestibule full of perilymph?
Yeah.
See the perilymph. That is most important, to have the vestibule full of perilymph. If the perilymph is, burn out, if the perilymph is absorbed, if the perilymph is, completely soaked by the laser, it has a negative impact. So
And this is
vestibule
definitely
should always be
yeah.
full of perilymph. Yes, sir?
Definitely better than the small rosette and making it to a single, again, more laser onto the foot plate. The rosette then making
Yes.
the communicating everything to one, as Dr. Robert Vincent does, and then he uses these drill onto it. So, but this is very single shot, just
Yes.
yeah, minimum exposure of the laser to the inner ear.
Yes,
Great.
minimal exposure. You can see the vestibule full of perilymph. So what happens, a lot of studies done, sir, in this regard, that does it have an impact on raising the temperature of the vestibule fluid, and can have an impact on the membranous labyrinthine structures. With this 20-watt shot, single shot with this kind of full of, labyrinth full of perilymph, up to 1.5 to 3 mm rise in temperature can be expected momentarily, which has no effect on the, negative effect on the hearing or on the vestibular end organs. Zero. Up to 7 mm rise in temperature has no effect momentarily. More than that, if happens to occur, can have a effect and result in sensory hearing loss. So that is very important.
Yeah.
Second very important thing here is to keep this labyrinth full of fluid all the time. Avoid sucking the perilymph by your sucker. Suction by the perilymph is a disaster. It will definitely draw the sensory hearing loss.
Even
To whatever
putting gel
extent.
foam. Yeah. Some surgeons put gel foam on the open labyrinth.
Never.
That
It
also
sucks out.
the perilymph. Yeah.
Yeah, so nothing is required to be done to the perilymph at this level. Nothing is required to be done. Leave it completely filling the vestibule. See, there is no gusher, no oozer at all.
Yeah.
Even some blood accumulates. See here,
Yeah.
the blood accumulating in the oval window will have no negative impact.
It will not go to inside. Indeed.
Yes,
if the
it will
perilymph is
never
there.
seep into the vestibule unless it is dry.
Yeah, unless it is dry.
If the vestibule is full of perilymph, there is always, the intravestibular pressure is more
See,
higher
the
than
blood
the
won't go
pressure in the
inside.
middle ear. It will never allow the blood to go inside, and you are 100% safe. See, you suck the blood around, the vestibule is full of pure perilymph. Otherwise, in a dry vestibule, if the blood seeps in, is a disaster.
Yes.
The blood hemosiderin has a negative impact and is a toxic to the membranous labyrinthine structure, and such particles will have a bearing on the vestibular system as well, not only in the hearing as well as the vestibular system.
What
So,
about, do you use the autolace, the fiber CO2 with the acupuncture?
yes, we can sometimes in difficult situation. That's a fiber laser, not aiming beam.
It's more
So
handy,
you
and
can
you
precisely,
can
can do precisely at the
vaporize
end organ
even the
level.
anterior crest.
Yes.
Yeah.
So anterior crest is normally hidden with the aiming beam, as the incus comes in
Hello.
between.
Yeah. So if the micro manipulator is there, no, it is hidden.
Yes.
But if the handheld probe is there, is
So
it better?
that is a boom in situation of thick anterior crust.
Yeah.
If you have a thick anterior crust, you can't fracture it so easily. It can mobilize. It can be a disaster. So even your micro drill is difficult to reach there. And then the fiber laser is the key. That is one of the best use of the fiber laser to vaporize the anterior crust in those situations. So here, the size of the fenestra, the location of the fenestra, and the length of the piston, all three are important. How you make it atraumatically with a laser rather than a mechanical instrument. Everything is important. What's my point?
Yeah.
Now,
Especially the site of the fenestra, we are all learned it is the posterior 1/3. That is the ideal site for the fenestration. And this has to be more propaganda has to be given for the inferior central 2/3, because the Yugo fish temple bone studies and even the vertical assembly all indicates that this is the correct site. But even majority of the ENTs are still going for the posterior 1/3.
It should be central inferior.
Yeah, it should
for
be
reasons
central
as you
2/3.
mentioned about the Yugo fish studies, they did on the temporal bone and draw the distances. That is number one. Secondly, the alignment of the piston with the
vertical assembly.
Yes.
Yeah, correct.
If it is angled piston you put, it can be fixed to the margin of the fenestra at some point of time.
Yes.
And can lead to incus necrosis if the piston is pushing on the margin again and again. So it should be a 90-degree assembly into the fenestra. That is best. So for both the regions, central and inferior part is good.
Yeah.
Regarding choosing the laser is important. As I said, there are variety of lasers introduced right from the argon initially to the KTP and the diode and so many other lasers. All have some other sort of inner ear impact. Like KTP is a visible laser. It is absorbed by the hemoglobin. It is absorbed by the red color. It is a good hemostatic laser, but it is not absorbed by the fluid. So laser energy can traverse through the fluid to damage the membranous labyrinth. So it is never so safe to the membranous labyrinth as compared to the CO2 laser, which is absorbed by the fluid.
No doubt, AccuPulse is the best, but the pricing of the machine.
Yeah, that is something
main limiting factor. Yeah,
that is prohibiting factor, I would say. Correctly, you're right. Secondly, the RBM, ND-YAG, they have their own advantage of producing acoustic wave, pressure waves. They are detrimental to the inner ear comparatively to the CO2 laser. That's why finally CO2 laser to be the best as far as the laser energy is concerned. What I'm showing is measuring the piston size.
Yeah.
You can measure it before fenestra, adding on to the thickness of the foot plate, but by and large, adequate side piston is the requirement for the optimum long-term hearing results. If the piston is over long, it's a disaster. Out of all factors, I would say the single important factor which determines the outcome is the length of the piston.
Yes.
It should not be over long. It will not allow the endosteal membrane to form, can result into perilimb fistula. It can impinge on the membranous labyrinthine structure in pressure situations and can be a disaster. So piston should not be over long. It should project into the vestibule for up to 0.3, 0.4 millimeter distance, not more than that. It should not be too short to have come out of the fenestra in negative pressure situations like sneezing or valsalva or whatever. It should not come out. So that's why our friend Ashim decided as a hanging and bending test to see the piston is of adequate size. So piston size should be adequate, and piston be used for the reasons I'll enumerate is the clip titanium piston, and we have a measuring gauge from the same company. Whenever you measure the piston with any equipment or anything, you should use from the same makers of the piston, same company. Otherwise, the parameters can be different, and we always determine the size of the piston required. The piston gauge was being used to determine the size of the piston required, and then we use the piston. See the beauty of this piston. See the beauty of this piston. Why we are using the clip titanium, I'll come to it. The beauty of the piston is it fulfills the parameters of an ideal piston required. Let me tell you, parameters of ideal piston required, it fulfills all parameters. An ideal piston should be extremely biocompatible. It should match the weight of the stapes. Like for example, earlier gold piston were being used. The gold had a mass, the weight, the piston weight was more than 10 milligram, which has a negative impact on the higher frequencies. So the piston should be biocompatible, matching weight. It should be, easy to use. That is most important. Now the Teflon, I know it's a widespread use piston. It's a good biocompatible. The thing which makes me use the titanium is the need of crimping in Teflon piston, because what we earlier believe in memory is no memory practically works. Adequate crimping is one of the most important factor for the sound coming to the incus to be transmitted to the inner ear without any sound loss, without any sound loss at the level of the incus, which can happen to occur because of the play between the piston and the incus. There should be no play between the piston and the incus. There should be adequate crimping. And that is some factor which has lots of impact otherwise. Let me tell you, if it is too tightly crimped, the crimping process itself, if you try to crimp too tightly, can result into malio-incudal joint dislocation. If you the entire loop of 360 degree you try to tighten, it can affect on the mucosal vessels. The incudal vessels can result into necrosis. If it is too loose, a crimping, the piston may keep on hitting the incus, particularly if it is lost inferiorly or medially at the foot plate level. That movement of the piston can lead to incus necrosis. And it has been found in majority of the revision surgery, the causes are piston related. So you have to be very careful about using an ideal piston of the ideal size. And here titanium scores, it has an edge above the Teflon, that being biocompatible, obviously, you need not to crimp. The clip need not to be crimped, and it holds the incus tightly, that too less than 1/3 of the circumference of the incus, but very firmly to avoid any play between the incus and the piston. On to the last part, that is the piston, and see the beauty of this piston. It has this opening to take on the incus. It has a middle slot. See, this slot only is going to take on the incus tightly, and that is less than 1/3 of the circumference of the entire incus. And this is the bar over here behind to push onto the incus. So that is the beauty of this piston. Let us see how this piston can be used easily. See this? See, this piston is coming. I'm just forwarding a little bit. See now, the fenestra. Now this, putting the piston, I would say, is the simplest of the job. Let me go back. See now how the piston comes and you can easily push in. Sometimes otherwise you may have to struggle a lot with the a Teflon piston to crimp it, to place it, and so on. The problems with the Teflon if you are not very experienced, but this can be this piston can be placed by the most, I would say, less experienced people in a very simplest manner without affecting the outcome. So what you need to do is take the piston straight 180 degree, first place at the fenestra rightly, and then see this, place on the fenestra rightly, and taking this open end of the piston towards the incus. See this, this step is crucial. The upper end is taking on the long process of the incus, lower end at the fenestra, Then I had shown you the bar on the piston. See this bar through which, see this piston is being pushed through the bar and the middle slot is taken up. That's so simple, like a video game. Now, no need of crimping. The connection is so firm, no play between the incus and the piston, and you can see how nicely and easily the piston can be placed. नहीं आएगा सर, पैसे वाले ठीक है, चक्कर की जरूरत तो नहीं है। See now how the piston is placed there. So, any questions before we wind up this first case? We'd love to discuss any questions or queries. This is a huge subject we can discuss day long, but in the given time.
Any questions from the audience?
Pardon? Yes.
Any questions?
Laser and
So,
yes.
Dr. Satish ji, often the Teflon available in India are highly, the quality is variable, very much variable, like the memory and the quality.
Yes.
So what is your opinion on that? Because many of the surgeons don't do the titanium pistons processes.
So, sir, I really use Teflon. It's been almost more than 10 years I've used Teflon, except once or twice for some regions.
Because, yeah, during the COVID, we didn't get all these imported ones. So we again went to the Teflon. But the Teflon, the quality is very, very bad in many of the Indian processes, Indian Teflons.
See,
so the
majority of the revisions, majority of the revisions are due to piston related problems.
Yeah, most of the revisions are due to Teflon. But maybe most of the people are doing Teflon. Also, maybe the one of the reason for that.
That depends how you use the piston as well. The experience matters. You know.
And we used to get the Audio Italy piston. The top is titanium and the bottom is PTFE. That is again Teflon.
Yes.
So you can cut according to the length you require.
Yes. Yes.
So that was also very good pistons from Audio Italy.
Good idea, because these pistons are not supposed to be cut. Though titanium cutter is available, but we are not supposed to cut this to.
Suppose you have to keep 4.25, 4.5, 4.75.
All
the things you have to keep
available at 0.25 graduations. 0.25 mm graduation.
Very easy to introduce the clip piston, and also it won't impair the real blood supply through the ingus, the anteroinferior part.
Yes.
Unlike the Teflon, which crimps almost the entire
tightly encircle it.
Yeah.
If you try to engulf the entire incus with a piston, it can result into that. So
and most of the time, when we revise, especially in females after 40, 50, they did the surgery around 30. Then we have seen the ingus is little small in size. The diameter is less and it is not very round because of the osteoporotic changes. The ingus gets narrowed. Then there is a space happens between the ingus and the Teflon processes. Then it's gone rubbing, causing either the piston gets fallen off into the middle ear or ingus necrosis. That is also,
Yes, so revision surgery is an art, and when we have done a couple of revision surgeries, and mostly it is related to the piston related
piston
which results into incus necrosis.
Yeah.
Piston came out of the fenestra.
Yeah.
Piston too deep into the fenestra for many reasons related to the piston.
Yes, correct.
So piston size and the piston and how to apply it all are very important. If you are using Teflon, the ideal adequate crimping is important.
Yes.
In our workshop, Dr. Ashin Desai has shown a couple of times the way he crimps with two hands to completely crimp around, adequately around the piston is very, very important. Because otherwise it may result into, suboptimal outcomes.
Okay. So,
You can use your corda over the piston to stabilize it further.
yeah.
We don't use anything at the lower end to, seal. Nowadays, we use a micro drop of blood to seal over it, which is a fibrin, and it works very well. If your piston size is adequate, you don't need to do anything. That's the single most important outcome. Vector.
Great start, Satish ji. Great start. We'll have a 15 minutes break for our official function. After that, we'll have a tympanoplasty. What do you want?
Yes.
After 15 minutes, we'll have a tympanoplasty, right?
Yes.
What do you want?
Yeah, anything you say.
Yeah.
Tympanoplasty is fine.
Tympanoplasty will be
common thing.
Tympanoplasty will be fine, right? Yeah.
Okay.
Everyone need a tympanoplasty. You take a 15 minutes break so that we will have a function, and after that we'll join you again.
Okay.
Okay. Thank you.
So thank you. So Satish ji, thank you so much for the wonderful topic, stapes, because it's the most rewarding surgery, but most technically challenging surgery also. Thank you.
Thank you, sir. Thank you all for the patience.
Thank you, sir, for that exhaustive discussion and surgical demonstration. Thank you to the chairpersons, Dr. John Panikkar and Dr. Sharfuddin. We now move on to the next part of this program, which is Remembering MAG, a tribute to an excellent ENT surgeon and a wonderful human being, a friend, guide, and mentor to many. We take you for a walk down memory lane. Good morning to all the delegates and well-wishers who have assembled here for this, the 9th edition of Magenta, an annual academic event held in memory of our departed senior mentor and stalwart of AOI Malappuram chapter, Dr. M.A. Gopalakrishnan. Dr. M.A. Gopalakrishnan, MAG as he was popularly known, was born on the 24th of April 1949 as son of Malanguril Angurni and Kunjama at Panangad in Kochi. He graduated from the Calicut Medical College. He did his DLO from the Government Medical College, Tiruvandhuram, completed his post-graduation MS ENT at the prestigious All India Institute of Medical Sciences, New Delhi, practiced at Government Hospital, Muvatupura, before coming to the District Hospital, Manjeri, then worked at Government Hospital, Manarkad, and later, having changed his plans, left government service to join the Korambayil Hospital at Manjeri. A team leader, friend, philosopher, and guide, Dr. Gopalakrishnan was a valued and respected member of our team who contributed to the AOI in many ways. In addition to his professional achievements, he was always thoughtful towards his colleagues, and everyone enjoyed working with him. He was a great man who brought cutting-edge otology practice 3 decades ago to a little town, Manjeri, in Malabar. With great organizing capabilities and leadership qualities, he was a founder president of the AOI Malappuram chapter, president of the AOI Malabar chapter for the year 1996, and president of AOI Kerala State for the year 2005. He was an active member of the IMA Manjeri branch and the Manjeri Clinical Club which meets every first Wednesday of the month, was his brainchild, which he nurtured till the end of his illustrious career. He was a master in fostering friendship, recognizing each and every guest or delegate at meetings hosted by the AOI Malappuram chapter. He was a brilliant surgeon, and his greatest achievement was not his flourishing practice or his finely tuned surgical skill. It was his enormous influence in bringing together the ENT surgeons from near and far into one cohesive, friendly group. The fondness and friendship that the ENT fraternity shares here is largely due to his overpowering influence. A source of motivation and encouragement to young dynamic colleagues with always a word of advice, and he has been a great influence to very many youngsters then who are leading ENT surgeons and teachers of the present. A keen learner, front bencher always, avid listener, participating in dissection courses vividly, always thrilled to be a student over and over again. Be it any academic forum, you could find Sir right there in front. He was a philanthropist and had a lot of social commitment. A caring doctor to his patients who came from far and near, he made friends with people in all walks of life. He was instrumental in organizing the first ever family meet of the Malappuram chapter members at River Retreat, Shornur in 2007. A trendsetter, later Alleppey, Munnar, Ooty followed. An ENT family trip to Malaysia during his last days was a wish unfulfilled. He kept up with his relations with everybody, played a wonderful host at family meets. He was ever ready to experiment, be it ENT or otherwise. He was always supported by his trusted lieutenants, his wife, Dr. Mali, a dermatologist by profession, and Dr. C. Prabhakaran. A doting husband, a loving father to two doctor daughters. He leaves behind his wife, Dr. Mali, and two daughters, sons-in-law, and grandchildren. His motto in life was hard work and persistent toil for excellence, untiring theatre days which could go on and on. At the end of a long day, he would still be smiling, catering to the sick who would be eagerly waiting at his clinic for consultation. His hard work and sincerity took him to the zenith of popularity and success, but he was always down to earth and humility personified. Simplicity in thought and action were his values. He was such a special soul that no words are adept to describe him. He brought us together, and his simple presence was a great relief and pleasure to everyone who knew him. And sir, you are sadly missed and always in our thoughts. Sir, all of us have treasured memories of your towering personality. As a tribute to this great soul, the members of the AOI Malappuram chapter decided to form a society, the M.A. Gopalakrishnan ENT Academia, read in continuation as Magenta. In the meaning of colors, magenta represents universal love, promoting compassion, gentleness, tolerance, and all these values were in full abundance in the life of our beloved MAG sir. It was decided to have the first Magenta dedication conference at his hometown Manjeri in the year 2014. His mentor and teacher, Professor S.K. Kakar, readily agreed to be the guest speaker. The other speakers were his best well-wishers, Dr. Tulsidas and Dr. Jayakumar Armenan. We were privileged to have his family and colleagues who worked with him in his nearly 3-decade-long career. The second edition of Magenta 2015 was held at MIMS Hospital, Kottakkal. We had organized a temporal bone dissection workshop and live surgery. Dr. Shabir Indorwala, Dr. Subramaniam Iyer, and Dr. Mubarak Khan were the invited faculty. Magenta 2016 was organized at Maulana Hospital, Perindalmanna, and was held on April 23rd and 24th, 2016. The main attraction was live surgery workshop on endoscopic thyroidectomy performed by the world-famous international guest faculty from Vietnam. Dr. Jaykumar R. Menon conducted a hands-on laryngeal dissection workshop on goat larynx. Magenta 2017 was held at Rose Lounge, Malappuram. Dr. Satish Jain and Dr. Virendra Gaisas, sinus and skull-based surgery and facial plastic surgery. Fresh frozen cadaver dissection workshop, first time in India. Magenta 2018 held at Perindalmanna at Ascent Hospital. Live surgical workshop. Faculty were Dr. Janaki Ram from Trichy and Dr. Nishit Shah from Mumbai. Magenta 2019, where Dr. Srinivas from Bangalore, Dr. M.V. Francis from Chertala, Dr. Debashish Chowdhury from Delhi were the faculty. 2020, unfortunately, due to the COVID pandemic, this was held totally online. Dr. Sanjay Vaid and Dr. Neelam Vaid from Pune, Dr. Manoj MP from Calicut, Dr. Sandhya from AIIMS Kochi, Dr. Arun Patatail from Calcutta were the faculty. Magenta 2021 was held at Malappuram. Dr. Amit Kishore from New Delhi, Dr. Meredith from Miami, USA, Dr. MP Manoj from Calicut, Dr. Shijit Malik from New Delhi, Mr. P. Shashidharan from Messiah, Calicut, Mr. Ranjit from Murph, Chennai, Mr. Saji Marathurkara from Sydney, Australia were the faculty. 2021, we awarded the first Magenta Award for the best outgoing PG student in ENT from Kerala. The Magenta Award includes a gold medal with certificate and a cash award of rupees 1 lakh, sponsored by Dr. Mali Gopalakrishnan, wife of Dr. M.A. Gopalakrishnan. We salute you, sir. We thank you for the wonderful experiences you have shared with us, and thanks for being the guiding light. We dedicate this 9th edition of Magenta 2022 in your loving memory. Your life was a blessing, your memory a treasure. You are loved beyond words and missed beyond measure. On behalf of AOI Malappuram chapter, we thank one and all of you who have come here and graced us with your presence. And I am sure we, the members of the Malappuram chapter, both young and old, will stand up to a measure of the grace of Dr. M.A. Gopalakrishnan. Thank you, one and all. Before we proceed with the function, let us observe 1 minute silence in memory of Dr. Archana Sharma, the gynecologist from Rajasthan, who ended her life under tragic circumstances. Thank you. We now proceed with the function. May I invite the following people to the dais. Dr. C. Prabhakaran, State President, AOI Kerala and President, Magenta Society. Dr. Sahir N. Abdullah, Immediate Past President, AOI Kerala. Dr. K. A. CD, Past State President, AOI Kerala. Dr. P. Shajid, State Secretary, AOI Kerala and Secretary, Magenta Society. Dr. Hema Shashidharan, President, AOI Malappuram Chapter. Dr. Mansoor Kurikal, Organizing Chairman, Magenta 2022. Dr. Mohammed Sharif, Organizing Secretary, Magenta 2022. I request the dignitaries to light the lamp. Thank you, everyone. We now proceed with the presentation of the Magenta Award 2022. I hand over the proceedings to Dr. Shajid, the Secretary of the Magenta Society.
Thank you all. We all know that from last year onwards, we installed Magenta Award for Best Outgoing PG Student in Kerala State. Award includes gold medal, certificate, and 1 lakh cash award, completely sponsored by Dr. Mali Gopalakrishnan, wife of Gopalan sir. So last year, Dr. Nikila Rajendram from Government Medical College, Trivandrum, won the prize with for 1 lakh cash prize. This year, there was 10 students attended that exam. Actually, we had a detailed evaluation. We collect all their marks, presentations, publications, and thesis. We evaluate it then 40 marks. After that, we conduct a OSK exam at MES Medical College, Perindalmanna. We are extremely thankful to Dr. Girish and Dr. Bashir and their team for conducting the exam. After evaluating that exam, I am proud to announce the results and give away the certificate. Actually, Dr. Divya from RCC conducted the examination disclosure. Okay. So second runner-up this time is Dr. Anne Maria Polson from Amrita Vidyapith.
I request Dr. KACD to please present the award.
I request Dr. KACD to give away the award. Please come.
Congratulations, Dr. Anne Maria.
First runner-up is Dr. Anju M.R., Sri Gokulam Medical College and Research Center, Trivandrum.
I
request Dr. Sahir Abdullah to give away the prize.
Congratulations, Dr. Anju.
And must awaited first prize goes to Dr. Sri Lashmi Balakrishnan from Dr. Serval Memorial CSI Medical College, Karakonam. She has got 2 international paper as a first author. We are proud to have to present this award to her. I request Dr. C. Prabhakaran to present the award.
Congratulations, Dr. Sri Lakshmi. Thank you, Dr. Shajid. I now request Dr. Hema Shashidharan to speak a few words of her association with Dr. MAG.
ബഹുമാന്യരായ സീനിയേഴ്സ്, ലീഡേഴ്സ്, കൊളീഗ്സ് ആൻഡ് ഫ്രണ്ട്സ്, MAG എന്ന എല്ലാവരും സ്നേഹത്തോടെ വിളിക്കുന്ന നമ്മുടെ ഗോപാലകൃഷ്ണൻ സാർ നമ്മെ വിട്ടുപിരിഞ്ഞിട്ട് 9 വർഷം തികയുകയാണ്. സാറിനെ കുറിച്ച് കുറെ നല്ല ഓർമ്മകൾ ഇവിടെ ഇരിക്കുന്ന പലർക്കും ഉണ്ടാകും. എൻ്റെ ചില നല്ല ഓർമ്മകൾ ഞാൻ നിങ്ങളുമായി പങ്കുവയ്ക്കുകയാണ്. ഞാൻ സാറിനെ പരിചയപ്പെടുന്നത് 1990 ഹൗസ് സർജറി കഴിഞ്ഞ ഉടൻ മഞ്ചേരി KMH ഹോസ്പിറ്റലിൽ ജൂനിയർ ഡോക്ടറായി ജോയിൻ ചെയ്തപ്പോഴാണ്. എൻ്റെ ഹസ്ബൻഡ് ഡോക്ടർ ശശി സാറിൻ്റെ കൂടെ മഞ്ചേരി മെഡിക്കൽ കോളേജിൽ മഞ്ചേരി ഡിസ്ട്രിക്ട് ഹോസ്പിറ്റലിൽ ഹൗസ് സർജൻസി ചെയ്തിരുന്നു. ആ കെയർ ഓഫിലാണ് ഞാൻ സാറിനെ ആദ്യമായി പരിചയപ്പെടുന്നത്. സാറിനെ ആദ്യം പരിചയപ്പെട്ടപ്പോൾ തന്നെ വളരെയധികം സ്നേഹത്തോടെയും വാത്സല്യത്തോടെയും കരുതലോടെയുമാണ് സാറ് പരിചയപ്പെട്ടത്. ആ സ്നേഹവും വാത്സല്യവും കരുതലും എല്ലാം പിന്നീടുള്ള സമയങ്ങളിലും സാർ വളരെ കാര്യമായി തന്നെ പുലർത്തിയിരുന്നു. ഏത് തിരക്കിൽ കണ്ടാലും വിശേഷങ്ങൾ അന്വേഷിക്കുകയും കുടുംബകാര്യങ്ങൾ അന്വേഷിക്കുകയും ശശി എന്ത് ചെയ്യുന്നു എന്ന് ചോദിക്കാനും സാർ ഒരിക്കലും മറന്നിരുന്നില്ല. KMHലെ ചില കാര്യങ്ങൾ ഓർക്കുകയാണെങ്കിൽ, KMHലെ കാഷ്വാലിറ്റിയുടെ വലതുവശത്തായിട്ടുള്ള റൂമിലായിരുന്നു സാറിന്റെ OPD. ഒരു ഗവൺമെന്റ് ഹോസ്പിറ്റലിലെ OPD അനുസ്മരിക്കുന്ന വിധത്തിലുള്ള തിരക്കായിരുന്നു സാറിന്റെ OPയിൽ എന്നും. എന്നാലും ആദ്യം മുതൽ അവസാനം വരെയുള്ള പേഷ്യൻസിനെ സുസ്മേരവദനായി ചെറിയ തമാശകളൊക്കെ പറഞ്ഞ് സാറ് കാണുമായിരുന്നു. ഹൗസ് സർജൻസി കഴിഞ്ഞ ഉടനെയുള്ള എന്തുസ്യാസത്തിൽ ഞാനും ഇടയ്ക്കൊക്കെ സാറിന്റെ OPDയിൽ ഫ്രീ ആയിരിക്കുന്ന സമയത്ത് പോയിരിക്കാറുണ്ട്. സാർ ഓരോ കുഞ്ഞു കാര്യങ്ങൾ പോലും നമുക്ക് പറഞ്ഞു തരുമായിരുന്നു. വളരെ നല്ലൊരു ടീച്ചറായിരുന്നു സാർ. സാറിന്റെ അന്നൊക്കെ സാറിന്റെ സർജറി ലിസ്റ്റ് രാവിലെ മുതൽ രാത്രി വരെ നീളുന്നതായിരുന്നു. അങ്ങനെ തിരക്കുള്ള ദിവസങ്ങളിൽ സാറ് OTയിൽ എല്ലാവർക്കും മസാല ദോശ വാങ്ങി കൊടുക്കുമായിരുന്നു. അത് കേട്ടറിഞ്ഞ ഒരു ദിവസം ഞാനും മസാല ദോശ കഴിക്കാനായി സാറിന്റെ OTയിൽ ചെന്നു. അത് കഴിഞ്ഞാൽ മസാല ദോശ വാങ്ങുന്ന ദിവസങ്ങളിലൊക്കെ സാർ അവിടെ OT ഇൻചാർജ് സിസ്റ്ററോട് പറയായിരുന്നു ഹേമയും കൂടി വിളിക്കുമെന്ന്. അതൊക്കെ വളരെയധികം സന്തോഷം തരുന്ന ഒരു സാറിനെ പോലെ ഒരു ബിസി പ്രാക്ടീഷണർ നമ്മളെ ഓർത്ത് വിളിക്കുന്നു എന്നുള്ളത്, ആ കൺസേൺ അന്ന് വളരെയധികം സന്തോഷമായിരുന്നു. KMHലെ എല്ലാ സ്റ്റാഫിനും സാറിനെ വളരെയധികം കാര്യമായിരുന്നു. സാറിനോട് വളരെയധികം ബഹുമാനമായിരുന്നു. പിന്നെ ഇപ്പോൾ സാറ് വളരെ ഒരു എക്സലന്റ് സർജൻ ആയിരുന്നു. അന്ന് തന്നെ സാർ ഒരുവിധം എല്ലാ സർജറികളും ചെയ്യുന്നുണ്ടായിരുന്നു. മെഡിക്കൽ കോളേജിൽ കാണുന്നത് കൂടുതൽ സർജറികൾ എനിക്ക് തോന്നുന്നു സാറിൻ്റെ അടുത്തു നിന്നാണ് ഞാൻ കണ്ടിട്ടുണ്ടാവുക. സാറിൻ്റെ ഫോളോ അപ്പ് കേസസ് ഇപ്പോഴും മാസത്തിൽ ഒരു 2-3 കേസസ് ഇയർ സർജറീസ് ഞാൻ കാണാറുണ്ട്. ഒരു വളരെ വെരി എക്സലൻറ്റ് MRM ക്യാവിറ്റീസ്, മിയാറ്റോപ്ലാസ്റ്റീസ് ആൻഡ് വെൽ ടേക്കൺ ഗ്രാഫ്റ്റ്. വളരെ സന്തോഷമാണ് സർജറികൾ കാണുന്നത്. അങ്ങനെയുള്ള പേഷ്യൻസിനോട് ഞാൻ സാറിനെ പറ്റി വളരെയധികം വാചാലയാകാറുണ്ട്. അസോസിയേഷൻ മാറ്റേഴ്സിലും മീറ്റിംഗ്സിലും ആണെങ്കിലും നിങ്ങൾക്ക് എല്ലാവർക്കുമുള്ള അതുപോലെ നല്ല നല്ല അനുഭവങ്ങളാണ് എനിക്കും ഉണ്ടായിട്ടുള്ളത്. നമ്മുടെ എല്ലാ മീറ്റിങ്ങുകളിലും നിറസാന്നിധ്യമായി പ്രഭാകരൻ സാറിനോടൊപ്പം മുൻനിര പങ്കിടുന്ന ഗോപാലകൃഷ്ണൻ സാറിനെ നമുക്കെല്ലാവർക്കും ഓരോ മീറ്റിങ്ങിലും വളരെയധികം മിസ് ചെയ്യാറുണ്ട്. സാറിന് പറഞ്ഞതിലൂടെ നമുക്ക് ഒരു നല്ല ക്ലിനിഷ്യൻ, ഒരു നല്ല സർജൻ, ഒരു വളരെ സ്നേഹമുള്ള ഒരു സുഹൃത്ത്, ഒരു ഗുരുസ്ഥാനീയൻ, ഒരു നല്ല മനുഷ്യസ്നേഹി, അങ്ങനെ എല്ലാവരെയും അങ്ങനെ ആളെയാണ് നമുക്ക് നഷ്ടമായിരിക്കുന്നത്. സാറിനെ പറ്റി ഓർക്കുമ്പോൾ ഒരു വളരെ വിങ്ങലോടുകൂടി, സാറിന്റെ മരണത്തെ പറ്റി ഓർക്കുമ്പോൾ ഒരു വളരെ വിങ്ങലോടുകൂടി നഷ്ടബോധമാണ് നമ്മളിൽ ഉണ്ടാകുന്നത്. കുറച്ചു നാളും കൂടി ആ സ്നേഹം നമ്മളോട് കൂടി ഉണ്ടായിരുന്നെങ്കിൽ എന്ന് ആശിച്ചു പോവുകയാണ്. സാറിന്റെ ആത്മാവിന്റെ നിത്യശാന്തിക്കായി പ്രാർത്ഥിച്ചുകൊണ്ട് സാറിന്റെ കുടുംബത്തെ ഓർമ്മിച്ചുകൊണ്ട് ഞാൻ നിർത്തുന്നു. നന്ദി, നമസ്കാരം.
Thank you, Dr. Hema. I now request Dr. Arun Divakar to share a few words with us.
Respected elders and dear friends, I still remember my last meeting with Gopalakrishnan sir. Actually, after his surgery, he had just come back to Manjeri and started practice at home. So one day I called on him at his place. He was in his OPD, a lot of patients waiting outside. And as soon as he saw me, he came out, took me inside. Mali madam also was there. She actually made coffee for us, and we had coffee and biscuits together. I kept on reminding about the patients waiting outside. But certain, you have come all the way from Kannur. We'll spend some time together. And actually, we spent some full 20 minutes together. And that was my last meeting with him. In fact, when I joined the Malabar chapter way back in 1996, I was a very proud member because we had a lot of stalwarts, superstars like Vijayaraghavan sir, Ravindran sir, Gopalakrishnan sir. Actually, they were ideal role models for any youngster growing up. The care, the concern, the affection they showed to all the younger members were far beyond the expression of words. And let me also congratulate the Malappuram chapter for wonderfully organizing Magenta year after year. And seeing the teamwork, the expertise of the Malappuram team, I'm sure that Magenta will grow up even further in the years to come. And moreover, when you are in this room attending Magenta, more than anything else, it just rekindles the memory, one of the most perfect human beings and gentlemen I come across in my life, our beloved Gopalakrishnan sir. Thank you.
Thank you, Dr. Arun Divakar.
Hello, Dr. Meera Gopalakrishnan, daughter of Dr. Gopalakrishnan sir is on the line. Meera, can you speak few words?
Good morning, everyone, dignitaries on and off the dais. I am extremely honored to witness this event as well as to speak a few words here. I fondly remember my father, how dearly he considered the ENT Association. He is somebody who lived his profession. And I'm extremely thankful that the association, ENT Association, carries forward his legacy and his passion. Extremely thankful to each and everyone behind this event. And we, the Gopalakrishnas, would be there for every initiative that you would take at present as well as in future. Thank you so much. We are extremely honored. Thank you.
Thank you, Dr. Meera. We now proceed with the next part of the program, which is surgery by Dr. Satish Jain. May I request the chairpersons, Dr. Arun Divakar and Dr. P.K. Sharfuddin, to please chair the session. Over to the chairpersons.
Hello. Hello.
Ah, sir.
Hello.
Yeah, hello.
Sir.
Satish, we are here again to hear from you.
Thank you.
Yeah, Dr. Arun Divakar is also with me. I will give to Dr. Arun Divakar.
Good morning, sir.
Good morning, sir.
We actually visualized a wonderful presentation on autosclerosis, stapes surgery. We are eagerly waiting for the tympanoplasty.
Okay, sir. Thank you so much once again. So this time for tympanoplasty, we all know tympanoplasty is one of the commonest surgery in otolaryngology practice. Surgery which has very good results, and still we are thriving for better results. For small percentage of failures still going on. From technical point of view, the surgery is evolving. We all know in the past, wherein and so far many techniques have evolved to give good results. Almost all techniques have ultimate results over 90% or so, I would say. So that no technique is bad as far as the surgical techniques are concerned, but still we are thriving for the better results, and this is our proposition to improve the results and what we have observed in our thousands of patients by using this technique. So we call it as a not simple meringoplasty or something, we call it as a middle ear cleft reconstruction. The reason being, a perforation in the tympanic membrane, the repair of the perforation can never always be, I would say, mechanical. We should look at the physiology behind it. So perforation could be end result of a problem or a pathology in the middle ear cleft, or a long-standing perforation can result into pathology in the middle ear cleft. Both ways. So our attempt is towards looking into the middle ear cleft and reconstructing it completely to get better results. And from 90 to 99, it requires, tremendous efforts. And this is our approach towards reaching that. And the most important thing in the, this surgery is to understand the role of eustachian tube. This is very, very important. And our working, our strategy started up after going through the publication of this great man, Jacob Sade, who has done phenomenal work in eustachian tube physiology. In understanding, clarifying, and publishing the eustachian tube, role is something this man has done amazing work, I would say. And what, in simple manner, I would say, what is eustachian tube? We all know middle ear cleft is composed of not only middle ear cavity, but editors, antrum, mastoid hair cells, and the eustachian tube completely to make it as a middle ear cleft. So this eustachian tube has an important function in maintaining the physiology of the middle ear. And how it is depicted by Jacob Sade is like a, lung and trachea, I would say, whereas the middle ear and the mastoid hair cells are depicted as a lung and eustachian tube as a trachea. To deliver the air into the middle ear to optimize the performance of the middle ear is the job of eustachian tube, which intermittently opens and closes. Almost every day, our eustachian tube opens and closes more than 1,000 times. And every time it delivers 2 microliters of air on average. Intermittently, eustachian tube opens and delivers the air in the middle ear cleft. That air is absorbed by the circulation in the middle ear cleft, and that continuous absorption of the air in the middle ear cleft results into negative pressure. The moment negative pressure develops, the eustachian tube reopens and delivers the air, and that's how the physiology goes on. So by and large, by means of over 1,000 times opening in a day of eustachian tube, the overall air delivered in the middle ear in full one day is around 2 ml. This 2 ml of air delivered by the eustachian tube is optimum or required for the physiological function of the middle ear. That is so important. So anything affecting in the middle ear cleft can have an impact on the overall outcome of middle ear function and the middle ear surgery as well. I hope you understand what I'm trying to say. So eustachian tube has an amazing impact on the middle ear function. So what does the eustachian tube do? Eustachian tube serves 2 functions. One is ventilatory function. It ventilates the middle ear by intermittent opening and drives the air in the middle ear to neutralize the negative pressure and makes the pressure equivalent to the atmospheric pressure, where the middle ear functions optimum. And second function is the mucociliary clearance to drive out the secretions from the middle ear down the eustachian tube into the nasopharynx. These are the 2 functions eustachian tube serve. And for any ear surgery to be successful, ideally we need to assess the eustachian tube, which should function optimum. And negative or the malfunction or non-functional eustachian tube has a significant impact on the long-term outcome of all otology surgery. Middle ear surgeries, particularly here we are discussing the tympanoplasty. A success of a tympanoplasty in long run depends upon optimum eustachian tube function. So our proposition is to test the eustachian tube, both the functions of the eustachian tube in every patient before doing surgery like tympanoplasty. So how to assess the ventilatory and mucociliary function? This is to prognosticate your patient before surgery, how the patient is going to fare after the surgery. If suppose the patient is absolutely non-functioning eustachian tube and you are going to carry out a tympanoplasty, at least you can guard your patient. You can tell your patient a guarded prognosis that he may not do well in, maybe in the immediate run, the graph may take up, but long-term results are poor, as the function of the eustachian tube is essential to maintain long-term middle ear function. So the eustachian tube function assessment is imperative to have a better long-term outcome of the middle ear surgery, tympanoplasty surgery. So how to assess the ventilatory function? See, Even if you test this function and found the eustachian tube non-functional, that is not an absolute contraindication to middle ear surgery or tympanoplasty surgery. But it gives you a guarded prognosis. You can be more careful. The eustachian tube may revert back to normal once the physiology of the eustachian, the middle ear gains back after grafting, or eustachian tube may open up with a surgery, medication, steroids, sometime post-operative treatment. It may reopen, it may improve. But this is the assessment of the function is very, very important. So to test the, I would say, the mucociliary function, so this ventilatory function, the best test is the Toynbee's test. You can do with your tympanogram. In a perforated ear with a tympanogram, you can easily test the Toynbee test. How to test the Toynbee? See what happens, as I said in the beginning, the tympanogram is an electroacoustic bridge wherein a probe is placed in the extra-auditory canal, hermetically sealed, which has two ports, one to deliver the sound and one is connected to a manometer to increase or decrease the pressure on both the sides, negative as well as positive. Now in a perforated ear, if you seal the extra-auditory canal with the probe, now the only outlet to the middle ear for the pressure to diffuse is through the eustachian tube. Got my point? So when you in a Toynbee test, what is to be done? You raise the pressure by manometer to 300, 400, whatever, plus or minus, anything, and ask the patient to swallow. After every swallow, you record the change in pressure on the manometer. If the eustachian tube opens, the pressure will be corrected from negative to normal side or positive to normal side. And after each swallow, the pressure will try to come back to normal. That is a normal function eustachian tube you can see on tympanogram by means of Toynbee test. So after in a normal functioning Toynbee test, the eustachian tube pressure, what is artificially changed the pressure in the extra-auditory canal. Extra-auditory canal and middle ear are same. So is that if the tympanic membrane is perforated. So if artificially created negative or positive pressure comes back to normal after 3, 4 or 5 swallows by the outlet, and the only outlet is eustachian tube. If it is functioning, it is opening, then means your eustachian tube function is normal. If it doesn't come back to normal, see, it should come back to normal. If it comes back partially, not completely back to baseline, to the atmospheric pressure, that means your tube is malfunction. And if it doesn't change at all, you can assume your ventilatory function of the eustachian tube is not good. And you can warn those patients as far as the results are concerned, short term, long term, whatever, but that is something need to be consideration, and it is an important part of the counseling. And it's a very, very simple test you can do with your tympanometry, and this is very, very useful. That is one thing. For the mucociliary function means the secretions in the middle ear are driven out through the eustachian tube by means of ciliary activity. What you can simply do, you can have saccharine pellets, and by microscopic vision through the perforation, place 1 or 2 pellets at the eustachian tube orifice. If mucociliary function is good, the saccharine pellets will be taken, driven out or forced out via the eustachian tube into the nasopharynx, and the patient will perceive a sweet taste. If patient perceives this sweet taste in a given time within half an hour or so, we can assume that the patient has a good mucociliary function as well. If it doesn't perceive even for an hour, you can say that the eustachian tube either malfunction or not functioning. That is a simple, it's not a very, very specific, but it's a good test to assume the mucociliary function, whether it is functioning good or not. So these are the 2 tests, simple tests, don't take long, very simple, doesn't cost much, and can give you a fairly good idea about the eustachian tube function, because eustachian tube function has a bearing on the overall outcome of tympanoplasty surgery, number 1. Number 2, the techniques of tympanoplasty. This is about the technique of tympanic membrane grafting. I said in a middle ear cleft reconstruction, we'll look into the middle ear cleft completely. We'll look into the Eustachian tube. We'll look at the mastoid air cell system. I'll show in the surgical technique. We'll look at the ossicular chain. We'll look at the tympanic membrane grafting, all the aspects. So as far as the tympanic membrane grafting is concerned, there are many procedures, proposed. The only is a very good technique. All techniques are good by and large. The provided they carried out good. Only technique is a good technique. What you need to do is see. Only means your graft is placed lateral to the fibrous layer. Underlays under to it, interlays in between the layers. Simple. So in only, along with the canal skin, the lateralmost layer of the tympanic membrane, that epithelium is elevated. There's a very thin layer and graft is placed on the fibrous layer. Now, out of all techniques, this is most technically challenging, I would say. Elevating a thin or the thinnest epithelium layer of the drum all around 360 degrees and placing the graft is a challenge. If you break it, if you leave the epithelium behind, even a part of it may lead to, pearl formation, cholesteatoma formation and disaster. So this is one of the biggest complications of only, besides the blunting, because anterior graft, both ends they stick to each other as the epithelium comes over it. So these are the complications, I would say, the drawbacks of the only. The biggest one is the technical challenge. If it is technically carried out very well, it is a good result, and people have published in the best of the institutes very good results with the only. Another drawback with this technique is your graft is mostly over the malleus, which may lateralize if it is not. But now there are techniques with only where your graft you can cut and place it underneath the malleus. You can push it underneath and you can overcome. So, but the biggest challenge is the technique, the surgical techniques to elevate the single epithelium layer. Then the underlay technique has been the most popular. Millions of tympanoplasties has been done worldwide with over 90% results. So technique-wise is no challenge. There's no doubt about the technique. And out of them, it's the simplest of the technique, where its graft is placed underneath all the layers of tympanic membrane. Now, external layer, the epithelium layer, middle fibrous layer, and the inner mucosal layer. Elevate the entire tympanic membrane, make the surface a bit raw for the graft to stick, and place the graft underneath all the layers. It's the simplest of all. Results are good, but the problems are in certain situations, in large perforation, subtotal perforation, anterior-superior perforation. The challenge is to keep the graft in place for longer time, particularly in pressure change situations. So what happens? What can happen? You place the graft underneath. In a post-operative period, if slight pressure change comes in because negative pressure develops with a cold or anything important, anything develops, the graft may fall off in the middle ear. And what happens if the graft falls off in the middle ear? Graft is a free tissue. It can get necrosed. A necrosed tissue is going to invite infection. And then infection will be blamed as a cause of failure, which actually is not the cause of failure, is the after effect of the failure. The cause is the imperfect technique, which couldn't stabilize the graft, couldn't sustain the graft in the pressure change situation. So that is with the underlay, and the challenge is to deal with the anterior superior region. Sometimes there is tympanosclerosis or something in the anterior superior region. It is difficult to. Then a lot of people propose over underlay to tuck the graft somewhere at the inferior canal, somewhere over the malleus, underlay with placing the graft over the malleus. So the combination of overlay underlay techniques. Our proposition then, following Dr. A.B.R. Desai's technique, was the interlay. Interlay, as the name implies, tucking the graft in between the layers of the tympanic membrane. This technique practically, rules out all the drawbacks of the other techniques, and it allows you to inspect the entire middle ear 360 degree. Doesn't allow, this lateralization, medialization, which happens in underlay technique as the graft may fall. It allows the opportunity, gives the opportunity to place the graft between the most physiological place between the fibrous and the mucosal layer. No need to separate the epithelium layer which is adhered to the fibrous. Keep the epithelium fibrous layer as one unit and place the graft between fibrous and mucosal layer. That separation of the fibrous and mucosal layer is the technical aspect which I am going to show you. And this way you can carry out this interlay tympanoplasty in the simplest way. It's not as technically challenging as only technique. And it, overcomes all the side effect disadvantages of other techniques. And it has given a good results in our hands in, in our thousands of tympanoplasties we have done. Even all our junior colleagues who have done at our place has given amazing results. So interlay technique, such large perforation, if you do underlay, it's a big challenge. So these are the disadvantages of underlay, the commonest one, and then interlay. And then there are steps of the interlay technique, which I'm going to show you. Any questions before we move forward?
We proceed with the surgery, sir.
Okay. So in this surgery, like already the post-oral incision, there's no need to show that, has been given. The canal has been cut to open the extraordinary canal here. The incision has been, the extraordinary canal opened up. You can see the large perforation of the tympanic membrane. I hope the quality is good there.
Good, sir.
Yeah. So as far as the technical parts are concerned, we are going to show this surgery. You have to raise the tympanic membrane all around. You have to separate the tympanic membrane into layers. You have to separate the fibrous layer from the mucosal layer. So you need to raise the flap all around. Our posterior part of the flap is same like we raised for the underlay. And rest is different that we are going to show you. So what you need to do, you have to raise the canal circumferentially, the tympanomeatal flap circumferentially. Now, you can raise it right from the beginning laterally. What happens? Your flap will be too big all around. It will be too cumbersome. Yes, in a case with an overhang laterally, obviously we'll make the incision lateral to it, drill the overhang, and then raise it completely. If there is no overhang, there is no point in raising the entire, cuff right till lateral point. There is no point in making the life cumbersome. So what we do, we change our, incision, anterior incision, little medially to raise, so as not to raise the flap right laterally up to the lateral end of the canal. But adequate cuff of, tympanomeatal flap all around still without raising it till laterally. So our incisions are again tailor-made. It's not fixed incision that we are going to use for this surgery. See, this is our margins of perforations. Our incision on both sides, the superior incisions will be few millimeters away from the margin of perforation, so that you can additionally tuck your graft beyond the margins of perforation. This is inferior margin of perforation, this is superior margin of perforation, and this incision, this is the inferior margin of perforation, so our incision will be few millimeters away from it. See this. This incision would be few millimeters away from it. See, this is the incision and this is the margin of perforation, this big, so that you can additionally tuck your graft. And this incision is not going far medially till annulus, because we have to convert it to a circumferential incision. So we keep it restricted to the half of the length of the extraordinary canal, or you can say up till few millimeters away from the tympanomeatal flap, 3 or 4 millimeters lateral to the annulus, so that we can raise 3 or 4 millimeter skin lateral to the annulus, not the entire tympanomeatal cuff. Similarly, superiorly also will make the incision away from the superior margin of the incision. This is inferior, then superior. So the idea, there is no fixed incision like 5 o'clock, 12 o'clock or anything. This is the superior margin of perforation. Again, our incision will be few millimeters away, and this time we'll go quite close to the annulus as we will rotate from inferiorly only the rest of the skin. Now, before this, as in any other technique of tympanoplasty, there is a procedure of, freshening the margins. We do freshen the margin. Here the margins are already freshened. We do freshen the margin in all cases in spite of. Here, this technique only gives you opportunity to separate the tympanic membrane into layers. Though we are literally going to separate the tympanic membrane into layers, still we freshen the margin. The reason being, why the margins are freshened? Margins are freshened to make the rest of the epithelium and the mucosal layer grow. Because what happens in long-standing perforations? The epithelium laterally across the margin of the perforation layer joins the mucosa to make it non-healing perforation. So you have to break this mucoepithelium junction. That's why we freshen the margin. But here, since we separate, literally separate, still we freshen the margin. See, the posterior flap is elevated quickly. This is like any other tympanoplasty. Only thing, inferiorly it is restricted a few millimeters, below. So in this technique, even we freshen the margin for a millimeter or so, because sometimes this epithelium may grow beyond the margins further to join the mucosa, and we may leave the epithelium behind if you don't segregate completely. So we freshen the margin. This is the posterior margin of the perforation now. And see here, we go until the annulus. We will stop when we see the annulus. And see, this is the level of the annulus. You can see the glimpse of the annulus very clearly. That's the glimpse of the annulus you can see. Very clear. See the glimpse of the annulus, and this is the step where this is stopped. This step ends here. And then we'll raise the rest of the circumferential, skin all around. Rest of the skin, circumferentially, we need to raise. So after this, replace the flap. See where inferiorly we left our incision few millimeters lateral to the skin. See here. Cursor aato raha isme. Few millimeters left, and now see this rest of the inferior part being raised, and this incision would be circumferentially extended beyond the anterior superior margin of perforation. There is no fixed, point where you need to raise beyond the margins of perforation. Now see, few millimeters lateral to the annulus and beyond the anterior superior margin of the perforation. See this? This is beyond the anterior superior margin of the perforation. Had there been a lateral, overhang, I would make this incision lateral to it. Since there is no overhang, I can, unnecessarily, I'm not raising this lateral skin anteriorly to make it cumbersome. So you can raise beyond the anterior superior margin of the perforation here. And now, like the posterior part we did, raise the flap all around. Raise the flap all around till the annulus now. So we know the annulus is a condensation of the fibrous layer, and anterosuperiorly, posterior-superiorly, except the notch of the ravenous, it is there in the tympanic membrane all around. So from notch of ravenous to notch of the ravenous, anterior to posterior, we will first raise this flap. See this very, very thin. You have to be very careful while elevating the anterior skin. Unlike posterior skin, which is relatively thicker. See this posterior, how thick it was. The anterior skin is relatively much thinner, sometimes a single layer of epithelium even. So you have to raise it very, very carefully, not to use your sucker directly over the skin. You can use your sucker over your instrument, over your knife, whatever you are using, rather than directly sucking onto the skin to traumatize it.
What about if the canal is too narrow by the bony, if the bony canal is very narrow, you will change the incision for a canal calibration or?
Yes. If you find the canal very, very narrow, at places where it is narrow, you should not think twice before doing a canalplasty to that particular area. We believe in canalplasty, but not in very extensive canalplasty, extensive planned canalplasty in every case, because when you do canaloplasty with a diamond burr, you tend to clog up the vessels underneath. This flap can be taken free into the saline completely and replaced back, and it works very well. How the vascularity comes from the underlying Haversian system of the bone. If you drill away smoothly all canal all around, you practically clogs up those vessels and can result into necrosis. So partly wherever there is canal overhang, we believe in canaloplasty to have a good exposure, so that what we do not do anything blind. So that is an important part. This question is important. So one should not think twice before doing a limited canaloplasty wherever required. See now, all around, our first part of the canal skin flap is elevate the tympanomeatal flap all around till the level of the annulus. Till the level of the annulus. See anteroinferiorly, sometimes you find a sharp band. Divide it sharp. See this? Divide it sharp to reach to the level of the annulus. The first step is circumferentially reaching the annulus. One should be very clear, not to go beyond one step at one point. We'll go all the steps together. See this? Annulus should be seen everywhere. See the annulus coming into the view. So the first step is reaching annulus circumferentially together. That is the first step. We know the annulus is the condensation of fibrous layer. This surgery in interlay, we are going to separate the fibrous from the underlying mucosal layer. See now my second step. Second step is this fibrous annulus is fixed in the tympanic sulcus, bony tympanic sulcus. To release this fibrous annulus, separate this from the tympanic sulcus. See this? Fibrous annulus being elevated from the tympanic sulcus. That's the bony tympanic sulcus. You can see very clearly. I hope the picture is good.
Yes, very good, clear.
See now, this is the tympanic sulcus where the annulus was sitting in. Now elevate the annulus of the sulcus. This is the second part of the second step of the flap raising. Now we have to do this thing everywhere beyond going further. Everywhere together, bring the annulus out of the sulcus first. We have done anteriorly. Anteriorly, the angle is sharp, so it should be done anteriorly first. It gives you a good orientation to identify the annulus sharp in relation to the sulcus. Now see, everywhere, see this annulus of the sulcus, and what you see underlying, what you see underlying is the glimpse of the mucosal layer underneath.
Yes.
The same mucosa which is draping over the promontory along the lateral wall, it comes underneath the tympanic membrane to make it an air-filled cavity. So what is left behind is after you elevate the annulus, what you see underneath is the mucosal layer. See the thin mucosal layer.
Yes.
Distinct mucosal layer, I would say, which is there. And here the goal is to separate. We all know the tympanic membrane thickness is a fraction of millimeter, and still we can separate into layers. And that is what you need to do. That's the only challenge in this surgery, that you have to execute perfectly to improve your outcomes. See this annulus behind?
Yes.
Annulus behind up to the notch of the revinus. Everywhere, gently lift the annulus of the sulcus. Of the sulcus. And you can replace the tympanomeatal flap back again. Once you elevate the sulcus, annulus of the sulcus, again you can replace it. And now the next step is a gentle one again, to separate this annulus of the mucosa. This is important. Just to peel this annulus. See, the instrument I am using is an angled blunt needle, not sharp one. We are not supposed to perforate the mucosa or anything. We are supposed to peel it off the annulus. See the mucosa underlying?
Yes, yes.
See the annulus overlying? Just engaging this angle, blunt probe and peeling it off. See the movement peeling.
Yes.
And see the mucosal layer. See the mucosal margins.
Yes.
You are supposed to peel, not supposed to penetrate. Now see the underlying mucosal, distinct mucosal layer left below, and rest of the two layers are being elevated. You can see it very clearly. I hope it is very clear.
Yes, yes, very good.
So peel this mucosa of the annulus. All around, same. Every step has to be done all around, same. Now rest of the two layers will be different together from the mucosal layer which is left behind, and in between these two layers will be placing our graft. See the mucosal layer below. See the chorda coming into the picture.
Yes.
So the goal is in interlay is to divide the tympanic membrane into layers. This mucosa will serve as a bed for our graft. This vascularized mucosal layer will serve as a bed for the graft, and rest two layers will come over the graft. So the graft will be finally sandwiched between the layers of the tympanic membrane. There is no question of, lateralization or medialization or anything like it. Now you see, open up this posterior superior area and see the entire tympanum all around. You can look into the middle layer 360 degree. Anterosuperiorly, you will see anterosuperiorly. This is posterior-superiorly. If you have any tympanosclerosis that lies in the same layer which you are separating, if there is tympanosclerosis, it will come to your notice immediately and you can remove it. That lies in the same layer. And now see anterosuperiorly, the rest of the layer being separated. This is left here. See now anterosuperiorly, again peeling. Pure peeling, not cutting at all. And see the eustachian tube orifice there. Underneath the mucosa in the middle layer, anteriorly. And see, we have separated beyond the margins of the perforation till where the incision was given. You can see everything crystal clear. After repositing, again you can see how far we have elevated. See this, that's the anterosuperior margin of the perforation.
Yes.
And that is the level till the, see this, till where the layers are separated.
You have to take any extra care near the anterosuperior angle for the anterior blunting and all?
No, blunting can happen when the two layers stick to each other. Two raw layers stick to each other. Here, the epithelium and the fibrous layer will come above, mucosal layer is below, and graft is sandwiched. There is no question of blunting at all, as we are repositing it into the layers. See now, the anterosuperiorly beyond the margin of perforation, like once again you see, that's the margin of perforation and that is beyond till there to keep our graft in place. To tuck our graft, very clear. I hope it is very clear.
Yes, yes.
So this is one critical step in interlay tympanoplasty, wherein you are going to sandwich your graft in between the layers of the tympanic membrane. So what we have seen so far is a division of the tympanic membranes, differentiation, separation of the tympanic membrane into layers, and this is how you can do it yourself. It's not difficult.
We're in large perforations where you have very thin anterior margins. How often do you use cartilage?
Still, the annulus is never eroded. You may have even 1 millimeter margin the same way, because you are not doing anything on the mucosa here, peeling of the annulus.
Do you use cartilage in such cases where the perforation is very large to support the graft?
Pardon?
Do you use cartilage to support your graft in large perforations?
Same way. Now our graft is supported by the remaining layer of the mucosa, as well as the part of the medial canal wall. but it will remain between the layers. So it can neither medialize nor lateralize. And this is the most physiological place for the graft as well. The graft will be placed between the mucosal and fibrous layer and the epithelium above. That's the, I would say, the most physiological reconstruction of the tympanic membrane rather than any other technique. So this is one aspect that the flap has been elevated. The other aspect, we have to do a lot of things in the middle ear still. We have to check the Eustachian tube. The function of the Eustachian tube, I have already mentioned about the test, can be done pre-op. Mechanical, passing in anything into the Eustachian tube to appear in the nasopharynx is as good as useless. The mechanical, patency is hardly of any use to determine. It is the physiological function of the Eustachian tube that is most important. Still, we flush the Eustachian tube to see if anything lodged inside the Eustachian tube, and we have recovered certain things sometimes, because these are long-standing perforations. They get infected sometimes again and again, and that infected things may catch flies. Sometimes some people have a habit of picking their ear with a matchstick or something. So we have recovered in some patients the broken matchsticks or flies lodged in the Eustachian tube. So we always make sure that at least we flush the Eustachian tube. This is not for testing the function of the Eustachian tube intraoperatively, but just to make sure that nothing is lodged behind your grafted drum.
Even small dead insects will be coming when you flush from the.
Yes, so flush thoroughly to see if anything logged into the Eustachian tube.
How you will manage the flap and the tympanomeatal flap at the notch of Rivinus and that area, and the hand of malleus and the neck of the malleus area.
Right from here to here, anterior superior to the posterior superior region, the tympanic membrane is left undisturbed beyond the margin of perforation enveloping the malleus. That is not disturbed at all.
Okay.
Even if I have to raise 360 for a more, marginal perforation coming anterior and posterior to the malleus, I would do that. There's no issue, but you have to go beyond the margins of perforation everywhere for the extra tucking of the graft to keep it stabilized, to not to get, retracted. And see now, the Eustachian tube being flushed. See this?
Yes.
That's a simple maneuver you can finish in few seconds to do it. There is no harm in doing it. You do it or not is a different thing. You may not recover every time something, but it's always good. One can be done in few seconds. There is no harm in doing it. Next is to check the mobility of the ossicular chain. That's very important when you think of reconstructing the middle ear. Middle ear is placed by the god in such a strategic location as a transducer function. Transducer means amplifying the sound coming to the middle ear and passing it to the inner ear. Sound coming to the tympanic membrane, sound runs in the environment, in the air with no resistance. Hello?
Yes.
Sound running in the air has no resistance. It reaches so fast. But sound reaching to the fluid in the middle ear has a resistance. The fluid has a resistance. So sound reaching to the fluid is going to reflect back. Once the environment is changed for the sound is travel, it is going to reflect back. For hearing, the sound is necessary to travel inside. And that's why God has interposed the middle ear. What does middle ear do? The sound reaching to the drum is amplified by the transducer mechanism of the middle ear, reaching preferentially to the inner ear, as some of the sound is reaching into the inner ear rather than the entire sound reflecting back. So middle ear is important. Middle ear transducer function is important. And here reconstruction of the middle ear hearing mechanism is important. And that's why you need to look at the ossicular chain. See what you need to see. There is a posterior overhang. The chorda is there. We need to see the integrity of the includostapular joint and the rest of the movement of the other ossicle. If it is not, you have to correct it at the same time if possible. See the little bit of the curettage of the posterior superior overhang to see this ossicular angle much better.
What all type perforations you decide you will go for an interlay?
The perforation is?
Which perforation, which type of perforation you will decide this I will go for an interlay?
This
Something
is
like
ideal for big size perforation.
Big size.
It's ideal. That is the situation where the underlay and others will not work, and with big size perforation requires all around tucking perfectly. So for all around exposure and tucking, this is ideal because we elevate all around. Now we have a full exposure all around. We can see all angles, all nooks and corners of the middle ear. Now see the ossicular chain is being exposed. Echidostapedial joint being exposed. You need to expose it thoroughly and see the continuity. See thoroughly that it is not only the glucosal continuity. And that is very important to assess.
Suppose if you don't want to open the mastoid, if someone wants to avoid a scar, someone requests to avoid a scar, you will do the procedure transcanal endomeatal, or you will go always post-oral.
Transcanal endomeatal can be done with the same efficiency, but the issue is
if the white
not
canal,
about opening the mastoid.
if you don't
It's
want to open
about-
the mastoid, yeah.
It is not about opening the mastoid or clearing the mastoid. It is about ascertaining the patency of the aditus.
Aditus, yeah.
Because all
But there
these
are a lot of
mastoid
surgeons
hair
who don't
cells,
open the mastoid.
yes, because all these mastoid hair cells are dependent for their aeration down the eustachian tube through the aditus. And if aditus is blocked and you graft the middle ear, it can result into a failure if it is not, if it is overlooked. So this is one of the causes of failure which can draw the negative pressure later on,
yes,
adhesions and overall failure. So how to ascertain the aditus patency without opening it and checking? I will show you our method of checking by drilling from behind. But there are some indirect methods. Let me tell you. Indirect method means a lot of people discuss about it. Some may think that radiology may help you by showing a good pneumatized, mastoid all around. Showing that it should be patent if it is fully pneumatized, aerated. This is indirect sign because it doesn't pick up, the CT scan doesn't pick up fibrosis, tympanosclerosis or anything which might be blocking adhesions. Another is the proposition from endoscopic surgeons. You can put a 45-degree endoscope from front towards the aditus and see the aditus whether it is patent or not. That's a good idea, you can think. But again, this is indirect for the other parts, other side of the aditus from
with an
behind.
angle needle. Endoscopy surgeons have a lot of technique to confirm the aditus patency.
Yes, you may be correct most of the time, but still you are blind from the other side of the aditus. Still it may be blocked with a tympanosclerosis or adhesions from behind. So our proposition is to directly check 100% on the table. Because what we are looking for, the results close to 100%. So this next step is not cortical mastectomy. Let me tell you.
Yeah.
This is not enterostomy. Let me tell you. This is not a procedure. This is a test, I would say, to check the patency of the aditus. Whether your aditus is patent or not, that is the test we are going to execute by means of drilling from behind and look how the water comes from front to behind. That free flow will signifying that aditus is patent. So now what we are going to do? We are going to drill the mastoid from behind.
Yes.
See this? And we have to be very careful, particularly for the junior colleagues. So Yes. So in drilling this mastoid and going right down to the, this is a, as I said, this is a test. The moment we find that the editus is patent, we will stop. No hard and fast opening the editus, no hard and fast opening the antrum.
And from just
Got my point? And we'll follow the same principles of drilling. Wide drilling from laterally and then proceeding medially. More you proceed medially, more you drill widely laterally. Got my point?
yeah.
See now, the first step is to ascertain your superior limit and go along the superior limit. That is the editor, that is the tegmen.
Yeah, tegmen.
Change of color tegmen.
Yeah.
If you stay along the tegmen and go medially, you avoid damaging the, the lateral semicircular canal or the facial nerve or anything. Got my point?
Yes.
Stay along the tegmen to go deeper, so that you avoid damaging the lateral canal and the facial nerve. We have seen such complications. We have seen from our junior colleagues to have come to us while at this step, while drilling for the patency, inadvertently misdirected, went to damage the facial nerve. They went on drilling and damaging the facial nerve, misdirected. So the most important thing that prevents you is to go along the tegmen. As you go deeper, keep widening, more and more widening. More and more.
If the mastoid is extensively cellular, when you open the first cell itself, if you can see the transmitted motion to the middle ear, you will stop like that, or?
Just a minute. Can you repeat your question?
Sometimes very extensive cellular mastoid, if you start the drilling, one or two cells will be exposed in the very early part of your decortication, the drilling, and you can see the transmitted mobility itself, which indicates that
that's it. That's finished.
Stop there.
Yes, we'll stop. The moment we'll get the, patency, we will stop.
Okay.
Until then, you have to keep going till editus. Many a times with a lot of blockage, with fibrosis, adhesion, tympanoplasty, we have to literally widen the editus to make it fully patent. We will widen the medial incudal space, we'll widen the lateral incudal space, we'll do every possible thing to get the patency in case it is blocked at the editus level. So see now, we are going on till we get the patency, our tegmen is in view. Go along the tegmen, keep widening and keep checking the level as you go deeper. See this? See this, the level checking. See from the canal side, as long as you are lateral to the annulus, you are safe. Your lateral canal, facial, nothing is going to come lateral to the annulus. So when you go medially, as long as you are lateral to the annulus, you are pretty safe. You need not to worry about anything. And now we're looking for the patency. Let's see as we go deeper, if we get the patency. Yes. See this ice gola test.
Yeah.
It sucks like the ice gola. See the cotton from their side. We'll widen it a little bit and show you better. Yes. See this mucosal band. We will widen till we get a clear flow. See that mucosal band?
Yes.
And now it looks like a free flow. Let's check. Free flow means the column of water on both sides should be equal. You flush or suck on either side, it should be equal. Equally free flowing.
And usually that the bony appearance of the andrum also.
See now.
Yeah.
See now the free flow. Pouring from one side, sucking from other side.
Yes.
And you see the water level. Equal water level on both sides. That is called free flow. See this?
Yes, yes.
Equal water level on both sides. Everything. That is free flow. This is a test. There cannot be a better test to define the editor's patency. Rest, whatever you do, that is all indirect imagination. So we make sure to do this to confirm on table 100% patency of the editors. So this is a test. There is no definite limit to it for the medial, going medially. You may have to reach to the level of the editors, and like you said, you may get patency very, very laterally by opening one or two cells. You have to stop the moment you get the patency. As simple as that.
And
this is not
suppose if the-
enterostomy.
yeah.
This is not enterostomy. This is not cortical mastectomy.
This is
Nothing. This is a test to check the patency until you get the patency.
If the water level is not equal, it's unequal. If you feel that the little flow is less, then you will go ahead with the
Yes.
complete master. Yeah.
Yes, what we'll do, we will see the thick canal wall underneath which the annulus is. We'll keep thinning it from both sides.
Okay.
Keep thinning it both sides to bring to the level of the incus, and then we will see the adhesions medial or lateral to the incus. You open up those adhesions, it will become free flow. So never leave without free flow.
So the medial wall of that andrum in this surgical patient, that bony projections, which we call stalagmites.
Yes.
Do you feel what I usually feel is that this type of appearance of the bone usually indicates that there is not much disease in the andrum, even in the past. This typical bony projections staring at you without the much mucosal changes and all. Exactly, you can see in this patient. The medial wall of the andrum, that.
Yes, so anything coming in the way of patency need to be dealt with.
Okay.
If it is patent, nothing is required to be done, and you have to keep doing until you get the patency. In the most, difficult conditions, let me tell you, most difficult, whatever conditions, you are not able to get the patency, your chain is intact. Now, finally, you are left with the options like either to remove the incus or to do a posterior tympanotomy. You have to do something to get the patency, and those are the last resorts when you don't get patency because of too much of the adhesion, tympanosclerosis or whatever. But you can't stop without getting the patency. Okay?
Yes, yes.
Now the last is the grafting. We have checked the entire middle ear cleft, and our policy is to use a fresh graft. See this. See the superficial temporalis fascia being lifted off the deep temporalis fascia. Our deep temporalis fascia is the ideal graft material, as it's going to be used as a free graft, and for any free graft, the ideal graft should be one which has a minimal metabolic requirement. See this?
Yes, yes.
This graft has a minimal metabolic requirement. It should be pure deep temporal fascia rather than the superficial innominate fascia or the muscle along with. If it is a free, pure temporalis fascia, deep temporal fascia, it has a minimal metabolic requirement and it can sustain until it acquires a blood supply.
Is it really a recorded video, or we feel it like as we are watching the live surgery?
It's a recorded one, unedited recorded one.
But we feel it like watching the live surgery.
Oh.
Very beautiful picture.
Our plan was to show the live surgery, the reasons.
We know.
And we all here are protesting for that unfortunate incidents.
For sure. So do you dry the graft or prefer to use a wet graft?
Not really. See, this is pure, fresh graft. We don't want to, ruin the integrity of the graft by means of too much of manipulation to it, too much of drying it or doing anything to it. It's a simple bed-to-bed grafting, I would say. We'll take the graft from here and place it to another bed without whatever manipulation, cutting, squeezing, separation of tissues, whatever is to be done in the bed. Size and all this, dimension and all, you can, we manage with our experience. You can, whatever manipulation you need to do, you are supposed to do at the bed to keep the graft quality optimum. We don't want the fibroblast to damage, to die out due to heat or crushing or whatever unnecessarily. See, this is pure fresh graft, and the beauty is it heals up so fast. See this? See this?
Yes, sir.
It is lifted off the muscle by means of injecting saline underneath the graft. See, idea is not to traumatize the muscle. More you traumatize the muscle, more it will bleed, more it will require cautery, fibrosis, and this give undue unnecessary pain in this region post-op. Many patients, in spite of having good surgery done, they come later on with a complaint of pain in this region because of too much of trauma. Given this, that needs to be avoided to get better outcome, better patient satisfaction. And see, this is a pure fascia graft. Everything is scraped off, separated. See this?
Yes, sir.
And then this is a pure, as I said, bed-to-bed grafting. Coming from one bed to another, we generally make it upside down. The surface facing the muscle should face the tympanic membrane. See this? Laid down, upside down. And now it is at a different bed. See, now the bed is ready for the graft. The bed is what? The mucosal layer and the canal wall. Mucosal layer and canal wall are the bed for the graft. See this fresh graft. Not crushed at all, not manipulated at all. It is so fresh, not dried up. And believe me, manipulation of this graft is much easier than the dry graft. A lot of people, registered us for the reason that a dry graft is much easier to manipulate. Believe me, sometimes it is 100 times difficult than to manipulate a dry graft, wet graft, fresh graft. Sometimes becomes so stiff. It doesn't follow your instrumentation, and it becomes really difficult, and ultimately you make it wet. See this, the first part of the grafting, it will be completed in 3 steps. The first step is to lay it down on the canal from incision margins to incision margin, superior to inferior incision margin, spread out in the canal and then spread out in the middle layer until it goes anteriorly onto the anterior canal. The small tear doesn't make a difference as it is going to close on its own. See this. You advance it as much as it is required to come over the canal wall. And at the same point, glide it underneath the malleus. See this. You have to glide it. See this. Glide this underneath the malleus. Can you see now?
Yes.
And advanced it anteriorly enough to come over the anterior wall. We have not seen how much it has gone anteriorly. We'll see now. So the first part of the grafting is to spread on the canal wall, incision to incision, advance into the middle layer until anteriorly approximately over the mucosal layer and the anterior canal wall. That much you have to advance roughly. We will confirm how much it is. We can manipulate further if it is not reaching there, or if it is too much, you can withdraw. But by and large, and glide it under the malleus. That is first part. Could you see very clear?
Very clear.
Now the second part. Replace this posterior flap. Replace this posterior flap and make this one unit with the graft. By means being a surface graft, by means of surface tension, it becomes one unit so easily. See now. See now, it becomes one unit so easily. So that once it becomes one unit, whatever you manipulate, it is not going to displace. Okay?
Okay.
Now see one unit. Graft and see. Graft and fascia, one unit stick together so well by means of surface tension. See underneath the malleus and deposit it back. So now, once you manipulate other areas anteriorly, it is not going to displace, not going to leave. Got my point?
Got it.
And now we'll see anteriorly how far it is reaching. Our goal is to spread it all around over the mucosa and the medial canal wall. See this. See this graft? We approximately advanced it. Now what we'll do? Raise the anterior flap, which we deposited. See this. See the anterior flap?
Yes.
And the other parts of the flap. See this? See the other parts of the flap? Spread this graft over the mucosal layer all around and the canal wall. Simply. It is so simple now. You have a bed for the graft. See this spread everywhere? You can see. See this graft coming on the inferior canal wall. Can you see?
Yes.
Along with the mucosa. Yes. So spread it everywhere on the mucosa and canal wall and reflect your lateral layers anteriorly onto the graft back. See this? These layers are reflected back on the graft now. See all around. See now?
Yes.
So now the graft is sandwiched all around between the layers of the tympanic membrane. This is second part. And the third part will be, third part of the grafting would be to check all the corners of the middle ear, whether this assembly, this sandwich means the lateral two layers, the graft and the medial mucosal layer, whether they are in order all around. That is the third part to check everything. See now, this second part done, the graft in place with two layers lateral to it and the mucosal layer medial to it. Now we'll check every corner.
Keeping the gel form in the middle ear, is there any chance you need not keep the gel form in this interlay technique and you have to keep
Not at all. In this technique, we don't use gel form at all. And the graft is well placed over the canal everywhere.
And also on the mucosa. So
and it is a good, it sticks so well with because of the fresh graft, because of the surface tension, it sticks so well. It is difficult to separate.
Only the classical underlay technique.
Yeah. Now see each and every area. Posteriorly, everywhere you can check whether it is in order, whether the assembly is in order. See our editors behind. This now see checking posterior superiorly. See now checking posterior superiorly. See this? The middle ear space, posteriorly, everything in order.
Yes.
Graft and flap together. Now inferiorly, every quadrant need to be checked. Now inferiorly, see the graft and flap. See this?
Yes.
Sitting on the canal wall so nicely, and the mucosal layer below. See this? Nice mucosal layer. This one. See this mucosal layer?
Yes.
And everything reflected back. So that's a sandwich. The mucosal layer below and the canal and the graft and the rest of the two layers above. And this annulus is pushed tightly. The margins are tightened all around. Annulus being pushed in the sulcus, like tightening a tennis racket. Now see anteriorly, we have to check the same. The flap elevated, this is the graft. See the graft and see the mucosal layer below.
Yes.
See where the graft was lying on? See the flap and graft one unit again. Like we did posteriorly. And this is replaced back. This is going to be replaced back like this. See this? Like this. See everywhere the periphery is tightened. The annulus is pushed back into the sulcus. Tightening the like tennis racket to make it in place strongly. See, now we have three layers together. The sandwich, the lateral two layers, lateral to the graft, the mucosal layer below, and the graft in between is very fresh, like a neotympanic membrane, you can see. And this is so physiological, wherein a fibrous tissue is placed between the mucosa and epithelium. Epithelium laterally, mucosa medially, and the fibrous tissue sandwiched in between. That is the beauty, as it has, been sandwiched between the layers, and you can literally see the cone of light, rather, I would say, ento-inferiorly emerging from the ambo. See the cone of light.
Yes.
And now what we do, we use gel form soaked in ciprofloxacin dexamethasone solution and the blood in the field. Blood in the field contains fibrin, and place them all around at the periphery to keep our annulus pressed. See this? Keep all around to keep the annulus pressed. See in periphery. See, the graft is so secure, can't you?
Yes, yes, very much.
There's no question like, like underlay, you're always, the graph may fall, overlay, it may lateralize. It is not secure, this, that. It is most physiological, most secure. And amazing results you do and forget most of the time. Provided it is properly executed. See all around in the periphery. See the cone of light from the umbo. It's like a neotympanic membrane. See now, the gel foam placed all around, secured all around to keep the annulus pressed, and now can be, one can fill the exotic canal to have a uniform pressure on the flap all around. And it has a soaked in antibiotic and steroid as well to prevent inflammation, edema. Everything remains pressed and it will acquire vascularity from the underlying bone. What now all is required to keep it in place. So you can fill, the last part is to fill the exotic canal. See now the edge to edge flap on both sides. Sir, any questions, any comments, any suggestions?
Any questions from audience? It was a really excellent demonstration of the interlay technique from the theoretical aspect till the each and every trick and procedures of the entire interlay tibuloplasty. It was really beautiful, and we actually was witnessing the real live surgery. We were really feeling that you are doing the live surgery near to Kottakkal. Thank you for that.
Thank you, sir.
Thank you, sir.
Thank you, Satish ji.
Thank you.
Thank you. What
all.
next? See, we'll have one talk from here.
Yes, yes.
After that, what is next plan from your side?
Whatever you say.
Floor.
Yeah,
Any
whatever you
suggestion?
say, boss. You have I see in the program, you have a talk now
Yeah. Any suggestion
by
from
Dr.
the floor?
Shibu Jose.
Delegate? What do you want to see? Mucor? Sir, have a vast
Yes,
number
yes,
of
yes,
mucor
yes.
cases.
Yes, yes. We'll discuss the decision making.
Hmm?
Yeah.
Can you show one face first? After that, we can have a mucor.
Oh, yes, yes, we can, but the fest will take longer.
No problem, sir.
Time period,
No
what I
problem.
see in the program is ending
See,
3:30.
No,
We
half
have
an
two
hour
talks.
talk is there. By that time, you can have lunch.
So,
Sir,
yeah.
post lunch, you can start that first case. Is that fine?
For yeah, post lunch, whenever you say, I'm ready.
Yeah, by 1:45 you can start first. Okay.
So you have one or two lecture now.
One lecture, 40 minutes lecture.
So one lecture, 40 minutes.
Yeah.
And then we'll resume. Huh?
Oh, yeah. Is that okay?
Okay, fine.
Okay. Thank you. Okay. Thank you.
Okay. Thank you.
We'll
Thank
meet by
you so much.
1:45. Okay.
Thank you, sir, for that wonderful demonstration. Thank you, chairpersons, Dr. Arun Devakar and Dr. Sharfuddin. We now move on to the first talk for the session, endoscopic endonasal management of skull-based defects, systematic approach. The speaker is Dr. Shibu George, HOD, Department of ENT, Kottayam Medical College. Chairpersons for the session, Dr. Suma and Dr. Vinod Felix. Sorry, no chairpersons for the session. We now move over to the talk. Dr. Shibu George.
Shiv sir will be speaking online. It is getting ready. Shiv sir, can you hear me?
Yes, Shall you can hear me?
Yeah, very
Audible?
well. Very well. You can share your screen. Yeah. 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 Your screen is visible, sir.
Yeah, just a minute. Seen there?
Yeah, very well. Thank you.
Okay. Good morning, everyone. We Malappuram, entire team of Magenta, Prabharan sir, Shajit for the very kind invite. Thank you very much. Very happy to be back in Magenta again. I take this opportunity to pay respects to the great MAG sir, MA Govalkrishnan sir. I was supposed to join physically today, but due to very strong personal reasons, I could not do so. I hope to join today evening itself. Now, presentation is in tandem with the general theme of the Magenta 2022. We are talking about endonasal management of skull-based defects. I'll straight away, we'll just have an overview of the management of the skull-based defects. This is what we are going to do. Now, endoscopic skull-based surgery is better termed as extended endonasal or expanded endonasal approaches to the base of skull. You know, it gives a direct access to the ventral skull base. And as opposed to open approaches, there is no need for brain retraction, no need for cranial nerve stretch. That means that the postoperative morbidity is much less as compared to the open approaches. And definitely it gives a much better rate of gross tumor resection as compared to even in tumor surgeries. Now, the advantages are not without its own share of disadvantages. Since it does a much better job, since the dural dissection, the intra-arachnoid dissection, and even the interstitial dissection is much more, it may be associated with extensive bony defects, it may be associated with CSF leaks, and the antecedent complications, high flow CSF leaks and antecedent complications, including meningitis and hydrocephalus. And it's not just that the problem. Those cases which required a prolonged postoperative adjuvant therapy, for example, malignancies may require postoperative radiotherapy. That might delay the radiotherapy as well. That means that your reconstruction has to be spot on. We need to understand that there are a whole lot variety of open approaches in skull-based reconstruction. We are not dealing with open approaches, and we are going with the endonasal approaches. Now, what is the aim? We know it is a significant challenge, and the aim includes a watertight separation between the cranial cavity, between the CSF space and the aerodigestive tract. And by doing so, you are trying to prevent the CSF leak, meningitis, and the associated complications. When there is an extensive resection of a lesion or a tumor resection, for example, you are creating a dead space. You have to cover the dead space. And then there are critical structures. For example, you have the carotids. You can't keep the carotids exposed. You have to cover the carotids as well. And since you are using the nasal corridor, you need an optimum function. You have to preserve the function of the nose and even the cosmesis. So these are the aims of your skull-based reconstruction. So what are the options available for you for endonasal skull-based reconstruction? Right at the base of the reconstructive ladder, you have the first reconstructive option, which is a free graft. Now we know free grafts are non-vascularized tissue. They have to derive nutrients from the recipient bed. Extremely simple. It is very easy for you to procure and very easy for you to apply. Very effective as well. But there is a but there. The issue is it is not very effective in larger defects. So it may be best suited for small defects, low flow CSF leaks, and those cases where you have exposed bony edges because you need to place the graft there. You need bony edges there, and it should be sufficiently vascular. You know, you're placing a non-vascularized tissue. That means that it is in need for vascularity. So the bed has to be somewhat vascular, which may not be the case in some of the bony defects. And what are the options available? You can have autografts, you can have allograft biomaterials. Now, autografts, it is significant. You know, that's the most common graft material used for CSF leak closure. And advantages we know, it is readily available. For example, the most common graft used is the nasal mucosa. It is readily available in the nasal corridor itself. You can easily harvest and place it. And if you want to obliterate the dead space, fat is readily available for you. Mucosalization fairly easily it occurs as compared to some of the other options. But as we discussed earlier, this is not the ideal option for large defects. Again, this is not the ideal option for high flow CSF leaks. If the bed is not vascular, if it is hypovascular, it can actually lead to graft rejection and necrosis. For example, if the patient has been irradiated earlier, or the patient had extensive scarring following surgery, that may not be the ideal option for a free graft. And significantly, some of the free grafts actually shrinks over time. For example, the nasal mucosal graft shrinks by a percentage, 20% shrinkages, which should be expected. That means that you have to give allowance when you're harvesting the graft accordingly. Again, contamination is an issue. For example, you are using abdominal fat into the cranial cavity, into the CSF space, means you have to be spot on with the asepsis. So that is autologous tissue. And what are the options of autologous tissue? Nasal mucosa, I told you, is the most common graft material used in CSF rendering closure. You can harvest that from the turbinates, middle turbinate, septum, floor. Greatest advantage is proximity, just nearby site. And it can very easily be incorporated into the reconstruction. But as we discussed earlier, 20% reduction in size. So you have to harvest at least 25% more for you to keep the graft in situ. What is the other option? Suppose you have a slightly larger defect, possibly you can go for fascia. You have temporalis fascia, you have fascia lata. Now, the advantage of temporalis fascia is the disadvantage of fascia lata. Temporalis fascia is at a nearby site, proximity is the advantage, but the size of the graft is actually less as compared to fascia lata. It is the vice versa. And then you do have fat, which is available, which is in large quantities from all sides. You can take fat from the dermal fat, you can take abdominal fat. And when you have to obliterate the cavity, for example, cellular defects, sphenoid sinus, fat is the ideal option. But again, the same issue with the mucosa, 50% reduction size over time can occur in fat. And again, delayed healing, especially when there is wound infection, is possible. Suppose you want a composite repair, always go for bone and cartilage. Bone and cartilage can be harvested from the septum, vomer from the septum, or lateral cartilage from the septum, composite repair. Now, the other option is allograft. Free graft is allograft. It is commercially produced, processed, and decellularized to remove the antigenicity. Examples are collagen matrix, commercially known as duragen, which is actually synthesized from bovine tendon, or alloderm, acellular dermis. So the advantage is you can shape, the size and shape you can customize to any defect you need. And the placement is so straightforward. The technique is, there is not much of technical hassles involved. Again, there is no issue of shrinkage or even morbidity of the donor site while fat harvest. It's not there. But, mucosalization of the allograft material would take time. In some cases, it may not mucosalize after all. There is an issue of infection. There's an issue of crusting because of foreign body reaction in some cases. Cost is a significant factor, 15,000 to 20,000 per patch, and even slow viral diseases, transmission of slow viral diseases, because this is made from bovine or porcine material. So that is again an issue. And then how do you place the graft materials, free grafts? How do you place? Now, just like your tympanoplasty, it can be placed as an onlay or an underlay. Now we know, since there is a bony buttress for the graft to be in place, always you should aim at getting an underlay inside there. And then if needed, you can actually reinforce with an onlay. And this is your combined inlay onlay. What you're effectively doing here, you are actually trying to push in the fascia on as an inlay graft. And once the fascia is well set, as an inlay, you reinforce that with an onlay mucosal graft. Once it is well set there, now you reinforce with an onlay mucosal graft. So combined inlay onlay would be C. That is from the turbinate. Now, suppose you have extensive defects, suppose you have comminuted bones, suppose dural tears, you have brain herniation, high pressure leaks, possibly the better idea would be to produce a composite graft. You can sandwich the bone or cartilage between fascia or bone or cartilage between fascia and a vascularized flap. That is the ideal option when you have an extensive defect, sandwich technique. Now, you are aiming all this, your aim in all these are to get a watertight closure. So what are the other methods to get a watertight closure? As early as 1997, this technique has been described by P.J. Wormald first, 1997. Now, this is a bath plug technique where the fat plug with a specifically secured vicryl actually is introduced into the intradural space, and then traction is applied onto the vicryl suture. And when you apply traction, it comes to the edge of the defect, and the hydrostatic pressure of the CSF actually maintains the flat bed. One of the earlier effective methods of creating a watertight seal. You are trying to tease in the fat into the defect, and once it is, you can see the vicryl already tied to the fat there, and once it is inside the defect, just apply traction to the vicryl suture, and it is brought to the edge of the defect, and the hydrostatic pressure CSF actually maintains a flattened position. Now, suppose you are dealing with a cavity. One of the techniques described is known as the facial pouch or tobacco pouch technique, where you use fascia, for example, fascia lata with the periosteal side which is turned outside. You convert it into a pouch by inverting switches. You fill it up with gel form, and once it is filled with gel form, you apply it inside the sphenoid sinus. And inside the sphenoid sinus, you moisten the gel form, and as and when the gel form expands, actually the fascia comes in a position where against the walls of the sinus. This is known as the tobacco pouch technique. It has been described as early as 1967. Possibly the best option of obtaining a watertight closure would be the recently 2008 described gasket seal technique, where what you're doing is initially after your inlay grafting, you place an onlay fascia, and on the onlay fascia you place a bony buttress or even a buttress from a prosthetic material, which is as same as the size of the defect, and then you just try to countersink the onlay graft into the defect. This is known as gasket seal technique, and this is your preoperative photograph. So these are the methods of obtaining a watertight seal in a CSF binary closure. Now, what are the precautions in graft placement? First and foremost, you have to widely open the sinuses. There should be no bony ledges there. Demucosalize the adjoining area for at least 2 to 5 millimeters. Remove the mucosa. You should ensure that there is no entrapment of mucosa, so that there is no risk of future mucocele formation, especially within the cranial cavity. Then hemostasis is a must, especially when you are bleeding with brain herniation, because there is a possibility of intracranial bleeding. Now, the graft should be placed with the periosteal surface applied against the bone, so that the take-up rate is there. And always try to
Sir, we lost your audio. Sir, we are not hearing you. The mic on the mic.
I'm audible now?
Yeah, you're audible now. I think you can go 2 slides back.
I'm audible.
Yes, sir.
Vinod there?
Yes, sir. Vinod Felix here. Okay. You can go 2 slides back, sir.
Okay, I'm just asking, I was audible all the time, or I was muted all the time?
No, we missed 2 slides. Just go 2 slides back.
Okay. So just to summarize the free graft for skull-based reconstruction, now this is simple, less challenging technically, freely available, there are no donor site morbidity, can be revised as and when necessary, and there is significant success rate, but only in case of small defects. That means in larger defects, you need, especially when you need wide dural dissection and indirect dissection, it is not the ideal option. Again, if the reconstructive bed is hypovascular, you cannot go for a free graft because that leads to graft necrosis. Example, irradiated patients or previous surgery. You need coverage for wider structures. Again, this is not possible. And in such cases, you might think in terms of vascularized flaps. So vascularized flaps can be divided as intranasal and extranasal regional flaps. Intranasal options, you know, the gold standard is, or in fact, for all reconstructive options, the gold standard is the nasoseptal flap. And then you have the intranasal lateral nasal wall flaps, which are based on the terminates. Now, as early as 2006, Gustavo Haddad and Louis Basagastege actually described the nasoseptal flap, which is based on the nasoseptal artery, osseous septal artery. It was such a revolution, which created such a revolution in skull-base reconstruction. It was possible for you to reconstruct right from the cribriform area up to the craniocervical junction and horizontally across the orbits. And almost 95% success rate was possible. It was a robust, simple, sturdy flap. It had a wide arc of rotation. It could be rotated anywhere onto the base of skull. Actually, it could cover almost the entire base of skull. Since the vascularity was well preserved, there was no problem of drying by airflow. Now, this had to be harvested earlier, and even when it was harvested earlier, still it could be easily stored in the nasopharynx or in some cases inside the middle meatal antrostem. So the graft never interfered with your surgery. And even in revision cases, it could be remodeled, remobilized, and used as well. And we know the technique of raising the nasoseptal flap. You put two incisions, superior incision almost 1 centimeter beneath the nasal dorsum to avoid the olfactory fibers. Inferior incision at the level of the maxillary crest, or you can take it onto the floor of nose if you want to add added surface area. And you preserve the pedicle by keeping just beneath the ostium of the phrenoid sinus and the lower incision going up to the superior aspect of vagina. And combine the first two incisions and elevate it almost like an SMR operation. The graft can be stored in the nasopharynx or within the middle meatal antrostem when if needed during surgery. And towards the end of surgery, you can turn it up against the skull base. And here in this particular video, you can see the graft is being extended to the floor of nose for added surface area. That's a superior incision. And once you join the superior incision, you start the subperichondral subperiosteal dissection, almost like your septal surgery. And it is elevated. Once elevated fully, it is pushed back to the nasopharynx. It is stored in the nasopharynx. And towards the end of the surgery, when you need the reinforcement, after your primary reconstruction is over, you can turn the graft back into the base of skull. And you can support with adequate material. Now, just by watching the video itself, we understand the obvious disadvantage of nasoseptal flap is because you're creating a large area of demucosalized area, both bone and cartilage. That means that it is liable to crust, it is liable to demucosalize. That means the mucosalization is going to take time, at least 6 to 12 weeks is possible. In such cases, the patient might need prolonged debridement and postoperative morbidity would be high. Now, the other issue is already we told we have to harvest the graft well in advance. If you have to harvest the graft well in advance, why is it so? You have to preserve the pedicle. And when you harvest the graft in advance, there is an issue there. Suppose you are creating a wide sphenoidotomy for a pituitary surgery. Your sphenoidotomy actually can injure the pedicle of the nasoseptal flap. And that is why you go for a preemptive harvesting. Now, preemptive harvesting may not be necessary in all cases. For example, all pituitary surgery is not associated with the CSFT. That means that in some cases, you may be forced to harvest the nasoseptal flap in a situation where it is not intended to. Then there's a theoretical risk of hyposmia if you would injure the olfactory nerve fibrils, but that is not a practical risk. Majority of times there is no hyposmia. And then finally, more importantly, this may not be possible. For example, you are dealing with a revision surgery. There was a previous septectomy. There was a previous septal surgery. Nasoceptal flap is not possible. Or you have a tumor involving the nasal septum. You have a tumor involving pterygopalatine fossa where the pedicle of the flap, the sphenopalatine artery comes from. Or the patient already underwent the sphenopalatine artery ligation early. The wide sphenoidotomy has compromised the pedicle of the. In all such cases, the nasoseptal flap may not be feasible. So what are your measures? What are the methods to get over all these disadvantages? The first disadvantage is donor side morbidity. And in donor side morbidity, the best method would be to go for a reverse nasoseptal flap or a reverse Haddad flap. This is just a rotation flap where towards the end of surgery, once you have elevated the Haddad from one side, what you do is just nibble off the posterior end of the bony septum. Once you have nibbled off significant amount of posterior end of bony septum and the mucus on the opposite side, mucoperiosteum on the opposite side is freed up. What you can do is you can rotate that to the ipsilateral side and suture it this side so that you cover that denuded area of bone, of mucosa. And this is known as reverse nasoseptal flap, which was proposed by Casido in 2010. Now, the second problem with the nasoseptal flap is preemptive harvesting. That means you have to harvest it in advance. Sometimes it may not be needed. In such situation, you can do something known as a nasoseptal rescue. This was proposed by Jain in 2011. What you do in this particular case is just elevate only the posterior superior part of the incision so as to preserve the pedicle of the nasoseptal flap. And then you don't elevate the rest of the nasoseptal flap and just keep it there. Towards the end of the surgery, if you feel that there is a CSF leak, if you find that there is a CSF leak and it needs closure with the nasoseptal flap, you remove that, you actually elevate the rest of the flap. This is nasoseptal Haddad rescue. Now, we know this nasoseptal flap may not be feasible in some cases we discussed, previous septet and sphenopalatine artery ligation. Or it may not be needed in smaller defect. In small defect, what's the need for a large Haddad flap? Or it can be preserved as an alternative to use, if at all, at a later date for some added repair can preserve. In such cases, should you look for a supplementary flap? And such flaps are the lateral nasal wall flaps, or flaps based on the two terminates, middle terminate and the inferior terminate. Mind you, middle terminate and inferior terminate receives its blood supply mainly from the sphenopalatine artery. You can see the posterolateral nasal artery supplies the middle terminate and the inferior terminate. The inferior terminate receives an added supply from the anterior ethmoidal artery. Now, two flaps are possible from the inferior terminate. You can have a posteriorly based flap, which is based on the posterolateral nasal artery in the inferior terminate. You can see the anterior ethmoidal artery there. You can have an anterior based flap on the inferior terminate as well. Now, just look at the posterior based flap. This is a posterior based flap of the inferior terminate. You can see it can very effectively, it can be used to cover small defects of the cella, posterior fossa and flywheel. But the arc of rotation is limited. It cannot be turned anteriorly into the anterior skull. So a posteriorly based inferior terminate flap is not suitable for defects of the anterior fossa. And that is your surgical picture. You can see it is being elevated and then it is posteriorly turned towards a cellular defect to reinforce a cellular defect. We know the inferior terminate is supplied by the anterior ethmoidal artery as well. And you can make use of this in elevating an anteriorly based inferior terminate flap, especially when the patient had undergone his previous sphenopalatine artery ligation. Now, and this can be turned up to the base of skull effectively to line the anterior cranial fossa defect. This is a case of recurrent esthesia neuroblastoma, which was actually involving the nasal septum and the upper part of nose. That actually precluded the use of a nasoseptal flap and other flaps. The only option of reinforcement in the reconstruction was to take an anteriorly based inferior terminate flap. And you can see once it is elevated, it is turned up onto the skull base defect towards the end of the surgery to reinforce the already created closure. So Koena, that's a sphenoid sinus, and you can see the completed middle maxillectomy cavity at 8 o'clock. Since there is extensive resection of bone there is inferior terminate flap usually associated with extensive crusting. That means that you need prolonged debridement. Again, you have to take care that you don't injure the branches of nasolateral duct when you are elevating the flap. The limitations. Now, because of the proximity, the middle terminate, it lies just on the midway between the fovea and the cribriform plate. So small defects of the fovea and cribriform plate, a middle terminate flap can be effectively used. And again, it is based on the posterolateral nasal artery. Again, since the pedicle is posterior, you can turn the middle terminate flap posteriorly to line a cellular defect as well. So small defects of the cella, small defects of the cribriform plate, and small defects of the fovea, a middle terminate flap can be effectively used. But the problem with the middle terminate flap is, of course, raising a middle terminate flap. It's very difficult to have a perfect flap for the reason you're possibly the most important aspect of raising a middle terminate flap would be the infiltration. The infiltration has to be submucosal, almost like your hydrodissection, very ostial. You should ensure adequate blanching of the tissue there. And once you put the incision has to go up to the bone. You can see it is a very small structure, very labile structure, inferior middle terminate. And there can be a lot of fixture instabilities also terminate. It is attached to the base of skull. If you're not careful enough, we can even produce an iatrogenic skull base fracture. And once you have gone up to the bone, you have to elevate the mucosa with great care, because it's not that easy to elevate the mucosa. And it is opened up like it is opened like an open book with the bone in between. Once the bone has been exposed properly, you remove the bone. And you can see the bone is exposed. And once the bone is removed, you can turn the flap appropriately, whether medially or laterally, depending upon the site of the defect, whether it is on the fovea or whether it is at the cribriform plate. So small defects of the fovea and cribriform plate, this can be effectively used. If the defect is posterior towards the cella, what you can do is you can cut anteriorly and you can turn the flap posteriorly as well. Smaller defects. This is our own series in 2017, almost 20 cases, very small defects of the fovea and cribriform plate. We did get very good results. Now, that is a comparison of the intranasal flaps. You can see none of the terminate flaps fares anywhere close to the nasoseptal flap. You can see it is far superior to the terminate flaps in the surface area, length or width. That means that the mainstay of reconstruction is the nasoseptal flap. The other flaps are just supplements inadequate as appropriate situations for the nasoseptal flap. So then, what are the other options? The second line option of reconstruction, vascularized reconstruction, is the extranasal regional flaps. Extranasal regional flaps include pericranial flaps, temporopetal fascia flap, and palatal flap. Possibly the best option would be pericranial flap for the comparatively ease of introduction of the flap. Now, this is used especially when the local flaps, nasoseptal flap, is not available. For example, there is tumor infiltration, or there is a sacrifice of the blood supply, spinopelvic artery ligation, or there is infiltration of the pterygopelvic fossa. In such cases, you might use a regional flap. Now, possibly the best one would be the pericranial flap. Pericranial flap is based on the supratrochlear and supraorbital neurovascular bundle. It potentially can cover any defects right from the cribriform area, anterior cranial fossa, anterior skull base up to the clivus. But it is not suited to cover for the want of an added length. It is not suitable to cover defects beyond that. Now the access is by a bicoronal incision as seen in the diagram there. And you elevate the flap. When you elevate the flap, you have to take care that the frontalis muscle is elevated along with the pericranium, because the vascular pedicle lies between the frontalis muscle and the pericranium. And once it is sufficiently elevated, you just try to introduce it to the nasal cavity. Before introducing it into the nasal cavity, you should demucosalize the sinuses. You should do a draft 3 of the frontal and a complete ethmoidectomy. And through a midline nasio-osteotomy as shown there, it can be slowly tunneled into the nasal cavity and it can be laid. That is a pericranial flap. The next extranasal regional option would be the temporopalatal fascia flap. Now, temporopalatal fascia flap is based on the superficial temporal artery. You can see the temporopetal fascia lies between the subcutaneous tissue, between the hair follicle and the deep temporal fascia. Deep temporal fascia is our temporalis fascia, which we use for tympanoplasty. So the temporopetal fascia lies between the subcutaneous tissue and the deep temporal fascia. And you expose that and try to harvest a good length of the flap. That is your temporopetal fascia. Again, your access is through a bicornal incision. And once you expose the area, you try to harvest the flap by 3 incisions. The first incision between the supratemporal artery and the temporal branch of fascia, taking care not to injure the fascial branches. The second incision is along the posterior aspect of the temporalis muscle, and then the third incision connecting the first two. And once you do this, you elevate sufficient length of the flap, and now the flap has to be delivered into the nasal cavity. This is by a transpterygoid approach. You have to clear the pterygopalatine fossa, also known as a temporal infratemporal fossa approach. Remove the soft tissue of the pterygopalatine fossa. Possibly you may have to clip the median nerve, and you may have to deal with the spinopalatine vessels, and then introduce it into the skull base. You can see this flap has to undergo a 90-degree turn into the nasal cavity, and that is the disadvantage of the flap. Though this is highly versatile flap, the disadvantage is a limited arc of rotation. Since it has to turn 90-degree into the nasal cavity, possibly this may not be the ideal option for reconstruction of anterior skull base defects. Again, when there is associated narrowing of the carotid atherosclerosis, or where there is compromise of blood supply by radiotherapy or previous surgery, this may not be an ideal option. So that is a temporopetal fascia flap. This is the summary of the vascularized reconstruction of the base of skull. You can see of all flaps, the gold standard is nasoseptal flap. Use the terminate flaps in those cases where the nasoseptal flap is not necessary. You can preserve the nasoseptal flap for future surgeries if needed. Or in those cases, nasoseptal flap, in some cases where nasoseptal flap is not available. And regional flaps, pericranial and temporopetal fascia flaps are used in complex defects usually, especially when nasoseptal flap is not available due to tumor infiltration or due to the lack of blood supply to the pedicle. That is vascularized repair of the skull base. Now, how do you keep the flap? Or what are the precautions to be taken when you are laying the flap onto the skull base? Always the flap should be in contact with the bone along the entire line. What can happen is that distal part of the flap is in contact with the defect. The proximal part is not in contact with the bone. When this happens, what can effectively transform is during healing, the proximal part can contract. As it contracts, it pulls off the distal part from the reconstructed side, from the defect, and that is going to cause a graft failure. So the entire flap should be in contact with the bone. There should be no mucosa between the flap and the bone. There should be no foreign body. Foreign body means there should be no sealant. There should be no fibrin glue, bone wax whatsoever between the flap and the bone. We know there is a possibility of donor side mobility. That means that you have to appropriately cover the donor side if possible. Always multi-layer closure is better as compared to a single layer closure. And here you can see we are using fat to plug. After the fat plug, you are using fascia and the bone. You are using a composite graft, and then after fascia and bone, you are trying to reinforce the fascia, the repair using turning in the nasoseptal flap. Then you are reinforcing with fibrin glue and then Surgicel. Graft is kept in position with the added gel form and Foley's catheter if necessary. So just a summary, what are the deciding factors in methods of reconstruction used in skull base defect? We already discussed this. First one would be the location and size of the defect. And this is actually what you are going to decide is whether it is vascularized or non-vascularized, whether you are going to choose a vascularized graft or a non-vascularized. Suppose you have a large defect, always go for a vascularized option. Second one is presence and type of CSF. Now, the most important aspect you have to decide on which provokes you to decide on reconstruction is whether there is a CSF leak or not. If there is no CSF leak, then your only idea of reconstruction is just to promote epithelialization. That means that you look for presence of CSF leak and then look for the type of CSF leak. you need to get a watertight closure. That means that in a high flow leak, always think in terms of a vascularized tissue flap. And then type of lesion, if it's a tumor, extensive resection means you should always have a composite repair. And adjuvant therapy, postoperative radiotherapy will always compromise blood supply, means free grafts should not be used in those cases where you are trying, or should not be the lone reconstructive option when you are trying to reconstruct cases which need postoperative radiotherapy. Comorbidities of the patient, suppose a patient is obese, such patients may have associated intracranial hypertension. That means that the possibility of having a high flow leak is very high. Such patients need much better sturdy repair as compared to just singular closure. And again, availability of options which we discussed earlier. It is limited. Majority of options, some of the options can be limited by prior surgery, trauma, radiation, means you have to choose appropriately. So that is a summary of our reconstructive options. And finally, this is just a very useful algorithm by Amin Kassan as early as 2010 for reconstruction of skull base defects. Now, the first thing you look on to a skull base defect is whether there is a CSF leak or not. And if there is no CSF leak, then your idea, as I told earlier, is to repair. Our idea of repair is just to promote epithelialization. If there is a CSF leak, you look and see whether it is a low flow leak or a high flow leak. Now, low flow leaks, you look at the size of the defect and site of the defect. Now, for one thing, all defects would do well with a vascularized closure. But a vascularized tissue flap is not necessary in all cases. And that is why, suppose you have a very small low flow leak, you may be justified in just using free grafts like fat or fascia. But larger defects are always better to couple fascia with vascularized tissue flap. Again, site of the defect, suppose you are dealing with a cellular defect, it's always better that you close off the cellular defect using, obliterate the cellular defect using fat, and then you supplement with the vascular tissue. And for defects of the anterior cranial fossa, it's always better to supplement. It is if there is a lead, it's always better to use a fascia and supplement with the vascular tissue. If it is a high flow CSF leak, again based on the site, if it's a cellular leak, high flow leak, always you can obliterate the cellular with fat and then use the appropriate tissue flap based on the availability, vascular tissue flap based on the availability. Anterior cranial fossa leak, you can use a free graft as inlay only when there is associated lead to bone available. If there is a lead to bone available, you can use a free graft and then supplement it with vascular tissue flap. If it is not available, bony lead is not available, you may have to depend solely on vascular tissue flap repair. So that's an algorithm, useful algorithm for reconstruction of skull base defects, just an outline of reconstruction of skull base defects. Just to summarize what we have been discussing till now, all skull base defects, majority of all skull base defects, majority would need some sort of reconstruction, and very few may not need reconstruction. That you have to decide appropriately. And this has to be reconstruction, method of reconstruction, type of reconstruction has to be decided by the type of the CSF leak, site and size of the defect, and availability of the options. And what are the reconstructive options? We know all reconstructive options. Free grafts are used only in those defects which are very small or low flow CSF, low pressure CSF. All others you go for vascularized tissue flaps. And the gold standard would be nasoseptal flap. Whenever available, you have to make use of that. And other alternatives, regional flaps, should be used in those cases where nasoseptal flap is not available. Nasoseptal flap is not viable. It cannot be harvested because of tumor infiltration or prior irradiation example. Or if it is not needed, for example, very small defects, possibly you might use the turbine flaps. And when you are using reconstructive options, it is always better that you go for a multi-layer closure. So that's it. I've just tried to give an outline of skull base reconstruction. This is in no way comprehensive, but just an outline of skull base reconstruction for the want to keep myself within the stipulated time. Now, before just finishing off, I would invite all of you to Kottayam this next month, May 14-15. We are holding the Kerala State Midterm Conference. We have a very unique theme this time. This is surgical safety. We are dealing with, essentially, we are dealing with complications. We are dealing with what are the reasons for complications, what are the measures to avoid complications, what protocols we need to follow. We are getting in eminent faculties. We are just trying to get them share their own experiences with complications. And I think that should be a useful advent for our scientific knowledge. And we look forward to see you in Kottayam. Please allow us to pamper you with our hospitality. Thank you very much.
Thank you, sir, for that exhaustive lecture. We now proceed with the next surgery by Dr. Satish Jain. The chairpersons for this session are Dr. Vinod Felix and Dr. Suma, who will be online.
Suma madam. Suma madam കേൾക്കുന്നുണ്ടോ? മാഡം കേൾക്കുന്നുണ്ടോ?
കേൾക്കാം.
മാഡത്തിന്റെ വോയിസ് ഫീബിൾ ആണ്.
ഹലോ.
അപ്പൊ കേൾക്കാം. madam.
Hello.
So, madam, കേൾക്കുന്നുണ്ടോ?
Yeah. Am I audible?
madam കേൾക്കുന്നുണ്ടോ?
I can hear you.
madamത്തിന്റെ വോയിസ് ഫീബിൾ ആണ്.
Hello. Hello.
അപ്പൊ കേൾക്കാം.
Okay.
madam.
Hello.
So, madam കേൾക്കുന്നുണ്ടോ?
Yeah. Am I audible?
madam കേൾക്കുന്നുണ്ടോ?
I can hear you.
madamത്തിന്റെ വോയിസ് ഫീബിൾ ആണ്.
Hello. Hello.
അപ്പൊ കേൾക്കാം.
Okay.
Hello. അപ്പൊ കേൾക്കാം.
Hello.
Hello.
Good afternoon, sir. Dr. Vinod Felix
Hello.
here, sir. I and Dr. Sumar are sharing this session.
What's volume बढ़ाओ ना इधर का?
Satish Jain, sir, can you hear us?
Hello.
Sir, we can hear you. Can you hear us, sir?
Yes, sir. Yes, sir.
Sir, Dr. Vinod Felix here.
Hi,
Myself
Vinod.
and Dr. Suma are chairing this session.
Hold.
It's our privilege to chair your session, sir. We are eagerly waiting for the live unedited video.
Thank you, dear, for this.
Hello.
Sir, Dr. Vinod Felix
Hello.
here, sir. I and Dr. Suma are sharing this session.
What's volume बढ़ाओ ना इधर का?
Satish Jain, sir, can you hear us?
Yes. Hello. Yes.
Sir, we can hear you. Can you hear us, sir?
Yes, sir. Yes, sir.
Sir, Dr. Vinod Felix here.
Hi,
Myself
Vinod.
and Dr. Suma are chairing this session.
Hold.
It's our privilege to chair your session, sir. We are eagerly waiting for the live unedited video.
Thank you, dear, for this.
Hello.
Dr. Vinod Felix
Hello.
here, sir. I and Dr. Suma are sharing this session.
What's volume बढ़ाओ ना इधर का?
Satish Jain, sir, can you hear us?
Yes.
Hello.
Yes.
Sharing this session.
Hold.
It's our privilege to chair your session, sir. We are eagerly waiting for the
क्या चल रहा
live.
है? अरविंद
Thank you,
देखो आ
dear.
रहा है इधर.
Hello.
Dr. Vinod Felix here, sir. I and Dr. Suma are sharing this session.
What's volume बढ़ाओ ना इधर का?
Satish Jain, sir,
Arvind.
can you hear us?
Yes. Hello,
क्या?
sir. Am I audible?
या क्या चल रहा है? रिपीट करके आ रहे हो इधर से बात किया हुआ? रिपीट करके आ रहे हो?
It's our privilege to chair your session, sir.
या वही सुनता है.
Repeat हो रहा है.
अरविंद देखो आ रहा है इधर.
Repeat कैसे हो रहा है?
Dr. Vinod Felix here, sir. I and Dr. Suma are sharing this session.
हाँ, क्या करूँ? Hello.
Okay. Yeah.
Yes, sir. So next session is on sinus surgery.
रिपीट करके आ रहे हो?
It's our privilege to chair your session, sir.
या वही अरविंद क्या चल रहा है? अरविंद देखो आ रहा है इधर.
Repeat कैसे हो रहा है? हाँ, क्या करूँ? Hello, Dr. Vinod Felix.
So we are here. I think there is.
So next
Whatever we said,
session is on
we could
sinus
again
surgery.
रिपीट करके आ रहे हो? या वही अरविंद क्या चल रहा है?
गुरु क्या हो रहा है? तुम करो म्यूट. Now? सही है? Hello, Dr. Vinod Felix.
Yes, sir. We are.
Felix.
Yeah. There is some problem with the echo. I think it is coming back again.
Next session is on sinus surgery. Something is repeating. I don't know why.
Suma, but can you try speaking from your side because there is some problem with the echo here.
Maybe some multiple logins. Can we go ahead with the sinus surgery session?
Yes, sir. Please go ahead.
Okay. So this session is about discussion on the concepts of sinus surgery and video demonstration. Before going to the video, I would like to share, certain aspects of decision making in sinus surgery. You know, this sinusitis is a medical disease, we all know, and mostly it is, or I would say it is always, diagnosed on the basis of clinical grounds. And the standard definition proposed by all societies for the sinus disease, I would say, we all know, this is the definition, wherein the disease is diagnosed on basis of symptomatology and clinical findings. Whether patient is more than two major symptoms, maybe obstruction, discharge, loss of olfaction, headache, pain, whatever, along with endoscopic confirmation of discharge, mucin, pus or polyp, whatever, and then we confirm with CT findings. And these changes, these, symptoms should persist for more than 12 weeks to be classified as a chronic rhinosinusitis, for which we need to treat either on the basis of medical treatment or surgical, and that is where the decision making comes. So, in brief, the surgery of sinus surgery was introduced long back in 70s by Messerklinger and Stemberger, and in their research was what they found: the sinuses drain through the ciliary activity towards the natural ostium. And to take the advantage of, that, understanding that, they propose for the chronic sinus disease, you open up the sinus ostia, wide opening and drainage to establish the ventilation and drainage of the sinuses to treat the chronic sinusitis rather than doing anything inside the sinuses. You establish the ventilation and drainage and sinus disease will revert back to normal, was the concept. And was taken up worldwide. Quickly, everybody started doing sinus surgery and got good results. And ultimately, it was established as a standard treatment to treat the chronic rhinosinusitis, not coming under control with medical treatment. When symptoms do not come under control with medical treatment, after a given period of time, you need to call for the surgery. That was the basic concept. But what happened after this sinus surgery established? A lot of people started doing, and after some time, they started getting recurrences. Having done a good surgical work with wide establishment of the ventilation and drainage, still patient coming out with a recurrence of polyps. So that was the time where the researchers again went back to the same field to understand the pathophysiology of disease, and a lot of things came out. How this disease, what this actually disease is, and how the role of sinus surgery is, what is the molecular level, at what molecular level, what exactly this disease is, and a lot of things revealed. And a lot of variants of this chronic sinusitis described. And one, by and large, we all know, is with or without polyps. This was the initial understanding that set up, because in research work, it was found that the disease which didn't have polyp had a better outcome, had a different pathophysiology, different management protocol, different outcome, different prognosis, everything different than or as compared to the disease which had polyps. Has a different pathophysiology at a molecular level, different inflammatory markers involved, severity is different, the treatment protocols are now different, and everything different from each other. These are the two varieties, and people started working on it. Now, what happened? This disease of without polyposis, these people fare much, much better than with polyposis. You just establish the ventilation, drainage, treat the underlying cause, if any, and they do generally well. These are not eosinophilic dependent pathologies, and they don't need steroids for long and all that, as compared to the polypoidal disease. So most of the polypoidal disease cases were taken up on the same lines. Yet again, we found the recurrence in spite of all these patients treating on a different line than as compared to the non-polypoidal disease. Still getting recurrences. So again, the researchers found that this polypoidal disease is not the same in every patient. There are different endotypes of this disease, which has a different pathophysiological mechanism at the molecular level, and every case has to be dealt with differently on the basis of the pathophysiological mechanism. And that is how the precision medicine concept came in. So precision medicine means every patient required a precise treatment according to its own pathophysiology in that particular patient. I hope I'm audible.
Yes, sir, we are hearing you.
So how to identify these patients with polyposis? These are defined as a type 2 disease. Type 1 disease has a different pathophysiological mechanism. Type 2 has a different pathophysiological mechanism. And these are more severe cases to be treated on a different line. So by and large, clinically, we can identify all these difficult cases by means of certain features. Clinical features, when the patient has a bilateral disease with polyps, when patients have history of allergy, when patient has a history of one or more oral steroid course in the past which were effective. Where the steroid is effective, that is the nature of this disease, this subset of disease. Then many of these patients, those patients who have comorbid asthma, those patients previously operated on histopathology had tissue eosinophilia. Those patients who presented with loss of smell or allergic mucin. These are the different and a difficult category of patient in terms of overall treatment, in terms of recurrences. These are the group of patients who have more recurrences, need to be taken more effectively. And there are certain biomarkers by means of which you can get to know by means of high serum IgE, high serum eosinophil, or some certain leukotrienes and other inflammatory markers. So, to understand this in brief, the overall pathophysiology of the sinusitis is finally proven to be an immune-mediated mechanism, wherein a change or dysfunctional immunity leads to this system of manifestation of sinusitis with polyps. So I am not going in detail of the molecular mechanism, but by and large, different molecular mechanism pathophysiology is based on certain markers like IL-4, IL-5, IL-4 and 13, immunoglobulin E. All these are involved in pathophysiology and manifestation of this polypoidal disease at various levels. This has been proven now. And according to that, lots of, monoclonal antibodies have been developed to block this pathway even before manifestation of the symptom. And that is going to be the future. That is targeted therapy for the sinusitis. That is the future of this disease, not the surgery. If you block the pathophysiological mechanism at the molecular level much before manifestation, there is no point in, even thinking of surgery. So the monoclonal antibodies have been developed, have been investigated. Lots. One of them, dupilumab, have got the FDA approval to be used for the sinusitis even in certain situations, in those recalcitrant, resistant or recurrent cases where the other therapies are not working. So at every, in the pathway of pathogenesis of sinusitis, in that as cascade, anti-IgE monoclonal antibody, anti-IL-5, 4, 13, so many monoclonal antibodies have been developed, but their use, their long-term efficacy, their long-term adverse effect are still investigational, and then the use is very, very limited. And what we believe is going to be the future of this, sinusitis management. So there are, amongst this polypoidal sinusitis, with the development in understanding of the pathophysiology, there are various endotypes discovered, and every endotype has a different pathophysiological mechanism. It's not that every polyp case has to be addressed in the same way. All different endotypes have been identified, and this is now the onus is on the surgeon, the clinician, to identify particular endotype before treating so that your treatment is directed correctly for that particular pathophysiological mechanism for the optimized outcomes. Otherwise, if you try to treat every polyp disease on the same line, it may not work properly. And this is how to understand this fact. Let me give you certain endotypes, certain examples by means of which we can understand this pathophysiology, and we can direct our medical treatment accordingly. We can direct our surgical treatment accordingly. We can choose the need of monoclonal antibodies accordingly, according to the understanding of the pathophysiology. So like, for example, certain endotypes, these are the endotypes which have been defined differently. Like AERD, aspirin exaggerated respiratory disease, is a different endotype at all as compared to the other. We'll see. Allergic fungal sinusitis is a different endotype. Chronic eosinophilic sinusitis is a different endotype. Central compartment atopic disease is a different endotype. Cystic fibrosis, which presents in children with bilateral polyposis, is a different endotype. That is even neutrophilic driven disease rather than eosinophilic driven disease, yet polyposis. So there are a variety of endotypes described, and now the time is of precision medicine to identify clinically by means of biomarkers these different endotypes, and then accordingly direct your surgical and medical treatment and other treatments so that to get the optimized outcome. It is not that all cases are to be treated on the same line. So one by one, if we briefly see this, aspirin exaggerated respiratory disease, what is this? It is simply understand as a Samter's triad when a patient has a polyposis with aspirin or NSAIDs, hypersensitivity and bronchial asthma. This is one of the most severe form of inflammation in entire chronic rhinosinusitis family. Out of all endotypes, this is one of the most severe disease, I would say, and it is not uncommon. Unfortunately, it is mostly undiagnosed, underdiagnosed, and patients are being treated for the sinus surgery again and again, polyp, without understanding what the hell going on at the physiological level to stop this progression of disease rather than operating again and again. So these are the, I would say, one of the most highest inflammatory spectrum. How does this happen to occur? Look at the molecular level, what is happening, so we can plan our treatment accordingly in a simplest way to identify and treat that. So what happens? It is basically a fault in the arachnoid acid metabolism. Body's arachnoid acid tissue breaks, and it is normally metabolized by the cyclooxygenase and the enzyme into prostaglandins, which are anti-inflammatory products. Now those who are, and secondly, the other pathway is by means of lipoxygenase into leukotrienes, which are inflammatory products. And to maintain the body's homeostasis, mostly by means of cyclooxygenase, prostaglandins and forms, and these prostaglandins inhibit the lipoxygenase to prevent normally leukotriene formation, which are inflammatory agents. This is a normal physiology. Now, what happens in patients who are cyclooxygenase hypersensitive to cyclooxygenase inhibitor? Aspirin is what? COX, cyclooxygenase 1 inhibitor. So those who are hypersensitive to this, the prostaglandins do not form, and that inhibits this inhibitory pathway, and leukotrienes forms in abundance, which are inflammatory agents, which induces vasodilatation, smooth muscle contraction, mucus production, by means of a lot of mechanisms at a molecular level, by means of abundance in interleukin 5 and eosinophilic production. So once the eosinophils come to play the role, the whole thing changes into a different scenario, and this is how this disease leads to asthma because of the smooth muscle contraction and vasodilatation in the lower airways. The same thing happens in the upper airway because it is a unified airway by and large, and this affects both the areas, and this gives a severe eosinophilic and leukotriene induced disease, leads to symptoms of asthma, polyposis and all that. And the basic physiology is hypersensitivity to cyclooxygenase inhibitors, that is aspirin. So how these patients present? with a lot of polyposis, and the treatment by and large in the present context, if you see, what is the treatment in the present context? Full house fest. This is the only subset of sinusitis, I would say, which requires, we need to understand, a big openings, full house fest. I would say nasalization. Nasalization means remove everything coming in between to introduce your topical steroid later on effectively. So remove the middle turbinates, do the draft 3, remove the floor of the frontal sinus, do the wide middle meatal enterostomy and ethmoidectomy, wide sphenoidotomy to allow the steroids topical more and more reaching to combat this highest level of eosinophilia. And so the treatment in AERD as far as the surgery is concerned is different than a regular sinus surgery. You have to be more aggressive in surgical work. And in AERD, we do, once we diagnose the AERD in every patient, we do this surgery like nasalization, wherein we remove the middle turbinates and wide opening of sinuses, and draft 3 is part of it. Always part of it, the moment you diagnose the AERD. And another concept which is recently introduced by El Sharif as a reboot surgery. Reboot means like rebooting the computer. You know, normally in sinus surgery, it is called functional because we preserve the mucosa which serves as a function. In reboot surgery is advised for this particular surgery, though we never propagate that. It is recent concept, and what he described is a remove all paranasal sinus mucosa and allow the nasal mucosa, that disease paranasal sinus mucosa, and allow the nasal mucosa to grow into the sinuses, which is not like paranasal mucosa to give eosinophilia and all the disease. So remove all mucosa and allow the nasal mucosa to go, rebooting the entire paranasal sinus system. So that reboot surgery has been advocated for this, though we have never done. And the post-op topical steroid irrigation. Next, to block the lipoxygenase enzyme is a xylitol, is a costly affair. Then Montelukast, the leukotriene receptor blocker, because the hallmark of this disease is abundance of leukotrienes. So leukotriene receptor blocker, Montelukast and all these are important to block the systemic effects of the leukotriene. Then all these dietary restriction of less salicylate food, less spicy food, alcohol, and all these things aggravate this disease. Then as far as the painkillers are concerned, since patients are sensitive to aspirin, we can give celecoxib as a selective COX-2 inhibitor. And the hallmark of the treatment of this disease is aspirin desensitization. See, why I am discussing this. Surgical treatment is important once the patient has come with a disease. But if you don't correct the underlying mechanism why the patient is developing this kind of a disease, is hypersensitivity to aspirin. If that part is not reverted back, however number of times you operate upon the patient, he is going to come back with the same problem because of the abundance of the leukotrienes forming. So you need to revert the pathophysiology. We need to understand the pathophysiology for that. That's why I put forward all this. And then for the treatment of that is aspirin desensitization. Once the desensitization happens to occur, the prostaglandin start forming in abundance that inhibits the lipoxygenase and leukotriene formation stops. So the treatment, the goal of the treatment, hallmark of the treatment is aspirin desensitization. That's the final cure towards the disease, is aspirin desensitization, not the surgery. Yes, once the patient comes with the symptoms and polyposis, obviously you have to remove this, do nasalization, full house fest, and then start introducing the topical steroids, reducing so that to penetrate deep into the sinuses. And in certain resistant cases when nothing works and patients who cannot tolerate these surgeries, patients allergic to many things, and then finally monoclonal antibodies is an alternative. So aspirin desensitization. So this is the hallmark of treatment for this group of patients. Same patient presenting with polyposis, they are sensitive to NSAID and asthmatic. We need to understand, we need to be careful evaluating all patients with polyp to evaluate the history of asthma. Any patient with polyp presenting with a history of asthma has to be evaluated for aspirin sensitivity. This is the bottom line. And So this aspirin sensitization is important, and we do aspirin sensitization in the post-operative period, because then patient has to be kept on aspirin for many a times or for life to prevent this leukotriene formation. So that cannot be done if you do in a pre-operative setting. Yes, yes, dear.
Sir, how do you pick these cases up? How do you pick up a case of the ERD? Is there some particular test or something they give?
Yes, yeah, that's what I'm coming to. So your question is valid, and there's a very simple way to pick up. Clinically, any patient presenting with nasal polyposis having asthma are the patient to be, selected to keep an eye for the AERD. Number one, not all patients. Asthma and polyps are essential, and then evaluate first for that group of patients. First, evaluate the history of allergy to painkillers. Number one, if they give, you have to confirm with the aspirin challenge. There are many ways to do that. I tell you the simplest way also. So there are many ways to do that. Simply, you can give oral aspirin, but the oral aspirin challenge means you have to be ready for the asthma attack and all that. The patient who is already sensitive to aspirin and you are challenging with the aspirin to test the patient may get asthma and severe problem, that cannot be done without ICU setting. Then skin prick testing for the aspirin, that is more reliable method. We do drug testing for skin prick, drug test for many drugs, and can be done for the same aspirin as well. That is the simplest way, cheapest way to establish one of the, I would say. Then the literature describe the nasal lysine test. Nasal lysine is introduced in the nose and you see the symptoms of rhinorrhea, nasal congestion immediately after that, shows the aspirin sensitivity. What we propose, the simplest way, non-invasive test in these patients, when you suspect any patient of nasal polyposis with asthma, get urinary leukotriene test. In this condition, the urinary leukotrienes are raised n number of times, because there is abundance of leukotrienes which are excreted in the urine. A highly raised urinary leukotriene establishes the diagnosis of AERD. You need not to do any other test. As simple as that. Got my point, Dr. Vinod?
Yes, sir. Is it a costly investigation or a cheap one?
No, it's not a costly investigation.
Okay,
so urinary leukotrienes, if they are raised significantly, is an indication of AERD in those patients who have polyps and asthma. And if leukotrienes are raised, then you have to revert this pathophysiology by desensitizing to the aspirin. Okay?
Okay, sir. Thank you.
So, desensitizing, the first important thing is the timing. We have now crossed 350 patients who have undergone desensitization so far. So, timing is, as I said, you have to do it post-operatively, because once you start aspirin, you can't stop it, because if you stop for a few days, you have to restart the desensitization. That is a challenging process. So best is do a full house fast, nasalization, draft, whatever, and the moment it heals up in few weeks, couple of weeks, after that you can start the aspirin desensitization, and that will be, should be done in the ICU setting. Should be done in the ICU setting. Just a moment. Hello. Hello. Hello?
Yes, sir.
Yeah. So what I
Sir,
was
can
saying,
we
it
give
should
Monty
be.
Lucas during that period?
Pardon, sir? Pardon, madam?
Can we give continue on Monty Lucas during aspirin desensitization?
Yes. Rather, we should start Montelukast in the immediate post-operative period. So this is the only effective way with us to reduce the, leukotriene's effect, systemic effect. Because Montelukast is a leukotriene receptor blocker. Whatever effective it is, that's the only tool with us before that. Another tool is the Xylitol, which is a very, very costly drug. So
Is it available?
that is not, huh?
Is it available, sir? Xylitol?
Yeah, it is available.
Okay.
So start Montelukast before desensitization, and it has to be done in the ICU setting. ICU setting means because you have to start patient oral aspirin. We know the patient has a reaction to aspirin. The patient may develop asthma, status asthmaticus, or whatnot, severe respiratory allergic reaction, for which our intensivist should be ready with his all plans to resuscitate the patients. So to reduce the reaction, the strategy is to start oral aspirin with a minimal dose 30 milligram. Why this strategy is so that the reaction can be less and body can accommodate. 30 milligram, after 3 hours you can raise to 60 milligram, then after 3 hours to 90 milligram. Whatever allergic symptoms comes, you have to manage symptomatically by means of steroid, by means of vasodilator, by means of bronchodilator, whatever, and keep increasing the dose of aspirin. The moment you keep increasing the dose, the time comes when there is no longer reaction to the aspirin. This way, when you slowly increase the dose, the body start tolerating, and by this way, at the end of the third day, we can reach up to 650 milligram dose in no time. And once the patient start tolerating that dose, we can continue with that dose of aspirin. Once you continue with the dose of aspirin, the prostaglandin start forming, lipoxygenase is inhibited, leukotriene stop forming, and the clinical condition reverts like a magic. And this is the hallmark of this disease, and this is how to revert. The only thing
Are
is
there any adverse effects of patient taking 300 milligram aspirin every day?
Yeah, 300 sometimes is not effective, but yes, initially you have to raise. Some people raise up to 650 milligram twice a day and then keep on reducing to maintain it long term according to the symptom endoscopic finding to 300 milligram a day, mostly for life.
So no adverse effects, sir?
Huh?
No adverse effects of taking.
Yes, so everybody cannot tolerate this. Particularly, there are certain contraindications also. There are certain contraindications also for this aspirin sensitization. You see in patients, particularly who have bleeding tendency or on anticoagulants, who are planning pregnancies, peptic ulcer disease, so many. So everybody is not able to tolerate the desensitization, and there comes the role of the biologics for monoclonal disease in the severe disease. So those who can tolerate desensitization, many of the patients have now on 200 milligram aspirin, some on 100 milligram a day now, and doing well. So it depends how the desensitization, then how the patient tolerates, patient to patient. But everybody is not able to tolerate this, aspirin, because it's required. It is required mostly for life, and this maintenance therapy is important to revert the pathophysiology back to normal. So this is what aspirin sensitization is in this subgroup of patients. Yes, surgery has a role. We'll discuss the surgical part, sinus surgery, after this presentation. But this medical treatment, if disease is not understood, the pathophysiology of this particular endotype is not understood, and we keep on operating, there is no point. Then the other category is the allergic fungal sinusitis. Allergic fungal sinusitis is a different endotype. The reason being, it is not invasive fungus. We are exposed to fungus all the time. Fungus is ubiquitous in the air. The fungus we inhale, our innate immunity pushes this fungus back in the nasopharynx and gut and out. Those who are allergic to the fungus, allergic to the fungal antigen, and this fungus after inhaling happens to get trapped in the mucosa or trapped in the sinus, the body's immune reaction, hypersensitivity, antigen antibody reaction, type 1 hypersensitivity comes to play a role, and the eosinophilic activity comes around it to combat this hypersensitivity, to play this hypersensitivity, and this around the fungus, the eosinophilic material start collecting. It blocks the sinus, then the irreversible phenomena of sinus drainage blockage, hypoxia, and all this starts. So fungus and the allergic mucin keep growing and affecting the sinuses. The sinuses keep expanding because of the expansile erosion, not invasion. So in most of the allergic fungal sinusitis, if you diagnose, there are certain, diagnostic criteria described by Bent and Quinn, and one of them is a characteristic radiological finding. These hyperdensities with expansile sinuses, bony erosion because of the expansion is a classical feature of allergic fungal sinusitis. But the disease, pathophysiology of the disease is allergy. Patient who developed this disease is actually allergic to the fungus, and because of the allergic reaction response by the body, this entire phenomena of AFRS develop. So the hallmark is patient has a polyp, characteristic radiological finding, fungus, positive on fungal stain, but not invading the mucosa. You'll find a lot of eosinophilic characteristic mucin and type 1 hypersensitivity. This is classical feature of allergic fungal rhinosinusitis. Since it is an antigen antibody reaction, you have to treat it accordingly. So how to diagnose this patient? By the means of CT scan. And there are certain subgroup of patients which are affected more, with particularly living in the high humid areas, and particularly in the males, younger population. And these patients have a, if you get the serum IgE level, they have a disproportionately high serum IgE level because they are allergic to fungal antigen, and immunoglobulin E plays a pivotal role in these patients, and they are mostly unilateral disease. And this is one factor we always propagate. These patients who have fungus, they are allergic to. When you are operating on one side, try to avoid or limit instrumentation to the opposite side. Try to avoid adjuvant procedures like endoscopic septoplasty or turbinoplasty or anything on the opposite side, which may allow the fungus to grow to the opposite side, and the same phenomena can start opposite side. So we always advocate to do some limited work on the contralateral side to avoid this phenomena starting there again. You operate on one side and later when you see the same allergic phenomena goes to the opposite side and given the recurrence. So the treatment is like for any antigen antibody reaction, the treatment is steroids. Now, since fungus is the antigen inciting the entire reaction, so the first treatment is the surgery to remove the fungus, to remove that mucin, to open up the sinuses, to establish the ventilation and drainage. So the role of the surgery is to remove the antigen load, re-establish the ventilation drainage, and since the steroids are required to switch over to the topical steroids, so that the topical medication should reach everywhere into the sinuses to revert back this pathology back to normal. And in order to allow the topical to reach, we need to do wide sinus osteotomies. These patients require long-term follow-up because any antigen, anytime can incite this reaction again, and the antigen is the fungus. So these patients require sometimes a lifetime surveillance to prevent this disease from happening, wide sinusotomy and access to the topical medication, which is the only treatment. For any antigen antibody reaction, steroid is the only treatment. So this is by and large primarily not a fungal disease. It is the patient's reaction to the fungus which led to this disease. We need to understand, and for that reason, the antifungals have no role. So hydrodebrider is another tool which is very, very useful in this particular patient. Why I'm saying? Because fungus is the antigen here. You open up all sinuses widely and use the hydrodebrider. Hydrodebrider is nothing but a jet of water which can flush out the fungus more effectively. If you leave the fungal antigen sticking somewhere in the sinuses, it can incite the reaction back. So use of hydrodebrider is justified in this particular situation, and we always use hydrodebrider when we are operating for allergic fungal sinusitis, to use the high pressure jet in every nook and corner of the sinuses to deliver any fungus which is sticking to the mucosa anywhere in the sinuses. And post-operatively, as I said again, this is an antigen antibody reaction. This endotype is different than the AERD. Here, the role and the treatment is steroid. This is the only endotype wherein the post-operative long-term oral steroids are required. And along with the topical steroids, oral steroids are finally withdrawn and the patient is kept on topical steroids. As I said, this is not fungal disease. This is a misconception, as the name implies. Allergic fungal disease, some people start antifungal. Antifungals have practically no role. This non-invasive disease. No meta-analysis has proven so far that this disease require antifungal or antifungals have any role. Antifungals have only rescue role in certain situations when the patients are diabetic who cannot tolerate steroids, and you can use antifungal itraconazole or something to reduce the burden of the disease. That's all. Otherwise, no role. Yes, since it is an antigen antibody reaction, allergic tests and immunotherapy definitely help certain patients. And obviously, those who cannot tolerate the surgical treatment, not good patient, surgical patient, high IgE, you can use monoclonal antibodies combating the IgE. So this is a different group of patients. I hope you understood what is AFRS, what is AERD. The third group of patients recently described category is the CCAD, central compartment atopic disease. And a different subset of sinus disease has to be treated differently. So what is CCAD? See, normally when we inhale the allergens, if somebody is allergic, this is again allergic component. The allergens are inhaled in a particular fashion. The air current goes above the inferior turbinate, then go posteriorly between the posterior part of the septum and the middle turbinate, and then go down towards the nasopharynx. So those who are allergic, the allergens are deposited maximum behind at the posterior part of the septum, middle turbinate and superior turbinate, and where this disease incites this IgA mediated reaction leading to polyposis. And these patients have particularly low prevalence of asthma as compared to the other category of polyposis. And because of the polypoidal posterior part of the septum, superior turbinate, middle turbinate, the disease progresses because of this progress of polyps laterally, from medial to lateral, with further obstruction of the sinuses, ventilation and drainage, and finally the laterally the dependent sinuses are affected. So the course of disease is different than the other variety of sinusitis we need to understand, and the treatment, because it's allergic, is a complete phase with topical steroid irrigation and allergen immunotherapy, which is the hallmark of treatment. If you don't see this classical picture, patient have a disease medially based involving the middle and the superior turbinate and posterior part of the septum where the allergic airway current goes, and then finally keep on expanding to involve the lateral sinuses and full house disease later on. So we need to understand this particular compartment of the disease, because laterally the sinus, if the lateral, suppose all sinuses are affected, ultimately all lateral sinuses have a normal mucosa inside. They are affected because of the polypoidal lesion, because of the obstruction and drainage coming from the medial side. So mind it, the lateral all dependent sinuses have no disease. They are affected only because of blockage of the ventilation and drainage, and the disease is medially based, affecting the medial and superior turbinate and the posterior part of the septum. This is central compartment atopic disease, which requires a proper phase to establish ventilation, drainage, topical irrigation, and allergen immunotherapy. Allergy treatment is the hallmark of treatment of this disease. So this is third category. Another is cystic fibrosis. Why I am showing all these patients have polyposis but a different underlying pathophysiology, and we need to understand and treat all patients accordingly. So cystic fibrosis is a different category, but it's a basically genetic disease. There's a genetic defect or mutation in the cystic fibrosis, CFTR protein, transmembrane regulator protein that results in mucoviscidosis, the viscid secretion, because defect in the chloride transport mechanism leading to viscid secretions, and viscid secretions ultimately block the sinus ventilation and drainage because the cilia are not working, and that leads to this kind of a disease. This is a massive disease with a high mortality. Progressive disease will ultimately lung failure. It involves the lower airway and presenting with the sinuses and then lower airway, and majority of these patients ultimately require lung transplant. So we need to understand this is a genetic disease. How to identify this? Simply, besides this, see, the chloride, sweat chloride test is the final test. But before that, how to identify? This is in children. In the early ages of life, we have operated youngest 2.5-year-old child. Children presenting with bilateral polyposis should be considered cystic fibrosis until proved otherwise. As simple as that. So patient, young children, very young children presenting with bilateral multiple polyps. And this disease is different from the other because this is not eosinophilic disease. It's pure neutrophilic disease and a pure Pseudomonas infection. Because of the pent-up secretions, they develop Pseudomonas infection most of the time. So this disease is a different disease with polyposis in very, very young children. The treatment is challenging because what you need to do locally is to give a gravitational drainage to the sinuses to allow the antibiotic to be introduced deep into the sinuses. So this again requires a perfect nasalization surgery. Even in the youngest of the children, nasalization means to give gravitational drainage to allow the topical antibiotics to penetrate deeply, not steroid. This is not eosinophilic disease. There is a secondary infection involved, mostly Pseudomonas, and you need topical antibiotics like topical colistin or topical tobramycin. All those antibiotics are required to tackle the Pseudomonas infection. So the surgery, the kind of surgery required in this is nasalization. Means we have done bilateral, medial maxillectomies, middle turbinectomies, full face, full in children. We don't need to do anything with the frontals as they are not developed, and wide sphenoidotomy, the complete nasalization and gravitational drainage. The role of the surgery is different to give gravitational drainage. It is not functional surgery, and to assist the topical antibiotic penetration, not steroid. This is not eosinophilic disease. So there are different subsides of sinusitis which need to be treated differently. This is what I'm trying to send the message, and the treatment is a lot of topical surfactant. Ibuprofen improves the local immunity in such patients. Resveratrol is an antioxidant, improves the CFTR protein mutation. This is one drug, it's a wonder drug. It's basically antioxidant found in the red grapes, and the concentration is more in red wines than the red grapes, and it helps in this cystic fibrosis patient. Then obviously the mucus is the problem. So NS tells Dornase alpha is a more potent mucolytic by means of breaking the DNAs of the degraded neutrophils in the mucus. This acts very well. Then the drugs which affect the CFTR protein is the ivacaftor and other are required, are very, very costly. 1 month cost is almost 2 lakhs, almost $300 per month is the cost for ivacaftor and all that. And other research work is going on about the gene therapy and other therapies as well. So there are many ways to, there are variety of endotypes, and we need to identify the ongoing pathophysiological mechanism. We need to, investigate thoroughly these patients before impinging on to the sinus surgery. Every case has to be treated differently. But now, why sinus surgery? What is the role of sinus surgery now? Time has changed now, and the indications for sinus surgery have been redefined. This is, we need to understand. We have seen the entire cascade of event in the pathophysiology of chronic sinusitis, wherein right from the pattern recognition receptors to ILC to IL4, 5, 13, IG, all are involved. Everywhere at every level of the cascade of sinusitis, the only thing which works is the steroid. Steroid works. So The steroid is the most effective treatment. Now, a patient coming to you with polyps, and you give any patient of polyps, you give course of steroid for 1 or 2 weeks, he'll come back to you and be very grateful. Doctor, your drugs are, magic, and I've been feeling so good. The other doctors are unnecessarily pushing me for surgery to make money. You are the best doctor I have found so far. And what you have given? Oral steroids. So oral steroids are effective at every level of the cascade of chronic rhinosinusitis. But in your hearts and hearts, you can't give oral steroids for life. So the strategy has to be designed how to avoid the oral steroid use, because right now, the weapon in our hand is one and only thing, steroids for all these polypoidal patients. So the strategy has to be changed, and there comes the role of FES. So now the goal of FES has been redefined. Redefined means the goal of FES, as discussed earlier, is to establish the ventilation and drainage of sinuses. Yes, it remains same. Number 2, you remove the inflammatory load. Like you are treating a fungal disease, polypoidal disease, you open up all sinuses, establish ventilation, drainage, and remove all these disease load, inflammatory load, eosinophils, IgE, polyps, fungus, everything you remove. You remove the inflammatory load and then provide the access to the topical steroids. Now, once you have operated, all sinuses open up, you give access for the topical steroid through penetrate. Why it was not happening earlier? Why oral steroid was the only weapon? Because earlier, what topical steroids were we giving were the nasal sprays only. Since sinuses were blocked, the other steroids, the douching will not penetrate the sinus inside. To make the topical steroid penetrate deep into the sinuses, the FES is the only way. So the goal of the FES has been, the role of the FES has been redefined. Mind it, to establish the ventilation drainage, to reduce the inflammatory load, and to make the topical steroid penetrable. Earlier, in a non-operated situation, you are left with only option, either give oral steroid, which you can't give for life. The only option was topical steroid, which do not penetrate beyond entry of 1/3 of the nasal cavity. The nasal spray, so many, radionuclide studies have been done, the steroids labeled with the radionuclide agents, and they do not penetrate beyond entry 1/3 of the sinus nasal cavities. So they do not penetrate sinuses as well. And in a non-operative situation, you can't even think of, there's the role of, topical steroid is so less. So if the disease inflammatory load is too much, topical steroids will be too less. So the goal of the sinus surgery is redefined. We need to understand before operating upon every sinus patient, why we are operating. We need to tell the patient also. We need to counsel the patient also that sinus surgery is not the final answer. It's a medical disease. We are operating because we want to make your sinuses functional by means of establishing ventilation drainage. We want to remove the inflammatory load. The load is so much, your topical steroids are not effective. And we want to make the topical steroid penetrate deep into the sinuses so that you don't need to take oral steroids in future. So this is the strategy to avoid oral steroid in the future and making topical steroids effective without systemic side effects of the topical steroid, yet penetrating deeply into the paranasal sinus. That is the whole strategy with the FES. And future, obviously, is the targeted therapy. Steroid is not the answer. The only answer we have right now is the topical steroid. And to make topical steroid reach deep into the sinuses, there is role of sinus surgery. That's why we are here to discuss the sinus surgery today. If the targeted therapy establishes in future as a safe and cost-effective therapy, I'm sure the sinus disease will not reach to the level of manifestation of polyps to require a surgical therapy. So, the sinus disease, once it comes to sinus surgery, first of all, why we discussed so far is for decision making. But once finally we decided to do a sinus surgery, now we are going to discuss the surgical steps of a sinus surgery. So before we move on, any questions, any suggestions, sir?
No questions, sir. We can proceed the surgery.
Do we go ahead, Dr. Felix?
Yes, yes, please.
So you can take any online questions or anything. In the meantime, feel free to interrupt me. So once it comes to sinus surgery, our goal, as we discussed, is to establish the ventilation and drainage. At the same time, to give adequate openings to penetrate the topical steroid. In future, we train our patient by various methods to douche with the steroid solutions so that it should reach everywhere in the sinuses, so the need of the oral steroid doesn't arise. So patient can douche in the future with topical without needing the oral steroid and without systemic side effect, and yet can remain asymptomatic. That is the goal. So once it comes to sinus surgery, surgical part, it's a surgery, with a surgery of, I would say, less safety margin in the sense sinuses are all around, in relationship with the orbit and the skull base with a sub-millimetric distance at places, and there are a lot of critical structures traversing around the sinuses. The skull base is above, the orbit laterally, the carotid artery, optic nerve behind. So many things, are in close proximity. So we have to execute this process as diligently as required. And here comes the role of radiology. Radiology is very important to give you anatomical details, relationship with the surroundings. As I said in the beginning, this is diagnosed on the clinical ground. On the symptomatology and endoscopic finding, you can diagnose this is CRS. The role of radiology is to rule out so many other disease. Role of radiology, rule out some other disease means sometimes the symptoms are overlapping and there could be a tumor behind. The role of radiology is to rule out some other disease. Role of radiology is to give you correct anatomical information of the particular patient, because the sinus anatomy is so variable amongst patients. There are variety of cells, cellular, difference amongst patients. There are variety of cellularity. There could be, different relationship with the surrounding structure. The surrounding bone may be dehiscent. The bone over the carotid, the skull base, optic nerve, orbit may be dehiscent, and if you are not careful, you may end up giving a disaster. So the role of radiology is very, very important. I'm not going into the radiological detail. If you want, we can take in the evening. And here what I want to show is, in this particular patient which I am showing, has a massive bilateral pansinusitis. And what we see here, let me go back a little. First of all, see this? See this, the frontal sinuses above. Go back. Go back. Yes. Let me go back. Yes. See the frontal sinuses above, completely opacified till here sinuses. This is the beak, the floor. And then this is very important to understand. This particular patient is a very interesting patient with all, anatomical challenges, you can say. See this. This was the frontal sinus initially, completely opacified. The intersinus septum deviated. This is incomplete septation anteriorly, then intersinus septum. And now the floor has gone here. Now see the orbit. See the maxillary sinuses has started coming. Earlier there was no maxillary sinuses until the frontal was there. And now there is no beak, and this is what? Ethmoidal cell going above the orbit, supraorbital cell. Looking like a frontal sinus, this is supraorbital cell. This is not frontal sinus, because this is too posterior where the cribriform plate is in view. When cribriform plate is in view, there cannot be frontal sinus. This is supraorbital pneumatization, supraorbital cell, the maxillary sinus coming into view. So what I want to say, this patient has an interesting frontal sinus, interesting, pansinusitis, I would say, and a small, you see this, this is what? Osteoma. A small osteoma. Everything complicating to the sinus disease.
Bilateral type 3 cells were also there.
Pardon?
Bilateral type 3 cells are there, sir, in the first cut.
Bilateral type 3?
Yeah, that one.
You can say small type 3, not a very classical type 3, Dr. Felix. If you see the definition of the frontal cells, see this. This is frontal beak.
Okay.
These two cells above the beak.
Yes,
Can you see?
Yes.
Type 3 cell, you can say about the level of the beak. But a very small one, it is not expanding high up into the sinuses to give a challenge.
Okay.
But my point. But yes, you're right, it has to be treated like a type 3. This is a frontal cell, anterior cell, you have to go behind and bring it out. That is why we'll treat it like a type 3, you can say. And this see behind the ethmoidal disease and minimal disease in the sphenoid. So basically, this is the ethmoidal disease which has affected all dependent sinuses. That's how the disease starts, when it blocks the ethmoidal channels, the dependent sinuses aeration and ventilation aeration is blocked, and that's how this disease is developed. So once it comes to surgical part, the role is to do a perfect endoscopy to orient yourself to the endoscopic landmarks, and the biggest landmarks in the sinus disease when you operate sinus surgery is the turbinate. See this turbinate? That's the middle turbinate, high up attached to the beak here anteriorly, and it goes high up, see here, to get attached to the cribriform plate at the junction of anterior cribriform plate at the junction of medial and lateral lamella. So this turbinate is very, very important. That's the polyp coming from the middle meatus. See, there are multiple polyps after decongestion from the middle meatus, and this is the fontanelle. There, that's the uncinate process anteriorly, so it is posterior fontanelle. And see multiple polyps arising from the uncinate, from the bulla, from everywhere. So that's a case of multiple polyposis, you can say. That's the fontanelle. This is endoscopy to determine your understanding of the disease. We use or always advocate the topical adrenaline for preparation rather than infiltration. This marrow cell we use as a vehicle to bring in the adrenaline to mop everywhere with the marrow cell, so you can apply adrenaline everywhere and decongest the mucosa, and then comes the role of surgery. So once it comes to role of surgery, the first part is debridement of the polyp. Debridement of the polyp to delineate the landmarks better. See now, once the polyp are debrided, you can see this is your middle turbinate. This is your bulla coming into the view. Can you see the bulla behind?
Yes, sir.
That's the bulla coming into the view. That's the uncinate process. This is the polyp coming from the uncinate process. So to define the landmarks better, the bulla, the polyps need to be removed as a first step. Now you see the field, how bloodless the field is. This requires a long preparation preoperatively. Why? To make the field bloodless. See how bloodless it is. Otherwise, the sinus mucosa is so extensively supplied, and particularly in the setting of the sinusitis inflammatory disease, the vascularity, vasodilatation, all these contribute to the high bleeding. And what preparation required is a preparation one can start a few days back. We give all polypoidal patients, steroid courses to reduce the inflammation, to bring the mucosa back towards normal, to reduce the vasodilatation and overall inflammation. And then intraoperatively, you have to prepare with the topical preparation of topical steroid. So that's how you can make your field, bloodless, and intermittently throughout the surgery, you can, after every step, you are supposed to mop with the topical steroids. Once you mop with the topical steroid, it will further improve your field. So the maintenance of the surgical field, good surgical field is very, very important. And that is a very, very important determinant of avoiding complications. If you are operating in a field with a lot of bleeding going on, it may make your identification of the landmarks difficult. And if your identification of the surgical landmarks is difficult, one can easily land up into complications. That is how we need to understand. Now see the middle turbinate, your uncinate, which is deformed because of the polyps, because of the polyp load, the uncinate is everted, I would say, and the bulla, More are the polyps, more the uncinate is deformed. Number one. More are the polyps, more the turbinate becomes unstable, floppy because of the pressure, and more are the polyps, more the middle turbinate becomes smaller, atrophic because of the pressure. So these are the things one can expect in the case of massive polyposis, I would say. And this is, now the the uncinate process. So now our first step in the surgery starts with the uncinectomy. Uncinate is a very, very useful landmark in sinus surgery. The first step is a very, very important step in terms of, carrying the surgical course smooth further. This uncinate has two parts by and large. The upper vertical part of the uncinate goes high up to get attached mostly to the laterally towards the lamina papyracea, and lower horizontal part goes behind to variable extent to either to the perpendicular plate of the palatine bone or ultimately ends in the inferior turbinate. It is variable, so that is lower horizontal part. And on CT scan we can easily determine how the vertical part is inserted, either medially or lateral, because that is something we need to know, how the vertical part is inserted. Before going to this, so this vertical part of the uncinate we need to understand. Sometime because of the massive aganesi or something, it may be pushed medially to get inserted on the turbinate or skull base, and those patients you have to be careful not to, or I would say to handle the turbinate, the uncinate gently, not to pull it, not to put a force on it to remove it. Otherwise, one may destabilize the attachment of the turbinate to the skull base or may give a distant CSF leak. So you have to be careful, and the radiology will exactly tell you where the upper part of the uncinate is going to get attached to the either to the turbinate or upper end. Now the first step is uncinectomy. Earlier, see what I am using here is the reverse biting forceps. Push your reverse biting in the hiatus semilunaris is inferior is, direct it little inferiorly. As you direct it inferiorly, it is away from the nasolacrimal duct anteriorly. See, this prominence is from the nasolacrimal duct immediately anterior to the uncinate. Earlier, when the Stamberger introduced this concept, they would use a sickle knife and take this uncinate as a one unit from the lateral wall attachment. But in that situation, sometimes your orbit is very close to it, and you may get an accidental entry to the orbit at the early course of the surgery. Now you see this uncinate, keep biting anteriorly until you find the hard bone. When you feel the hard bone, is the time to stop to prevent the nasolacrimal duct being bitten with the forceps. So you have to analyze, use the reverse biting is a very, very safe tool, and come anteriorly, and this process is known as what it has opened here. That is the infundibulum. Just behind the uncinate, see, this is the infundibulum here where the maxillary sinus ostium open. This infundibulum is a three-dimensional structure. So this is divided the uncinate at the upper vertical and lower horizontal part. This is unsenotomy. You can say unsenotomy, you can say infundibulotomy, whatever. And now see, if you push your ball probe lateral to the lower part, see this, lateral to the lower part, you can fracture this lower part medially to open up the middle meatus or the maxillary sinus ostium. See this, just fracture the lower uncinate medially. Just fracture it and you will get the maxillary sinus opening, laterally opening into the infundibulum. Ajaypal? See this. This is a very, very important step, the uncinectomy. See now how the lower part of the uncinate is being removed. This the bony uncinate, and see the middle meatal antrostomy is being carried out. That's a very, very important part of this the surgery here. See this, That's the bony uncinate, which is being removed with the forceps. That's the bony plate of the uncinate. One can easily remove. You have to pull it gently without catching the mucosa. In this surgery, we are supposed to preserve the mucosa everywhere as much as possible, as this is functional surgery, functional endoscopic sinus surgery, and the function is ultimately going to be served by the mucosa itself. So this is functional endoscopic sinus surgery. We need to understand. And so the first part is uncinectomy, uncinotomy or infundibulotomy, and then fracture the lower part of the uncinate, remove the bony plate, and now with the red 40 debrider, shaver, you can remove the rest of the uncinate. Debrider is a very, very important tool which cuts sharp and sucks. It is mucosal preserving, and you see the maxillary sinus, interior of the maxillary sinus now, without peeling off this mucosa. We have to be careful not to peel off this mucosa. That's why don't pull anything, cut sharp. Cut sharp, create a middle meatal enterostomy. See this? And depending upon the underlying disease inside the maxillary sinus, you have to widen the middle meatal enterostomy. If you have a massive disease inside, massive fungal disease like in allergic fungal sinusitis, which requires a lifelong surveillance, then the strategy is different to create a mega middle meatal enterostomy. That mega middle meatal enterostomy allows you to inspect the maxillary sinus better for life. It allows you to introduce the topical steroids better in high doses topically into the sinuses, and it allows an overall better surveillance. So if the patient is not having massive disease, you are not supposed to create a mega enterostomy. Just create a regular enterostomy and this is middle meatal enterostomy. If you want to create a mega one, you can see how you can do. You can widen this posterior wall, the medial wall posteriorly up to the posterior wall of the maxillary sinus. So this part of the medial wall you can extend, removing it till posterior wall, and sometimes it is formed by the perpendicular plate of the mucosa that you have to bite through and widen it. That is a mega middle meatal enterostomy. If I remove this medial wall till posterior wall behind. So in cases required, there are varieties of ways to create the mega middle meatal enterostomy, and one of them is to widen it posteriorly. If you want further, widening, you can reduce down with a part of the inferior turbinate down to the floor of the nose to further widen it, or you can do even a medial maxillectomy needed in certain situations, which we have already discussed. Two massive diseases like AERD and cystic fibrosis, where it is mostly required. So the kind of surgery required is dictated by the underlying pathophysiology. That was the message I wanted to convey. To understand the underlying pathophysiology is very, very important, which can dictate you, to choose the surgical procedures, which can dictate you to choose the medical treatment. It can dictate you to choose other treatment like biologics, dictate you to choose like immunotherapy. That is very important to understand. And this is the surgical part. So the first part is the lower part of the uncinate has been removed. Still the complete uncinectomy is not done so far, and now is the time. See, the field has again improved by means of applying the Merocel. The field is good. Then you move on to the next step. After every single step, keep mopping with the Merocel soaked in adrenaline to improve your field, to identify again the landmark so as not to land up in complications. So that is very important part of the surgery. As I said, the safety profile is less in this surgery, as it is surrounded by the important critical areas around. See now, for the upper part of the uncinate, there are various techniques again. I can use a debrider and remove it with an angle debrider. What I am using here is the curate, angle curate. This is best. This step we must know in sinus surgery. Go behind the cell and fracture it out anteriorly, means away from the skull base, away from the critical structures behind. See this is very, very safe step. This upper part of the uncinate fractured anteriorly, away from the posterior important structure. You don't make that way you don't damage anything, and now you can remove the bone or you can debride it all the way to get rid of it. See, now the uncinate plate is being removed separately by means of the forceps. See, this is the plate of the bone. You can remove separately, and then you can debride the entire thing to get rid of this uncinate completely. That's how. So it is again, it depends upon you how you handle the every anatomical structures differently. It's not hard and fast to do the everything in the same way, but we need to understand why we are, what we are doing and why we are doing and what to save at particular step. Please feel free to interrupt me if any questions or suggestion any point of time.
Yes, sir.
Now, the uncinate is being taken, this upper part being debrided.
Do you always prefer this angle debrider over the straight one, sir? Because you're using it, the angle.
Pardon, can you speak a bit louder?
No, do you always prefer using the angled micro debrider to the straight one?
No, not angled everywhere. Like for the initial debridement, we use the straight one. For widening the middle meatal antrosmy of 40. Here again 40. When we go to the frontal, we'll be using more angle, 60. At the skull base, we'll be using the reverse one, adenoid one, the skull base blade. So at different level, differently in the maxillary sinus deeply or frontal deeply, we use 120. So it depends. Where are we using? Where are we working? But yes, here until now, after the straight for the debridement, I have been using the red 40. This is 40. See, the shaft of the blade is not coming in the way. And see, this is the remnant of the uncinate being taken. This upper part uncinate removal is a very critical step because immediately lateral to it is the lamina papyraceae. And I said you, this uncinate is deformed because of the polypoidal mass coming out of the middle meatus. And you have to be aware of this fact so as not to make an accidental entry into the orbit at this point of time. If you get an accidental entry into the orbit at the beginning of the surgery, it affects your temperament during the entire surgery. So it is very important at this step because this is very, very close to the lateral wall, and that is orbit. See now what is there behind? See the middle meatal antrosmy, and behind that is what? Behind that is bulla ethmodalis. So now medially is the medially is the turbinate here. Laterally the remnant uncinate being removed to flush with the lateral wall completely, thoroughly. Behind what we see is the bulla ethmodalis. See here.
Yes.
We debrided the polyps there. And see, this is the middle meatus completely opened up. Flush everything to the limits. Flush the uncinate to the limits, but don't cross the limits. And one of the most important thing, as we have already discussed, to respect this middle turbinate. During sinus surgery, at any point of time using any instrument, we are not supposed to, handle this turbinate. The best treatment of this middle turbinate is to respect it, not to do anything to it. To stay away from it rather than manipulating and making it unstable. See now laterally. What is there? This is lamina papyraceae. Immediately lateral, we can see the glimpse of lamina papyraceae here. See this?
Yes.
And on the lamina, what is attached is this bulla ethmodalis. This bulla is attached laterally to the lamina, and once we remove this, part of the uncinate, that is lamina here where my cursor is, and this is the bulla ethmodalis. Now the uncinate looks like completely removed from above, and this is some sort of suprabular pneumatization you can see.
Yes.
That is suprabular pneumatization. Now, again, as I said, after every step, you have to mop with the marrow cells.
Using plain adrenaline in the marrow cell or with?
Yeah, this is, see, in most of the patient, when we are using topical, we use pure adrenaline because we are not injecting, number one. Number two, plain adrenaline application reduces its systemic absorption immediately by means of vasoconstriction. So it is pretty safe, except in cardiac patients, highly labile patients, elderly patients. We avoid using a pure one, even for the topical, but mostly because we operate younger patients for sinus disease, mostly are younger patients, used freely the topical pure adrenaline, but only for topical use, not for infiltration. Now see, change to 70 degree. This is the time to change to 70 degree. Let me go back a little. Yes, now this is the time to change to 70 degree for the reasons here. Let me tell you, we have done a middle metal antrostomy, nothing else. Our bulla is still intact. And now we want to go to the frontal sinus to work there, using a 70 degree for certain regions. And this technique we have been following for years after the initial description by Professor Dharambir Sethi from Singapore. We have been grateful to him to introduce this intact bulla technique at point of time. And intact bulla is the technique, means you are keeping the bulla intact and carrying out the frontal sinus work with the advantage, as most of the time this bulla goes to the skull base. And when it reaches skull base and you keep the bulla intact, your anterethmoidal artery is automatically protected by this bulla anteriorly, and you can ensure, something like avoiding damage to the anterethmoidal artery if you keep the bulla intact. Now see, this is the bulla, and this is coursing towards the skull base above and medial to the bulla. See, medial is the turbinate this side, is the bulla this side, and this is the area which we are now handling with the 70 degree. So, how to avoid complication in sinus surgery, as one of them is by means of using 70 degree at the level of when you are working for the frontal sinus. See, this is the lateral limit, that is the orbit. It is visible with a 70 degree. Now everything will be done under vision with a 70 degree. Otherwise, the frontal is so strategically located up that you can't see with a 0 degree, or that you try to do, it is going to be blind. With 70 degree, it is under vision. This is the lateral wall formed by orbital medial wall. Medial limit here is the turbinate, which we have to protect. And anteriorly is the beak. That's the beak which forms the floor of the frontal sinus as well. So what we believe, if you follow this beak and go behind where the beak ends in the beginning of the frontal sinus. So if you try to do with a 70 degree, you have an advantage. Number one, from safety point of view, you keep the medial wall of the orbit in view, and as long as your instrumentation doesn't cross this medial wall, you can certainly avoid the orbital complications. You keep the orbit medially in view. As long as orbit is in view, and if you don't breach this, don't cross this limit, you practically avoid injury to the skull base, as this orbit goes above and insert on the lamina papyracea. Keeping both the landmarks medially and laterally in view is possible only with a 70 degree while working here at this level. And thirdly, the beak. Another landmark with a 70 degree which we are seeing, which is a useful landmark. In the sense, this beak forms the anterior wall as well as the floor of the frontal sinus. If I stay between the medial and lateral limit and work towards the beak, anterior to posterior, where the beak ends is going to be frontal sinus, this is something, a very, very useful, reliable landmark. It cannot change. If you keep this in view, you're never lost to the frontal sinus. In any extreme difficult revision situation, the beak is never going to change. So now our goal is to stay lateral to the turbinate. This is the Agarnagi cell. This is the posterior wall of the Agarnagi. And we need to see this go behind the agar to bring it out. See, these are all anterior group of cells in the frontal recess, frontal outflow drainage pathway. This is one cell which is sitting on the mouth of the frontal outflow pathway. See this cell here. Again, mob with the marrow cell. Mob with the marrow cell. We saw in the CT scan this patient is an interesting frontal. See this. This is the agar cell or a frontal cell sitting on the mouth of the frontal pathway. This cell, entire cell. What we need to do is go between this cell and the middle turbinate to go behind this cell and fracture this out. And here anteriorly and below is the bulla ethmoidalis, which is left intact. So this is the cell which need to be fractured. Go behind and fracture it out. That is the simplest way. See this, how it is being done. Go behind. Go behind and fracture out to lead to the frontal recess. This is very, very safe. And I would say one of the best ways to enter the frontal so easily. See now, this has been fractured. Once we remove this, behind is going to be the frontal drainage. See this? This was adhered, fractured with a ball probe, a blunt instrument, very safe tool. Fractured laterally, anteriorly and laterally, and remove this, and then straight away enter into the frontal. See this? See this cell being fractured and entering into the frontal. Now what you are keeping in view? With a 70 degree, your middle turbinate is in view all the time. Your instruments are directed laterally. Could you see that?
Yes, yes, yes.
All instruments were directed laterally along the turbinate. So that is a safer way of avoiding the skull base injury, and that is possible under vision only because of the 70 degree. It's so important it is to understand to carry out the sinus surgery in the safest and the easiest manner. See, goal is to simplify the things. And now see this redundant mucosa. After fracturing and using the microdebrider, we can easily remove this redundant mucosa. See this? Now this is red 60. See now, this redundant mucosa, why the microdebrider is important here? Not to pull anything to give, denuded areas in the frontal recess. If you see this,
Yes,
this
yes.
is something, the opening to the frontal recess. See that?
Yes, sir.
Now we have a lot of challenges here. Remember from the scans, sometimes there are a lot of opening in this area and everything looks like frontal sinus. We suspect one opening for the frontal sinus. We suspect one opening for the type 3 cell going above the beak. And we have to suspect one opening for the supraorbital cells. All three can look in the same region. Everything looking like a frontal sinus, and how to differentiate each other is very important for the surgeon to get the optimum outcome. Sometimes your supraorbital cell is so big, looking like the frontal sinus, and surgeons come out opening the supraorbital cells and leaving the frontal sinus as it is behind. So what you see, is it frontal sinus? See this opening, the big opening? Is this frontal sinus? No, this is not frontal sinus. See this? This is a cell which is going high up above the beak. Can you see this cell? You have seen in the CT scan which Dr. Felix pointed out. So this is a type 3 cell. Going, see this high up going above the beak, though it is not very big. Had this been very big, we would have, we might require the drilling of the beak to reach high up, but that was not very big. We could see that. So now we have to enter into the frontal proper. We have to define the type cell, type 3, and we have to define the supraorbital. All three differently. Now, one by one. It's purely unedited. Again, improve your field. In the marrow cell at every step, we don't want any bleeding to prevent the identification of the landmarks, and see the field. This field is so amazing. Now see, we can go medial to this cell. Medial to this cell, that is a type 3 cell. Type 3 cell, there are, variety of cells in the frontal recess. Certain groups of cells, are anterior to the frontal pathway. They narrow the frontal pathway from anteriorly. There are certain group of cells which they narrow the frontal outflow from behind. Those are suprabular or frontobular cells. So for those cells, they are attached to the skull base behind. And these are the cells which are attached anteriorly, and they are narrowing the frontal outflow from anteriorly. So goal for this group of cells is to go behind these cells and fracture out anteriorly. You need to understand. See, this is the beak.
Yes, sir.
Beak, and this is the cell which needs to be taken now. Needs to be taken now. See now. See now, going medial to the cell. Going medial to the cell. See that? Can you see the instrument behind the cell?
Yes, sir.
That is the instrument. See, a sinus cannot be so thin. Sinus wall cannot be so thin. So this was the type 3 cell. Could you see?
Yes.
Simpler for anybody finding difficult to handle type 3. Don't get scared. Don't be afraid of type 3. See this big cell there?
Yes,
and what I did, I went medial to it between the cell and the turbinate. Went behind the cell. See again, go behind the cell. Just for demonstration, this was, see this?
Yes.
That is your frontal sinus. Can you see?
Yes, sir.
Very nice.
And this was the cell. See the difference? This is the cell, this is the frontal sinus. Everybody, don't get confused. Go through the CT scan thoroughly about the cellularities there in the frontal recess. See this? And this is the type 3 cell. What we need to do is now go behind this cell and fracture out completely. Remove the party wall between the cell and the sinus now and widen the sinus outflow pathway. As simple as that. Okay? Here we didn't do anything to the bulla so far. We are using 70 degree up there towards the skull base, doing nothing with the bulla. Try to understand. See this? So you need to remove the party wall and see there what is there in the floor here. This is the osteoma.
Okay.
Remember we had osteoma.
Yeah.
Will you remove the osteoma or leave it like this?
Yeah, you can easily remove. This is a small osteoma.
Okay.
Now see this party wall being removed. Can you see?
Yes.
Or the party wall of the type 3 being removed, and that is the widening of the frontal sinus. Still this frontal is not completely widened. I tell you the reasons. See this party wall.
Yes, sir.
See this party wall?
Yes.
The bone need to be removed. See this bone now, separate. So earlier people would discuss about how big the frontal opening should be in terms of, measurement in terms of millimeters, centimeters. That is bullshit. I tell you, the frontal opening should be as big as possible to the limits. Limits means anteriorly the limit is beak, medially the limit is turbinate, posteriorly the limit is skull base, and laterally the limit is orbit.
Even when
Unless
the frontal sinus is normal.
Pardon?
In this, the frontal sinus mucosa looks perfectly normal.
Yeah, there was some edematous mucosa, some secretions, nothing else. It was blocked secondarily, looks like.
Yeah.
Because of the ongoing blockage in the ethmoids, polyps, because of the so many things, the abnormal anatomy of the cells, narrowing the frontal ostium, because of this thing, osteoma, everything contributing to the blockage of the frontal sinus. See this party wall coming out.
Yeah.
And now the rest of the mucosa can be debrided to widen it to maximum laterally.
Sir, are you deliberately avoiding using deep breath over the bone? Are you deliberately avoiding using deep breath over the bone? Everywhere you're
deliberately avoiding
first,
what?
Using deep breath on the thin bone, because everywhere you're removing the bone first and then deep breathing.
Yeah. The debriding on a thin bone.
Yeah. You can actually.
Yeah, because we can remove the thin bone as a whole. See now this bone exposed.
But even with the deep breath, you can remove that bone. Also.
Yeah, you can debride. But see this. Entering there completely all the way for debridement is difficult. What you can see this with a giraffe.
Okay.
Yes, see now the big portion of the bone comes out. So you can do anyway. Both are safe. The debridement is also very, very safe. See the type 3 cell. See the frontal sinus. All different.
Sir, is there some particular scenario where you don't do a intact bulla technique?
Don't?
Is there a particular scenario where you don't go with the intact bulla? You go with the bulla down technique.
Yes, you can go with the bulla down if you are, very experienced to able to identify the landmarks above and do it. We can go ahead. We do sometimes.
I'm asking about your experience.
See, this is suprabular cell. See, this is small suprabular cell. See this?
Yes, sir.
This is small suprabular cell, which is now fractured here. Inferiority is attached to the skull base, and now see further widening of the frontal. A lot of widening is still required. There's a very interesting frontal. That's why still osteoma is, narrowing. Still, see this mucosa is coming. Avoid mucosa pulling. Could you see?
Yes, sir.
Avoid peeling of the mucosa to give raw areas. This time you can use debrider. Dr. Felix, could you see?
Yes, sir. Yes, sir.
So not to pull the mucosa. If it is coming, use the debrider. Now see, we haven't seen the supraorbital cell yet. What is supraorbital cell? We have seen on the CT scan. It is a posterior anatomy, posterior to the frontal, going above the orbit.
Yes, sir.
Yes.
Mind my words, posterior anatomy, posterior to the frontal, narrowing the frontal drainage from behind. See this?
Yes.
See this bone comes out easily. as a piece once you pull it out without mucosa. See that? Now the frontal looks much bigger. So now we have see the frontal sinus, we have seen type 3 cells, we have seen osteoma, we have seen supraorbital cell, we are going to see bulla, we have seen, but we have not seen the anterior ethmoidal artery. See how safe it is to carry out the work so far. We have seen, we have done so much of work, we didn't even discuss about the anterior ethmoidal artery. Why? Because we are working far anteriorly with the angle telescope, directing anteriorly. Could you see?
Yes.
Yes, sir.
Anterior ethmoidal artery runs in the roof of the ethmoid, in the roof of the anterior ethmoid, in the posterior most part. Again, anterior ethmoidal artery runs in the roof of the ethmoid, in the posterior most part of the anterior ethmoidal roof. So now see where we are working, the beak, the frontal sinus, behind that is the anterior ethmoidal roof, and in the posterior most part of the anterior ethmoidal roof will be the anterior ethmoidal artery, and that too covered by the bulla, since we have kept the bulla intact. So see how safe we are from the posterior ethmoidal, anterior ethmoidal artery. See the rest of the remnant of the type 3 cell. Could you see?
Yes, sir.
Yeah, that's the cell wall coming out.
And the anterior ethmoidal artery may be running in the mesentery when you have a large supraorbital cell. Right,
Correct.
sir?
Yes, there is a high possibility. The reason is simple. When there is, see, it normally this artery runs in the roof of the anterior ethmoid, which already has a thin bone. The roof of the ethmoid is a thin bone through which this artery traverses. Now with too much of pneumatization there. See now, this is, let me show. This is, see this reverse blade, so-called adenoid blade, which never advocate for adenoid because it's a rear facing blade. And what we are using here for the skull base to flush it with a 70 degree to make it anterior facing. Now it is anterior facing for us. See this?
Yes, sir.
That's a so-called adenoid blade. See this? To remove these septations, to flush to the skull base, under vision, and see how widened the frontal sinus is now. Can you?
Yes, sir.
See, the entire septation has to go. Yes. See, initially, when we started, we didn't even see the frontal sinus.
Yes, yes.
It was a type 3 cell. And then, see now the final wall coming out. See this?
Yes, sir.
And given a wide opening of the frontal. So, this cell was narrowing the frontal outflow from anterolaterally. And once this is flushed, the frontal is, widened, some more bone piece. Posteriorly, it is narrowed by this supraorbital and this osteoma as well as medially. Though it is adequately enlarged now. So frontal sinus work is something we must understand. We should not terrify. With the only thing required is to get used to 70 degree, which is a very important scope here, to look into corners, because what you see with the 0 degrees, where the scope shows straight is your anatomy, but with 70, the scope shows 70 degree up than what your scope directs. So it is very important to get used to, because everything is angle now, instrumentation. See the frontal and the scallopings inside. See the big frontal sinus. And now is the time to see our supraorbital cell. to complete the frontal sinus work. See, once you want to work deep into the frontal, this is 120-degree blade. You can go far deep into the frontal sinus with this blade. See this small bone pieces and redundant mucosa you can flush for better healing. This is 120-degree blade. Yes. Now see the lateral wall, that is orbit. And now we'll see the cell going laterally and high up behind the frontal sinus into the from the ethmoidal roof above the orbit, behind the frontal sinus, narrowing the frontal anteriorly. So that cell is posterior to frontal. See the view after cleaning with the saline. Douching is very important. Keep douching with the saline in between or ringer solution, whatever. See the bulla with 70-degree. Still intact and going, see here, going up to the skull base. Can you see?
Yes, sir.
The bulla going up to the skull base, that has concealed the anterior ethmoidal artery from us. We couldn't see an anterior ethmoidal artery because of the bulla going high up. Yeah. Now is the time to flush the anterior ethmoidal roof to uncover the supraorbital cell and further widen it and further defining the anterior ethmoidal roof completely. And that's the bulla ethmoidal is still intact, completely intact, which has covered our important structure. Mopping, cleaning, it's a part of the procedure every time. See now the skull base blade. Now to flush the skull base after the frontal sinus. After means behind the frontal sinus. See this. The blade, see the cutting edges are visible. Can you see?
Yes, sir.
This is a reverse blade, adenoid blade. I am working at the skull base with a 70-degree vision and see these cells I am opening up to flush to the skull base. Can you see?
Yes, sir.
How safe this blade is here? Because you are cutting under the skull. See now the cell is opening up and that will lead to the supraorbital cell. See this. See now the cell is opening up.
Yeah.
Yes, that cell is opening up. Yeah, that is the supraorbital cell going far laterally. Can you see there?
Yes, sir. Very
Yes.
clearly.
Oh, that is above the orbit which saw on CT scan. See that? And this narrows the frontal opening. If I remove this party wall between this and frontal, imagine how big the frontal would be.
Yes.
See, everywhere what tool is required is very important. And another important thing is to maintain the visualization by means of reducing the oozing, bleeding. So every single thing is important to carry out and optimize work. See that? See this now. The two things which are still there, one is the supraorbital cell narrowing the frontal from behind, and another is this osteoma. See, this is uncovering the supraorbital cell, and see, removing the party wall between the supraorbital cell and frontal sinus. The lateral limit is the orbit there. This cell is riding laterally and above the orbit. See this? See now the party wall being removed between the supraorbital and the orbit, and see the osteoma mobilized.
Yeah.
And now it is going to come out soon. So far, we didn't even look for the anterethmoidal artery. Not even bothered to see that because our bulla is intact. See, this is the party wall, all the way laterally. See that? How the cell is going laterally with the 70 degrees. See that?
Yes, sir.
Below is the supraorbital, above is the frontal. So anteriorly frontal sinus, behind is supraorbital, and it narrows the frontal from behind. That is the thing to understand. See this? The kind of cellularity there. So this is an amazing case of a frontal sinus for everybody to deal with, how to deal with type 3, how to deal with, supraorbital cell. इधर आने लग गया आवाज. See now, it is wide, and see the supraorbital cell, how it is flush with the frontal. See how big the frontal sinus drainage pathway now. Once you are doing frontal flush with the limits, as I said, see this? My limits, anteriorly the beak, can you see here?
Yeah.
Medially is the turbinate you see here, laterally the orbit you see here, and posteriorly this is skull base. That is the limit. So all limits should be flushed. That is the supraorbital. So for frontal sinus work, it is imperative to understand this anatomy, to use the 70 degree, to read the CT scan thoroughly, and then executing this work to the limits all around. That is most important. If you leave the septation in between, that can invite problems later on. See the fine tuning with the party wall clearance. See, little bit of the bone still left, and then the osteoma is out. And now see how big the opening is. See how big the frontal opening is now. And because now it is completely flush to the all surrounding with little bit of the septations, and now see the frontal opening, and this is flush with the ethmoidal roof. behind. You see?
Yeah.
That's the ethmoidal roof where the supraorbital cell has gone laterally, and this is the frontal. So frontal sinus with the beak anteriorly, this is the anterior most is the beak. Then frontal sinus where it ends behind is the where the posterior table is, and then is the roof of the anterior ethmoid flushed. So frontal and anterior ethmoidal roof flushed. See the party wall, remaining party wall, some septations. So there's a fine tuning.
So if there is
Still we
a
have,
large
madam?
osteoma in the frontal outflow tract, what are the precautions to be taken in drilling over there?
Large osteoma,
Yeah.
exposure. First,
Compromise.
First
Yeah.
is the exposure. Exposure to see all around the osteoma, and that may require a draft procedure, number one.
Okay.
Once it is completely exposed, if it is, not mobilized, you can divide the osteoma. You can go inside the osteoma and, make it empty, and then you will be able to mobilize the osteoma, rest of the osteoma as a one piece.
Okay.
It comes out easily. Osteoma is never a big challenge. See, flushing everywhere. The marrow cell in the frontal, and still not remove the bulla. That's what I am reiterating again and again. Everything done so far to the frontal sinus, to the anterior part of the roof of the ethmoid, yet we didn't discuss about the anterior ethmoidal artery, not remove the bulla. That is the important part of the surgery. Now, once we remove the bulla, that posterior part of the anterior ethmoidal roof, you will see the anterior ethmoidal artery running there behind. And one of the best landmarks for the anterior ethmoidal is at the posterior edge of the supraorbital cell. Bigger the supraorbital cell, more the anterior ethmoidal artery pushed behind. More the pneumatization of the skull base, more the anterior ethmoidal artery you will find running into the mesentery. Because the bone will be less and less thin, thick. See now, this is complete. Can you see in one view?
Very nice.
The frontal and the anterior ethmoidal roof, still the bulla is intact. See this bulla?
Yeah, yeah.
Now the bulla being fractured, Go behind the bulla.
Through the retrobullar.
Yes. See the bulla being fractured, and then you will see the beauty. The anterior ethmoidal artery courses along the anterior ethmoidal roof. In the posterior part of the anterior ethmoidal roof, covered anteriorly by the bulla. To understand this fact, if you understand this anatomy, we can execute the intact bulla technique without the fear of the anterior ethmoidal artery coming into the way. That is the whole, idea behind this carrying out this technique. Is the safest. See, once you talk about the anterior ethmoidal artery, we have to evolve the technique which is safe and complete. Safety is very important because the margin of safety is very less in this surgery. Slipped. That's the smallest osteoma, it slips. And now is to look at the ethmoidal roof thoroughly after removal of the bulla. and you'll find the artery coursing there along the roof of the ethmoid, immediately caudal to the supraorbital cells. Once you have a supraorbital cell, look at the caudal aspect of the immediate caudal aspect of the supraorbital cell, you'll find the interethmoidal artery. That is most important. Say this, the remnant of the bulla being debrided. This is the remnant of the bulla. And if we see superiorly, anteriorly there, see that's the wall of the bulla. That's the bulla. And behind that, you see something coursing.
Yeah.
That is the level. It was so well covered by the bulla. So as long as bulla is intact, what you need to see at the CT scan that the bulla is going to the skull base. If the bulla is going to the skull base, see now, that's the interethmoidal artery. See, this is your supraorbital cell, and immediately caudal to the supraorbital cell is interethmoidal artery. It is always, and see, artery is so prominent because the supraorbital cell is so pneumatized. So that is very, very important part. See now, where the artery, see where the frontal sinus is, how far behind is the artery. Could you see?
Yeah.
And immediately behind the artery is the bulla, the ground level attachment. Behind that are postethmoids. So immediately behind the artery, the postethmoid starts. This is the attachment of the ground lamella here to the skull base behind the artery. There's the artery. That is supraorbital cell, and this is the anterior attachment of the bulla. See, this is the attachment of the bulla to the skull base. That is artery here, and this bone is the attachment of the bulla to the skull base. So, once this attachment of this bone is removed, see this bone. This bone is the anterior attachment of the bulla to the skull base, which is being removed now, and the artery is completely uncovered. Uncovered. See this? That is the bulla attachment to the skull base. Imagine this bulla, whenever attached to the skull base, the artery is covered behind. See this yourself. Can you see?
Yes, sir.
How protected it is. That's how the intact bulla technique works, and we are grateful to Dr. Sethi for propagating this technique. See this. That's the interethmoidal artery. And here was the anterior attachment of the bulla, the upper attachment of the bulla. And here, this is the supraorbital cell, just immediately anterior to the artery, and immediately anterior to supraorbital is the frontal, and anterior to that is the beak. Can you see in order everything?
Yeah.
In entire process, our middle turbinate was just not disturbed. The best treatment for the turbinate is to respect. Yes, madam, your question? Can I get some question? That's the remnant of the party wall anterior to the artery, so that we can flush this supraorbital cell with the interethmoidal artery. See now. So it is, see the supraorbital cell above and the interethmoidal artery immediately behind. See immediately caudal to it yourself. Could you see?
Yes, sir. Very clear.
This is the artery there. And see. Yeah. That's the artery there. That's the artery there. And that was the supraorbital cell. And so important is to understand this all anatomical concepts. See, so far the frontal and the anterethmoidal work is done, completed. Still the posterior and the frontal, the sphenoid sinus work is left behind. And for that you can change to 0 degree again. So this work of the anterethmoidal roof and the frontal sinus for, accuracy, for safety and under vision work, it is the 70 degree which is most important. This is what I wanted to convey. And the rest of the work you can carry out with a 0 degree. Yes. See the turbinate, everything. Now for the 0 degree, see this. This is the roof of the maxilla. Could you see? Roof of the maxilla, if you draw a line from the roof of the maxilla, is known as maxillary line. Draw a line from the level of the roof of the maxilla to enter into the ground lamella safely. See now, for the posterior work, our fear is to avoid penetrating the skull base, to avoid accidental entry into the sphenoid sinus. What all is to be required? This is ground lamella. Can you see the ground lamella?
Yes.
Now, at the level of the
Maxillary, below the maxillary
sinus roof, medially, we need to enter into the ground lamella to enter into the posterior. And when we enter into the posterior, see this, just to enter into the posterior at this level. The moment you enter, we are not supposed to carry out the posterior first. To add on to the safety that we don't accidentally enter into the sphenoid, our proposition is when you enter into the posterior, take a medial route, find the superior turbinate and then go medial to it to form the sphenoid ostium. Once you find the sphenoid ostium, then staying anterior to it, you can remove the posterior. That way you will never damage the carotid artery or optic nerve. Because the carotid artery and optic nerve never come anterior to the sphenoid sinus ostium. What's my point?
Yes.
See now, this is entry into the posterior. So simple. At the level of the maxillary line, this maxillary line has a lot of importance. This is important from the safety point of view. Now take a medial turn. See this. Once you take a medial turn, you will find some important structure there. Why maxillary line? Because to enter into the sphenoid, this line is the guide. Don't go above it, otherwise you may enter the skull base. As simple as that. See now, taking a medial route. See this. See this. Taking a medial route, and what you are seeing now, that is the superior turbinate coming into the picture. See that? Yes, this one. This one is the superior turbinate. Superior turbinate, that's the nasal septum medially. So go between the superior turbinate and the septum, flushed again, this is septum. Flushed against the septum. Again, these two important things, landmarks. One is to stay in the line of the superior, the maxillary line. For the superior inferior level, this line is the limit. And for mediolateral level, see this. Entering medial to the superior turbinate. Can you see the superior turbinate being bitten? Hello?
Yes, yes, sir.
Yeah. Now going medial to the superior turbinate. The septum there. Go flush with the septum. See this. Could you see the septum there?
Yes, sir.
Go flush with the septum, along the septum, not along the superior turbinate. And never above the maxillary line. See this. You will find the sphenoid ostium. See the maxillary line for your reference. See this.
Yes,
never above the maxillary line. Otherwise, if you go above, high up there, you will enter the middle canal fossa. Never above the maxillary line. Yes, debride this part of the superior turbinate further. And there, if you glide your instrument along the septum, it will always be in the sphenoid sinus. That is the safest entry into the sphenoid sinus, I would say. See the maxillary line. Again and again, Could you see the sphenoid ostium?
Yes.
Glimpse of it. The idea
Yes.
is to, if you avoid going above the level of the maxillary line, you can never give complication of a CSF leak. See this?
Yes, sir.
With a periosteum gliding, suction periosteum gliding along the septum. Can you see this movement? Glide your instrument along the septum. See the suction periosteum gliding along the septum to enter into the sphenoid sinus. Could you see easily?
Yeah.
I am emphasizing again and again, glide along the septum. If you go laterally, you'll be misdirected. So now once you have seen it, once you have seen the sphenoid sinus, see now, remove all the cells anterior to it. All this bunch of cells, we need to remove, staying anterior to the sphenoid sinus. See this? The large ethmoidal cells, posterior ethmoidal cells, larger ones as compared to the anterior ethmoids.
Yes, sir.
We can see now, remove all these posterior ethmoidal cells. See this? This is the ground lamella, and that is the skull base behind. The posterior ethmoidal skull base behind, you can see, that's the posterior ethmoidal skull base, and that is the sphenoid sinus below, posterior-medially. So in order to carry out safely, that is the posterior ethmoidal skull base. See, that is the posterior ethmoidal skull base. Yeah. And here medially is the sphenoid. See, this is sphenoid and this is posterior ethmoidal skull base. In order to enter into the sphenoid, you have to be careful to go along the nasal septum. And now removing the party wall between the sphenoid and the posterior ethmoid to flush the skull base all the way from the frontal to everywhere. See, that is the sphenoid sinus. Yes, still. That is the sphenoid sinus. Can you see?
Yes, sir.
Yeah. So, keeping the ostium in view, remove everything anterior to it. Now you will stay anterior to the sphenoid sinus opening. Remove everything, flush laterally to the orbit. You cannot damage anything. You cannot damage anything like optic nerve, carotid artery. It cannot come anterior to the sphenoid ostium. See this way, if you don't follow this, keep doing the posterior ethmoidectomy behind. See, that is the optic nerve behind. See, in the depth is the optic nerve behind. So one has to be very careful, which is what an already described is one of the cell going behind the sphenoid. If you keep going behind, without looking at the sphenoid ostium, one can easily see the skull base completely flushed. Now, that is the optic nerve there. Okay. And this is the sphenoid ostium there. Now, the last part of the surgery is to widen this sphenoid ostium, removing the anterior wall. See this anterior wall here?
Yes, yes.
That is optic nerve there. See that?
Very clearly seen. Yes,
so this is onod cell. This is onod cell. So this interesting patient has all kind of variety of cellularity. So worth demonstrating. And this, the last part now is to widen the sphenoid. See now, we were at the level of the sphenoid ostium anteriorly. If we don't follow this and go behind the level of the sphenoid ostium, we can easily damage the optic nerve. See this? So if there is onod or whatever, if you follow the medial route, find the sphenoid ostium first and then carry out the posterior ethmoidectomy, staying anterior to it, you can never damage the optic nerve. As simple as that. See now, the last part is to widen the sphenoid. See that? That is the anterior wall of the sphenoid now. See everything flushed like a box. See my medial limit turbinate, lateral limit orbit. Can you see the orbit all the way?
Yes, sir.
Yeah.
The skull base behind, the turbinate here, and the orbit here. And this is the entire skull base. See, mucosal eyes, complete mucosal eyes. Everywhere mucosal eyes. Now, last part is widening the sphenoid ostium. This is now the widening of the sphenoid ostium. Mopping, cleaning. Now see widening the sphenoid ostium. With a bone punch, Kerrison punch, you can widen the sphenoid ostium like this because the onode is there behind. So Kerrison is the safest one. And that is now the interior of the sphenoid. See now the interior of the sphenoid. Do you see?
Yes, sir.
So we need to understand this anatomy of the sinuses, the relationship to the skull base, orbit, preserving the turbinate, preserving the mucosa, flushing all the cells. It requires a lot of efforts to carry out a good sinus surgery in terms of giving minimum, morbidity to the patient post-operatively. And see, once this complete flushing is done, even if now what is left for the patient according to the disease profile to douche with a steroid solution. If he keeps on doing under follow-up everything normal, you can reduce the frequency and intensity of the steroid. And if the patient finds asymptomatic, we can reduce much according to the need. So it requires long-term follow-up. In case the patient forgets and doesn't do the douching and the polyps develop, suppose worse to worse. Now what is left for the future sinus surgeon? Nothing. All bone work till limits. Till limits means till orbit, till skull base, everything bone work is done. Nothing left for the future surgeon. So in case the polyp develop, you can give a course of oral steroid, start douching again. You can debride the polyp little bit under office and nothing. No formal sinus surgery is required. Once this kind of a full house sinus surgery is done, you can indirectly guarantee your patient that you will not need a formal sinus surgery in future. Yes, if the douching and the follow-up is regular, you won't need any kind of intervention for that matter. But worse to worse, you will still not need any formal sinus surgery. Worse to worse, you may develop polyp if you don't follow, and we can debride that in office and we can start the steroid and douching later on. That is the beauty of the full house sinus surgery, and this is the final answer to the patients who have chronic rhinosinusitis and polyp and this kind of a disease, and rest of the treatment is directed according to the pathophysiology or the molecular profile of the disease, which we discussed earlier. Any questions or anything, sir?
No, sir. The fantastic demonstrations, sir. We really enjoyed each and every aspect, and every time we watch, we learn some new points.
Suma madam, any comments?
Excellent demonstration, sir. Luckily, it was a very good case with all sorts of anterior pneumatization, onode, supraorbital, and a very good frontal demo. Thank you very much, sir. As Vinod told, every time we hear you, there will be a very good practical tips, especially management of sinusitis and the endotypes and phenotyping of chronic rhinosinusitis. Thank you very much, sir.
Thank you.
Thank you, Satish ji.
Thank you.
What
boss.
next is 35 minutes talk by Vinod. After that, we will have 1 hour surgery, and that will be fine, no, sir?
Okay.
What surgery you are planning after this?
You tell me. You have 5 o'clock now, so we have to.
Now it is 4:15, so 5 o'clock you can start.
Okay, let me bring something. Okay, I'll be ready with that.
Okay, 5 o'clock you'll be ready. Thank you.
Okay, boss.
The next topic is an overview on endoscopic skull base surgery by Dr. Vinod Felix. Consultant KIMS Trivandrum.
Respected organizing chairman, secretary, senior colleagues, other delegates. It's my proud privilege and honor to be here to give this lecture for this Magenta conference. I remember MAG sir, meeting MAG sir when I was a youngster, just freshly passed out MS student. He used to come for all the conferences, but I was just a fresher. He used to come to me, how is your practice going? Are you doing good? Every time she saw all this same smile. So that's a fond memories about MAG sir. So coming to endoscopic skull-based surgery, skull-based surgery is undoubtedly one of the most difficult surgery in the human body because the skull base has all these blood vessels, the carotid artery, cavernous sinus, and all the cranial nerves assembled on the skull base. And of course, there are a lot of pathologies in the skull base, and we need to address the skull base to address these pathologies. And coming to the skull base or reaching the skull base through the nasal cavity is not something new. This is a CT scan of 4,000-year-old. The 4,000-year-old CT scan of a mummy, which shows a transnasal corridor was used to approach the skull base. This was done in the mummies to preserve the mummies. They suck the brain out through the nasal cavity, but nowadays the reason why we go to the skull base to the nose is something different. Many may think that endoscopic skull base surgery is just to avoid an external incision or a scar, but that is not the real reason. See, if you have a tumor in the skull base, the two basic principles we use are: one, you avoid crossing the cranial nerves. Sorry. So avoid crossing the cranial nerves. So, for example, if you have a tumor here, it doesn't make sense coming laterally from here, crossing all these cranial nerves and address a tumor here. So, whenever you cross a cranial nerve, you put the cranial nerve at risk. And the second thing, you try to choose an approach with minimal brain retraction. So, for a pituitary tumor located here, the best approach is to come through the anteromedial corridor. You can do that by doing a frontal craniotomy or through the nasal cavity. But by doing a frontal craniotomy, you have to retract the frontal lobe. So the best approach for a tumor here is definitely endoscopic intranasal approach. And the endoscopic intranasal approach, they are divided into sagittal modules and coronal modules. The sagittal plane, you approach a skull base between the plane of the two carotid arteries and between the plane of two orbits. And the sagittal plane consists of approach from the frontal sinus to the C2 vertebra. So this is the sagittal plane modules. You have the transfrontal approach, then the transcribiform, transpannum, transcellular, transclival, and transodontoid. The coronal plane dissection is a bit more difficult. Here we go lateral to the plane of carotid artery. And as is always told, that reconstruction should always be planned ahead. Before planning the surgery, you must think about the reconstruction. Before any exposure, you must have the idea of how to reconstruct the defect. If you have a CSF leak and you cannot reconstruct, the patient is going to die of meningitis. And this topic of reconstruction was well covered by Shivu sir, so I'm not going to touch the reconstruction part at all. And the starting point for all endoscopic skull-based surgery is pituitary adenoma. If we want to start doing skull-based surgeries, endoscopic skull-based surgeries, you must start doing CSF leaks, pituitary adenomas. You must do at least 25 pituitary adenomas, then go to next step. So I think I can spend some time showing the basics of pituitary adenoma, then go further. So this is a scan of a patient, coronal scan of a patient showing with the pituitary adenoma. Here you have the typical snowman appearance. This is a tumor in the cellular cavity. This is supracellular space. And the diaphragm actually compresses the tumor. So that's a typical snowman, a head and a body. And these patients present with visual field defect because the optic chiasm is here. The tumor presses on the optic chiasm. The patient presents visual field defects, sometimes with hormonal dysfunction, and at times with headache also. This is a silent endoscopic anatomy of sphenoid sinus. The intersphenoid septation has been removed here. This is optic nerve, carotid artery, cellular floor, clivus, and this is the lateral optic carotid recess between the optic nerve and carotid artery. So with this basic anatomy, let us see a small 3 minutes clipping of the pituitary surgery. That's a right nasal cavity, middle turbinate, superior turbinate, nasal septum. So once you generally lateralize the superior turbinate, in many cases you can see the sphenoid ostium. That's a middle turbinate, now medialis. The first step is to lateralize the inferior turbinate. You lateralize inferior turbinate, that creates plenty of room. Then you push the middle turbinate towards the septum. And I generally take the elevator with the same elevator I do the ethmoidectomy. Just make a punch incision, dissect the ethmoids from the orbit. That's a very fast technique. It's a nearly unedited video clip. This part is unedited. I reached the posterior ethmoid now. And then with the blood vessel, remove the ethmoid cells, whatever you dissect to remove it. Now push the middle turbinate to the orbit. Because once you remove the ethmoids, you have the extra space to push the turbinate to the orbit. So now you push the middle turbinate onto the orbit. And now we are taking the Haddad flap. The Haddad flap has already been described by Shibu sir. He detailed it very well. So that's the middle turbinate. Till the level of middle turbinate, leave at least 5 millimeter mucosa above, because that's olfactory mucosa. It spare the olfactory mucosa. And that's the inferior incision. You start the inferior incision at the level of posterior tubal fold. That's a posterior tubal fold. Start the incision there. Sorry. Start the incision there. Curve the incision along the arch of Coyana. Take it anteriorly till the mucocutaneous junction. And then you start dissecting the flap, just like you do septoplasty. Once you get in the correct submucoperichondral plane, there is hardly any bleeding. There is no need of any infiltration or anything. Just get in the correct plane, there's no bleeding. Now dissect the flap down. Now you can push the flap into the nasopharynx. Then you remove the posterior septum. That's the other posterior septum has been removed. Remove the anterior sphenoid very widely. You are seeing the pituitary tumor bulging to the cellular floor. And at this step, you must identify the optic nerve and carotid artery. Here you can see this is a carotid artery. This is a carotid artery on the other side. So both carotid arteries are clearly seen, and this is the OCR. Other side OCR. Optic nerve is here and here. Now you drill the entire bone on the cellular floor. So the carotid arteries are clearly seen. I know where I'm making the incision. Now we open the cellular dura now. I generally make the U-shaped incision. And once you make the incision with the help of either two sections or a curette, you can remove the pituitary tumor. And towards the end of the tumor removal, you will see the cellular diaphragm. That's the cellular diaphragm just herniating down. Then you cover with the Haddad flap. So this is the basic starting point for any endoscopic skull base surgery. You must start doing the pituitary first, then go to the next step. Here, after about 25 pituitaries, you go for the next step, which is the craniopharyngioma. The craniopharyngiomas are considered the most formidable of all the brain tumors. And that's how Harvey Cushing described this tumor. It's not an easy tumor. This tumor will be starting from involving cellular, supracellular region, and the third ventricle also. And the third ventricle, you have the thalamus and hypothalamus. If you give a lot of traction there, you can remove the tumor, but the patient will lay comatose. The patient will never wake up because all the higher functions, the circulation, respiration, everything is controlled by the thalamic and hypothalamic regions. So exposure is almost same, but only thing you have to expose a bit more planum here. So the planum is also exposed in addition to the cellular floor. And then you make the dural incision. Now we are cutting through the tumor. Superiorly, you are seeing the anterior cerebral artery. That's the anterior cerebral artery. That is the anterior cerebral artery. You are cutting the tumor from the anterior cerebral artery. There is no role for pulling the tumor here. You cannot pull the tumor because it is attached to the anterior cerebral artery. It is attached to the optic nerve, attached to the thalamic, hypothalamic region. You shouldn't pull the tumor. You always dissect it or cut it away. Whatever is, I'm just holding it and cutting it. I'm not applying any undue traction or undue pull on that. That is a part of tumor going into the third ventricle. That's after tumor removal. You can see the foramen of Monroe, the choroid plexus, the aqueduct of Sylvius, everything very clearly. Then reconstruct in the multi-layer with the fat, fascia, and a Haddad flap over that. And generally, in these cases, we put a lumbar drain also, because once the third ventricle is open, you need to put a lumbar drain. And that's a Haddad flap. Here, the Haddad flap should go into the clival recess. It should stick onto the bone all around. It shouldn't have a dead space underneath, because if there is dead space, the flap can get retracted. When you place the flap like that, then take a cottonwood or a patty or a murosol and place it over the flap. Keep on pressing so that the flap sits on the bone. This is what I told. This place a patty, push on the flap. Now the flap will sit exactly on the bone. And then you progress to cribriform plate. This is actually a tumor in the cribriform plate, an esthesioneuroblastoma. Sorry. So these tumors, we remove the cribriform, we remove the entire bony cuff around. We remove the cribriform plate, remove the perpendicular plate of septum, remove the lamina paprica. So that bony box concept removal is required in sinonasal malignancies. Only then you get a clear margin. Otherwise, if you just remove the tumor, you don't get a margin clearance. So there is an anterior artery. So here we remove the cribriform plate. That is it. You are seeing the dura there. There is a perpendicular plate of septum being removed. And now we have cut the dura. We are going to cut the dura. You're seeing the olfactory filament. That's the anterior nerve. That's not olfactory. That's anterior nerve. There is a lamina paprica being removed. And there is a flap from the other side. And here we have cut the dura. There is a olfactory filament. Olfactory tract. Sorry, this olfactory tract being cut. And we send this for frozen section margins. And then we reconstruct with the flap and the contralateral Haddad flap. So after all this, we then go to the clivals. So we are covered. We start with cella, then start advancing to the adjacent modules. Pituitary, craniopharyngioma, then transcribriform. Then you come to the clivus. This actually is a petroclival meningioma, but this is not an ideal case for clival approach. This actually requires some experience, but then you can start doing the clival chordomas. Here again, you can remove this is the pituitary dura. You remove the tumor from here. Now you are seeing the basilar artery. That's a basilar artery there. We are giving the ICG there. You are seeing the basilar artery glowing up with the ICG. So that is about the brief introduction, brief overview about the sagittal plane. Now let us go to coronal plane. So once you are comfortable with the sagittal plane, you start addressing further. This is the sphenoid sinus. You have the sphenoid sinus here. The sphenoid sinus is here. Once you remove all the bone of the sphenoid sinus, once you remove the bone here, remove the clival bone, you can see this carotid artery like this. So this carotid artery consists of this. This is a segment in the neck called the parapharyngeal segment. The inner ear will be somewhere here. This is the horizontal petrous. This part is called paraclival. This is the cavernous. It's a paraclinodal. And this is the Vidian nerve. This Vidian nerve takes you to the foramen lacerum. So basically for doing the coronal plane dissection, you need to do the transpterygoid approach. So once you remove the posterior wall of maxillary sinus, you have the maxillary artery. This is the greater palatine. This is sphenopalatine artery. And then you have the fat. And behind the fat, you have the maxillary nerve running to the foramen rotundum. So here again, another foramen, the pterygoid base is the Vidian canal. So with the pterygoid base, there is a foramen rotundum and a Vidian canal. Once you find the Vidian nerve and go along the Vidian nerve, they will take you to the foramen lacerum. Mic on. Audio. Good afternoon. Move the posterior wall of the maxillary sinus and the contents of the pterygopods in the back of the pterygopod has been removed in the same. കുഴപ്പമില്ല ഇത് മ്യൂട്ട് ചെയ്യാൻ വിട്ടുതരാം. ഇവിടെ പിന്നുണ്ട്. വരൂ ഇവിടെ കുത്തിയ കണക്ടറാണ് നമുക്ക് പ്ലേ നോക്കട്ടെ. And this here is the Vidian nerve. So the next picture, the right side, maxillary nerve, foramen rotundum, pterygopalatine ganglion here. So that was a surgical exam, anatomy of the pterygopalatine fossa, the pterygoid base, seeing the foramen rotundum, Vidian nerve, etc. You must understand that the Vidian nerve in an endoscopic endonasal approach is a very important anatomic structure. It tells you where the foramen lacerum is. So once you follow the Vidian nerve, that can take you to the foramen lacerum. So the internal carotid artery, it has. So there is a if you work below the horizontal petrous, it is known as the intrapetrous approach. Above the horizontal petrous carotid artery. So this patient has had a lesion. Sorry. This patient had a lesion in the region of Meckel's cave above the horizontal petrous carotid. It's the right side. You are lateralizing the inferior turbinate. You are cutting a part of middle turbinate, and we do a maxillary sinus opening, MMA, and a ethmoidectomy. Spinoidectomy all had been done. That is the spinopelvic artery being cauterized. We don't need a wide maxillary sinus opening in this case. You're seeing the spinopelvic artery now. That is the posterior wall of maxillary sinus being removed. And now we are gently lateralizing the pterygopalatine fossa. Once I do that, you can see that the pterygopalatine fossa is tethered posteriorly at the Vidian nerve. That's a Vidian nerve, and that above you are seeing the foramen rotundum. You can even see that once I lateralize in this patient, you can see that the V2, the maxillary is bulging into the sphenoid sinus here. And you can see the maxillary moving inside the sphenoid sinus once I lateralize the pterygopalatine fossa. This basically is a cholesterol gland or mucosal in the Meckel's cave. The bone between the maxillary nerve and the Vidian canal, and we are removing the anterior wall of the lesion. So this actually is the plane of the carotid artery. You are working lateral to the paraclavial carotid artery. This is the carotid artery. This is the carotid artery. This is the paraclavial carotid. This is the carotid artery. We are working lateral to that. We are working above the horizontal petrous. So that is a lesion there. You are using a ball hook to go. There is a lesion being removed. Dissection on that region. And one. So, as I told you, posteriorly you are seeing the region of Meckel's. See, there is a Meckel's cave and a mesial temporal lobe seen after removal of tumor. Complete removal of the lesion, and there is no CSF leak as it's an extradural dissection. That's the end of the surgery. So, as I told you, if you work below the horizontal petrous carotid, that is not suprapetrous approach. If you work below the horizontal petrous, that is So just now you saw a lesion being removed from this Meckel's cave region. Now we are going to remove lesion from the Petrus apex. Let's say below the carotid artery.
Intrapetrous approach. So the Petrus apex actually lies behind the level of the horizontal Petrus carotid artery. So if the lesion is located, see, you imagine that you have the carotid artery coming like.
See, basically the Petrus apex is just behind this foramen lacerum. Once I drill all this bone on either sides of carotid and push the carotid artery laterally, I'll be on the Petrus apex. So approaching like Petrus apex is a very difficult task. Even if you come from the lateral aspect, you have to go all the way along the temporal bone to the innermost surface.
Right? So lies behind and gently push the carotid laterally off. Have a biopsy, so we thought we'll come through the nasal cavity, do the maximal debulk.
This is a chondrosarcoma involving the Petrus apex from the internal aortic canal all the way to the Petrus apex. So we need to get a biopsy and do the maximum debulking here.
So,
and that's a pterygoid base. That's a right pterygoid base. That's a median nerve.
Sphenoid sinus seen.
This is sphenoid sinus, the median nerve.
Open, and we have already removed the medial wall of maxillary sinus. We have removed we have cauterized the spinopelvic artery. We have lateralized the pterygopalpine fossa, and you are now seeing the foramen. So the Vidian canal. That's a Vidian canal at the pterygoid base. That's a pterygoid base. That's a Vidian canal. We are going to drill around the Vidian canal so that we can identify the foramen lacerum. So we are going to drill on either sides of carotid artery, identify the foramen lacerum, gently push the foramen lacerum to one side and approach the Petrus apex. That's a right sphenoid sinus. That's a pterygoid base. That's a Vidian canal there. That's a Vidian canal. And now we are lateralizing the pterygopalpine fossa contents that bit more laterally. That is drilling around.
This is a paraclaval carotid artery. It's a paraclaval carotid artery.
And we are drilling around the Vidian nerve to identify the foramen lacerum.
There is a carotid artery. Paraclaval, this is a horizontal
There is a carotid artery being mapped with the Doppler. The vertical Petrus, there is a horizontal Petrus. And the suction is at the foramen lacerum. We drilled on either sides of carotid artery. And now we are drilling the petroclival synchondrosis so that the foramen lacerum is unlocked.
We are now drilling the lateralmost aspect of clivus.
And now
pushing the carotid artery laterally. That is
we are lateralizing the carotid artery to approach the Petrus apex. A bit more drilling of the clivus.
Now I am all the way into the Petrus apex. I am removing the lesion with the suction and the curettes now.
That is, we are working exactly behind the horizontal foramen laceral segment of carotid. And the lesion is very fibrous and vascular like a meningioma.
That is almost the region of Indian aortic canal.
Wiser to go for the alternate approach like an anterior petrosectomy, a classical neurosurgical approach. However, this endoscopic approach is good for cholesterol granulomas and some cases like this.
So this is another case of a Meckel's cave schwannoma.
Hi, this is Dr. Vinod Felix, and this is a case of Meckel's cave schwannoma. We are going to do this with endoscopic suprapetrous approach. We are going to drill the quadrangular space, which is a space bounded by the vertical and horizontal petrous carotid on one side.
This is the quadrangular space.
V2 and 6 cranial on the other side. That's a quadrangular space on the PAP on the side. There's a right quadrangular space being drilled. So we are going to drill lateral to the paraclaval carotid, both the horizontal petrous carotid, and medial to the V2. And of course, below the cavernous sinus.
The same picture is being exposed here. That's a carotid artery. This is a quadrangular space.
There is a quadrangular space. And now, after properly identifying the carotid We are going to open the dura.
Now we are opening
There's
this
a dura
one.
being opened. And now that's a tumor. There is a tumor in the Meckel's cave. This tumor is predominantly in the middle portion with a slight bulge to the posterior portion. There is some internal debulking of the tumor. There is a tumor being delivered. Once you deliver the tumor, you have the CSF leak. Then there's a small.
That leak you can just plug some fat and put the hard art flap. So there is no worry about the endoscopic, sagittal and coronal plane approaches. So you can start with the pituitary, then start going further, start doing coronal plane. And this is a challenging field. I think you'll be seeing some more cases from Satish, sir. So thank you once again, organizers. Thank you.
Thank you, sir, for your remarkable speech. You have taken us through a wonderful journey to the skull base.
Thank you.
Thank you, sir. Any questions from the audience?
I was making this presentation yesterday, and my son was 10-year-old son was sitting along. He was saying that, see, you're speaking about mummies and a snowman. I know all these things. This is what you're going to speak to the ENT colleagues.
Thank you, sir. Next, we are continuing with
one more surgery to follow. Sir is planning either submandibular dissection or glomus tympanicus. Sir is preparing to take 5 minutes, but there will be one surgery more.
Hello.
Yes, sir.
Yes. Am I audible, sir?
Yes, definitely.
So coming to the final session of the day,
Yeah.
We are starting something with the paragangliomas. We may not finish completely today because 6 o'clock we have to go for a condolence meeting of Dr. Archana Sharma. So we have 1 hour's time. Okay?
Yeah, we'll have.
So paragangliomas, we all know, are vascular tumors. And to the variety of paragangliomas in the head and neck.
I invite Dr. Vinod Felix and Dr. Santosh to chair the session.
Yes.
Hello.
Hello.
Good evening, sir.
Good evening, sir.
I'm Dr. Santosh, head and neck surgeon.
Yeah. Yes, yes, sir.
Okay, sir. You can proceed with
So,
surgery.
do we go ahead?
Yes, sir.
So, as I discussed, paragangliomas are important, challenging vascular tumors. And in head and neck, there are a variety of paragangliomas, arise. Those arise from the temporal bone or temporal bone paragangliomas, further classified as tympanic paraganglioma or jugular paraganglioma, from where they arise from. Those arise from the tympanic plexus in the middle ear are tympanic paragangliomas or glomus tympanicum. And those arise from the glomus bodies on the dome of the jugular bulb are jugular paragangliomas, or known as glomus jugular tumors. Then those arise from other parts of the head and neck like glomus bodies at the carotid bifurcation as carotid body tumors, on the vagus nerve or vagal paragangliomas. So there are a variety of paragangliomas arise from the head and neck. And today we are starting our discussion with the temporal bone paragangliomas, which are subdivided into two categories, the tympanic as well as the jugular paragangliomas. And these temporal bone paragangliomas are further classified. Yes? Hello? Hello?
Sir, you can proceed. You can proceed. Hello?
Yes?
You can proceed, sir.
Okay. So the temporal bone paragangliomas are further classified into various categories. And this is a very clinical classification initially proposed by Hugo Fish and then, further modified by Professor Mario Sana. So there are class A, B, C, D, E, V. There are a variety of classification systems exist. From this modified Mario Sana classification, class A and B are tympanomastoid paragangliomas. Paraganglioma is the appropriate term than the glomus tumors. It has been, widely accepted now. So class A paragangliomas are commonly known as glomus tympanicum tumor, which arise from the tympanic plexus on the promontory, glomus bodies and the tympanic plexus on the promontory. So they are further subdivided into A1 when you see the complete tumor on otoscopy with all margins visible. And tumors which the margins are not visible going either in the eustachian tube or in the aortic or somewhere else behind are A2 tumors. Class B are the tumors which extend to the tympanomastoid compartment and the hypotympanum. So B1 are the tumors that are still confined to the middle ear cleft but extend inferiorly into the hypotympanum. B1. Why this classification is clinical? Because your surgical strategy is based on the tumor extent. So B1 are the tumors still in the middle ear cleft but extend inferiorly into the hypotympanum and they require a little extensive approach. B2, along with the hypotympanum, they extend to the mastoid behind. And B3 is a new category defined by Mario Sana from the surgical point of view, when the tumor further extend anteriorly with erosion of the carotid canal. There's a different category which require a different surgical strategy. Now, why that A1, A2, B1, B2, B3 divided? What is the surgical clinical significance? A1 are the tumor you can simply remove by the transcanal approach even. Elevate the flap, tumor is completely visible on the promontory from all around. Just coagulate the tumor and the tumor vessel and come out, transcanal. A2 are the tumors when they are beyond the visibility of the tympanic membrane, maybe extending into the aortic commonly or in the eustachian tube. They prolapse into this is important to understand, they arise from the promontory. So once they grow bigger, they prolapse either anteriorly into the eustachian tube or prolapse superiorly into the aortic, but they do not have any attachment anywhere in the aortic and eustachian tube. This is important from surgical point of view, as they do not have any attachment there anywhere besides the promontory. So what you need to do? Coagulate on the promontory, coagulate the vessel on the feeding vessel from the promontory, which is coming from below. Coming from the hypotympanum is a branch of ascending pharyngeal as an inferior tympanic artery to supply this. So coagulate the attachment on the promontory, coagulate the vessel on the promontory, and then pull out the tumor from the eustachian tube, pull out from the aortic, pull out from retrotympanum, anywhere. So that part is only pulling out, as that doesn't have any attachment. This is important. So this kind of tumor, A2 tumor, you need a little bigger exposure. You can go post-oral, raise the flap, push it anteriorly and remove it. It requires a lot of coagulation. Sometimes your flap may get damaged, your tympanic membrane can get damaged. The other strategy is to make the tympanomeatal and the tympanic membrane free, put outside in the saline, remove the tumor and replace it back. So entire cuff can be removed and replaced back. That is another strategy for A2 tumors. Now tumors which are B1, which is extending into the hypotympanum, you need to drill the bone covering the hypotympanum a little bit, or you go from behind, make the facial recess approach towards the middle ear and extend it inferiorly lateral to the facial nerve in the hypotympanum by sacrificing the chorda tympani. That is extended facial recess approach towards the hypotympanum. So now you have two axes, from the middle ear side and from behind by the extended facial recess approach to deal with the hypotympanic part. That is for DB1. For B2, tumor extending into the mastoid obviously require, besides the canalicular approach, you need a cortical mastoidectomy and remove the tumor from behind along with the aortic and the middle ear part from anteriorly. So that's a combined, like a mastoidectomy approach, you can say, for B2 tumors, according to your convenience, according to the extension, according to the experience, you can choose a canal wall up or canal wall down approach. See, this is not a chronic disease, and most of the patient can be very well managed with a canal wall approach. By making the canal wall thin, you can remove a part of the canal wall somewhere and reconstruct it. That is the best approach for B2 tumors. So these are all tympanic paragangliomas. Now the B3 is a category of tympanic paraganglioma which is more extensive, which involves the carotid canal. Exposure of the carotid canal, drilling of the bone around the carotid canal or drilling of the bone of the carotid canal may compromise the eustachian tube function later, and it requires a lot of exposure with drilling of the bone of the eustachian tube around to deal with the tumor on the carotid artery. Require more exposure around the carotid artery, more drilling of the eustachian tube and all that, and these tumors ultimately requires a subtotal petrojectomy obliteration to rule out the need of the eustachian tube function in future. So this is more extensive, require more extensive exposure, more extensive surgery, that is subtotal petrojectomy obliteration for these tumors. So that's how this is a very, very clinical classification where the tumors have been divided into various categories according to the according to the need of the exposure, need of the change in the surgical approach. Then, like, see this. This is a tumor. You can call it as a tympanicum tumor, A2 category tympanicum tumor. Can you see this tumor? The tumor is beyond the confines of the otoscopic examination. Can you see?
Yes, yes.
Yet it is limited to the promontory and prolapsing into the eustachian tube. It is not eroding the jugular bulb at all. So this is tympanicum, this is tympanicum, and this is type AB tumor. So A1 transcanal, AB, A2 a little bit better is post-oral. Now for type B tumor, where the tumor extends to the mastoid. See this, many a time such tumor present with CSOM with a polypoidal mass coming out of the canal. And the surgeon can be, sometimes, get confused, and these tumors are mistaken as, a CSOM with polyp cases, because we generally don't get a CT scan done for CSO cases, and this tumor required for diagnosis a contrast CT scan for that matter, with confirmation of the jugular bulb intact and tumor limited to the tympanic and mastoid cavity with the carotid canal good. So these are type B tumors. Glomus mastoidalis is also a common name to these tumors, and this is the category which is most often diagnosed as a surprise finding while doing a mastoidectomy. We get many of the patients where the surgeon operated for the mastoid, assuming a CSOM with a polyp, and it turned out to be a vascular tumor inside, and this is the type. And this is type B, which requires a mastoidectomy approach for this tumor. Mastoidectomy approach for these tumors, according to your experience and facilities and all that, either canal wall up or canal wall down approach. So now what is C tumor? C are the category of the tumors where the tumor arises from the jugular bulb. See, those are the glomus jugular tumors where the tumor arises from the dome of the jugular bulb. Jugular bulb is in the jugular foramen. Anterior to the jugular one is the carotid artery, and these tumors frequently involve the carotid artery. Frequently involved means they are categorized according to that. The C1 are the tumors which they involve the carotid artery and the carotid foramen. C2 are the tumors which involve the carotid artery further, much more than the C1, and the entire vertical petrous cord of the carotid artery is involved. Those are the tumor. Jugular tumors, jugular paragangliomas extend anteriorly to involve the entire vertical petrous course of the carotid artery are C2. C3 are much extensive where they extend to involve the horizontal portion of the carotid artery. Horizontal portion of the carotid artery doesn't have adventitia. These are more, challenging tumor to separate from the carotid artery. Carotid might rupture otherwise if you are not careful. So these are more extensive tumor, and see, for C1 and C2, you require the approach is a different one wherein you need a full exposure of the jugular foramen, carotid artery at this level, and Fish has, described the infratemporal fossa approaches. This is infratemporal fossa A approach wherein, the reason is the facial nerve crosses the jugular foramen. So you need to transpose the facial nerve. That's a part of the infratemporal fossa approach, type A. The transposition of the facial nerve anteriorly. Facial nerve comes out of the, the geniculate ganglion. Then it becomes the tympanic segment, then vertical, then it goes out of the stellomastoid foramen into the parotid. So here it is transposed right from the geniculate ganglion right directly into the parotid. Elevate the entire tympanic and mastoid segment and transpose it anteriorly to expose the jugular foramen, which is immediately underneath the facial nerve, and then you can deal with this tumor much more effectively. The facial nerve is an important anatomy, and you have to preserve the facial nerve, which is the integral part of this, surgery. That is infratemporal fossa approach. And then you go into the neck, define these vessels, control these vessels, control the cranial nerves, and then along with the jugular bulb, these tumors are removed. So these are more extensive approaches we'll discuss tomorrow, most likely. So these are infratemporal fossa A approach for C1 and C2. And when it goes beyond further anteriorly, right to the foramen lacerum, C3 involving the horizontal segment, now this requires more anterior exposure. Unless and until you remove the TM joint, separate and push it anteriorly, inferiorly, you cannot expose the entire horizontal segment of the carotid artery, and that is termed as infratemporal fossa B approach by Hugo Fish, wherein you go more anteriorly to expose the horizontal portion of the carotid artery right up to the foramen lacerum, and which is limited by the TM joint laterally. So you need to disarticulate the TM joint, go inferior, push the TM joint inferiorly, anteriorly, and expose the bone over the carotid artery completely to take a complete control of the carotid artery. The issue is, once tumors involve the carotid artery, you need to have an approach which can control the carotid artery to prevent a disaster, and that is how the infratemporal fossa B approach is used for C3 tumors, and C4 are the tumors which go beyond the foramen lacerum. They involve the cavernous carotid artery and further, and these are most complex tumors for which you require more anterior approaches to expose these areas and more extensive approaches. Similarly, the class D are the tumors. See, you can pick up just an example how to pick up which part of the carotid artery is involved. How to classify C1, C2, C3, C4 the tumor. See, this is carotid foramen on axial CT scan. That's the carotid foramen. Vertical, see the cut of the carotid where it enters the carotid foramen. Then the carotid canal, vertical petrous in the axial section. Vertical petrous in the axial section. Now it is becoming horizontal petrous. Horizontal petrous carotid. A tumor here involving which portion of the carotid you can accordingly classify that it is C1, C2, C3. Horizontal carotid, horizontal carotid. Now the foramen lacerum carotid. See foramen lacerum, the sphenoid sinus anteriorly, and that is how if tumor goes beyond it is C4. So that's how one can easily, classify the tumors according to the which part of the carotid artery involves C1, C2, C3. Once it involves the horizontal, see the horizontal portion of the carotid artery is involved by the tumor, and we need to take the horizontal carotid in control. And see, this is the TM joint. TM joint is, lateral to the horizontal carotid. You need to displace the TM joint and expose the entire horizontal course to tackle this. And C4 are the tumors which even go beyond to involve the lacerum portion. Then for the D tumors, D are D means tumor with intracranial extension, maybe extradural, intradural, 1 centimeter, 2 centimeter. This is important clinical classification again, because if tumors is going intracranial more than 2 centimeter, it is difficult to remove at the same time. Even if you remove the controlling the CSF is a big problem, because in infratemporal fossa approach, you remove the tympanic bone, the neck comes in continuity with the temporal bone all the way. All the fibrous tissue separating the temporal bone from the neck is removed. And if there is a more than 2 centimeter defect in the brain there, controlling that CSF leak with no, fibrotic tissue at the level of the lower part of the temporal bone separating from the neck is difficult to hold the tissue to control the CSF leak. And then it has been advised to, stage the tumor removal once you have a big intracranial extension. Nowadays, we have changed our strategy. Now we have removed even bigger intracranial tumors in the same stage using the flap reconstruction to prevent the CSF leak. So as the science is evolving, surgical science is evolving, reconstruction abilities are improving, free flaps are coming, we can remove even the bigger tumors at the same stage. Then other category, Mario Sana divides the V category where the vertebral artery is involved or not, and if vertebral artery is involved is a massive tumor, massive category, and controlling the vertebral artery and removing the tumor from the vertebral artery is the most difficult aspect. And you have to extend your approach to the far lateral approach, which can control the entire course of the vertical extracranial vertical artery, and still those tumors can be removed. So according to the tumor, extensions, according to the situations, you need to take the tumors into control, and this is how the strategy is devised for which tumor, which kind of a surgical approach is required. So this is important. Another thing important in the glomus tumors is to get an angiogram done. Once you have a CT scan or MRI to define the tumor extension strategy, everything, MRI is very, very diagnostic to give you, soft tissue relationship. The next step is to get an angiogram done, at least a CT angiogram, to see if there are any multiple paragangliomas in the head and neck, which is not uncommon. If it is, the angiography can easily identify those multiple paragangliomas. And in that situation, it is very, very important. Angiography gives you a lot of information about the feeders. These are vascular tumors, and bringing the vascularity under control is the biggest challenge to the surgeons, So how to, do this challenging work? This angiography will tell you which vessels are involved and supplying the tumor so that you can control those vessels on table surgically and obviating the need for the embolization. In our series, we rarely get these tumors embolized. Or angiogram clearly shows which vessels are supplying to the tumor. On CT angiogram, we can trace each and every vessel entering into the tumor, and we can control. As we always open the neck, external carotid branches are the main feeders. Internal carotid feeders can be there once the tumor massively involves the internal carotid artery. And so most of the time these are the external carotid feeders which you can control intraoperatively by knowing the information from the CT angiogram. So surgery is obviously the gold standard for these tumors. Observation is for elderly patient with minimal morbidity, obviously, and radiation is never a treatment, rather to control the tumor by inducing the fibrosis in the vessel supplying the tumor, to contain the growth of the tumor, and reserved for certain category of patients like elderly patients who are unfit for surgery, who refuse surgery, or inoperable tumors, very, very extensive tumor, like tumor invading the brain tissue, tumor invading the cavernous sinus, tumor involving the vertebral artery, or its branches like pica or ica in the brain, which are, cannot be, sacrificed, otherwise can lead to brainstem infarction. So those are the tumors wherein the radiation is used as a model, I would say, as a model to control or contain the growth. Then obviously massive tumors operated, you're left behind some tumor, because of the morbidity, risk of the morbidity, or recurrent tumor, aggressive tumor, whether further surgery is not possible or refused by the patient, or the patient whether radiation is used, but it is not the preferred treatment. Treatment is, the gold standard is surgery. For tympanic paraganglioma, surgery is the only answer, not even radiation. Even for the elderly patient, you can remove because that surgery is not so mutilating. It can be considered if the patient is anesthesia fit, even in the elderly patient. But for jugular paragangliomas, you have to take a call whether to observe, radiate, or surgery. But if possible, particularly in young patients, surgery is the gold standard. Elderly, you have to take call according to the fitness and the patient factors. And this is the area where this tumor arises. Jugular, this tumor can grow superiorly into the hypotympanum, grow anteriorly to involve the carotid artery, grow inferiorly into the neck, grow medially to invade the cranial nerves and the brain. And so those tumors which are already gone into the brain, it is difficult to preserve the lower cranial nerves. Mostly they may be paralyzed preoperatively, or difficult to sacrifice preserve intraoperatively as well. So there are situations where these tumors need to be, decision making is important in tumors, when to operate, when not to operate. Yes, when already the cranial nerves are paralyzed, is a straightforward indication for surgery and not going to give any further harm to the patient. But yes, when the cranial nerve function is intact, then decision making is required. And those are the patients where you need to take a call according to the patient's counseling, patient preference. And these are the most difficult cases, young patient with cranial nerve function intact, yet a huge paraganglioma, which is going to, some point of time, otherwise going to involve the nerves. Sometimes the most unfortunate situation for the surgeon is, many a times, facial nerve function is normal, lower cranial nerve function is normal, and once you explore, you find a tumor involving these cranial nerves which need to be sacrificed. And that is so difficult to counsel your patient also, because the cranial nerve function is intact, clinically intact, yet involved by the disease, and you need to sacrifice and take a call intraoperatively. So that is, you need to tell your patient up to 10% of the patients may have clinically normal functioning cranial nerve, yet the cranial nerves are involved, and you have to take a call accordingly in those patients. So finally, let me take you through the surgical video of glomus tympanicum, and tomorrow we'll discuss the jugular and the other tumors. So tympanicum are the tumors which arise from the, as I said, from the tympanic plexus on the promontory where the glomus bodies are there, and those are the tumors. You can remove the postoral if it is a A2 tumor. And before going to this was to show you how the facial nerve bisects the jugular bulb. Why the facial nerve transposition is required for the jugular tumor. Let me orient you with this picture. First, see, this is the ossicular chain. This is the middle ear here anteriorly. This is posteriorly. This is the sigmoid sinus going to become the jugular bulb here. And this is the labyrinthine block. And this facial nerve horizontal coming from here, genu, and the vertical course going towards the stylomastoid foramen. This nerve crosses the jugular bulb in the middle of its course. It bisects the jugular bulb laterally. And if this part of the face, once you deal with a huge vascular glomus jugular tumor, this nerve has to be reflected. Otherwise, this won't allow you to work, or otherwise get injured. Otherwise, we'll get injured intraoperatively. So the idea is, this is the level of the first genu. This entire course of the nerve is elevated till the parotid, and this nerve is anteriorly transposed, and this area is made free for the for the dealing in the jugular bulb. You can see by this picture, this is the nerve and this is crossing the tumor. If the nerve is crossing the tumor, you can't handle this tumor so effectively. So what you need to do is transpose this nerve right from the first genu, and this tumor can be dealt with so easily. So that is called anterior transposition of the facial nerve in those situations, and you can deal with this glomus jugular. So we have two kinds of tumors to demonstrate you: the glomus jugular and the glomus tympanicum, or a tympanicum or a jugular paraganglioma, whatever you say. And in a couple of minutes, I'll be starting. I have downloaded this. I'll be starting this jugular tumor from the cloud. So I am starting this jugular tumor now. Tympanicum, tympanic paraganglioma, in a couple of minutes, in a minute or two. It's already come.
Hello.
It will take a minute or two to start. Meantime, any questions now before you proceed for paragangliomas? Anything?
How often do you see such cases?
How often
do you see such cases? How often do you see such cases?
How often?
Yeah.
Quite often. Every week we do some or other paraganglioma surgery. Every week almost. And more and more extensive cases we see. Tympanicum are rare to us. Yes, but jugular with massive extensions are not uncommon. The reason being, these patients are not diagnosed earlier in the case. We don't have a habit in India to diagnose, to do imaging often for symptoms, and mostly our cases we follow on the clinical ground, and these patients, ultimately diagnose at a later stage because they are painless, slow growing, and not so easily diagnosed early in the course.
And
so,
sir, clinically, when will you suspect that it is paraganglioma or glomus jugular?
Can you speak a bit louder, sir?
Clinically, when will you suspect that it is glomus tympanicum?
Glomus tympanicum?
Yeah.
So tympanicum you can diagnose easily on otoscopy with some reddish hue behind the tympanic membrane. Number one, with patient presenting with conductive hearing loss most often, and also with the tinnitus, because these tumors grow, once they grow from the promontory, they come in contact with the ossicular chain and give tinnitus. Pulsatile tinnitus is a classical symptoms when these patients come in contact. The patient which I am going to show you is the one which was, with the patient presented with a classical pulsatile tinnitus. He was not bothered with the hearing loss, but the pulsatile tinnitus, and it was completely engulfing the ossicles from all around. So this is how they present tympanicum very often. And one of the major presentation of this tumor. Since otherwise they are painless, the hearing loss is very mild initially because they do not erode the vesicles, ossicles so easily. They occupy the middle ear space, they reduce the middle ear space, they occupy the eustachian tube. But once they start giving tinnitus, is their major presentation, and which is something bothersome to the patient. For jugular, their presentation is variable. As I showed you on this slide, their presentation for jugular is variable. Yeah, this one. Yes. See, the jugular present, the way they spread and involve some important areas. Like for example, I tell you certain funny examples. Patient coming to us with a sole unilateral vocal cord palsy. No other symptom. There is a policy in unilateral vocal cord palsy patients, particularly in young patients, to rule out any tumor along the course of the vagus nerve. So right from the head, neck and chest CT scan is a common policy, to order in patients with a unilateral vocal cord palsy. We have patients presented solely with a vocal cord palsy, nothing else, and it discovered a jugular paraganglioma. Patient had hearing loss a little bit, patient had a tumor going above, but hardly anything, it didn't bother, and solely present with the vocal cord palsy. So it depends upon where the tumor is extending. If the tumor is extending preferentially above, it occupies the middle ear, it occupies the external, comes to the canal, extra-auditory canal may present like a CSOM. So it depends how the tumor is progressing, in which direction. We had a patient who presented with oral bleeding, wherein the tumor came through the eustachian tube all the way in the nasopharynx and hanging down in the oropharynx. So it depends which direction the tumor is growing, accordingly they present, So their presentation depends upon their extension. And similarly, their vascularity they acquire according to their extension. If the tumor is extending more towards the mastoid behind, they acquire occipital artery as a major vascularity. If the tumor extend inferiorly down into the neck from the jugular foramen, they're mostly or limited to the jugular foramen, mostly the ascending perennial artery, which is the main vascularity. Tumor going high up anteriorly and superiorly, they acquire additional blood supply from the middle meningeal artery. So tumor extension is the key thing which is dictating the symptoms, vascularity, their surgical approach and everything. That's why the CT scan and MRI together are the important investigation for all the decision making. Any other questions? We are starting in a minute, otherwise.
Sir, have you seen any sarcomatous change after radiation in glomus?
Glomus we haven't seen yet, but yes, we have seen malignant glomus. I can answer it the other way around. We have seen malignant glomus tumors. Now, this definition of a malignant glomus tumor is different. It is not histological definition. Malignancy in glomus tumor cannot be confirmed on histology. It is diagnosed on the basis of metastasis. If you have lymph nodes or any distal area, it is found to be a paraganglioma. In a case of jugular paraganglioma, it is considered metastatic. That's why in glomus jugular surgery or jugular paraganglioma surgery, it is always, advised to do a sampling of level 2, 3, sampling of all those nodes in the area of level 2, 3, or limited selective neck dissection to rule out anywhere this tumor metastasizing to the neck nodes. Otherwise, your histology doesn't, diagnose the malignant glomus tumor as a malignant one. It is the spread to the lymph nodes or the distal areas is the way to classifying them malignant. Yes, your question about the sarcomatous change after the radiation, we have seen in JNAs. We have seen 2 cases of JNA. It came to us with a massive multiple surgery done, radiation done, and finally turned into sarcomas. So angiofibroma turning into sarcomas, we have seen, but not yet. The glomus or paraganglioma, we have not seen turning into sarcomas. But there is a theoretical possibility always. Yes. Any other questions before we?
Sir, hello, sir.
Yes, yes, please.
Sir, MRI is primarily done for characterization, right? For this tumor.
No, MRI is for many reasons, I tell you.
Okay.
See, MRI gives you soft tissue details. MRI has a ability of, is a versatile one because of ability of giving so many sequences. MRI with its ability to pick up flow voids. Flow voids is for vascular lesion. Lesion in the jugular foramen with flow voids is quite diagnostic of a paraganglioma, jugular paraganglioma. So MRI is not only for the diagnosis, MRI is most important for relationship with the surrounding structures like the intracranial space. See, this big glomus tumor going intracranially, relationship with the vertebral artery, relationship with the brain tissue, whether truly invading the brain or extradural, this can be best picked up on MRI for differential diagnosis. And with the MRI has the additional ability to do MR angiography that is non-invasive. CT angiography is invasive. MRI can give MR angiography you can do, that is non-invasive investigation, additional investigation without any, not an invasive investigation, and it can give equally good information for the vessels supplying the tumor. So MRI is versatile. It gives the best relationship with the carotid artery, where the carotid purse is invaded, where the periosteum, the periosteum of the carotid is involved, and all the vessel has a luminal, narrowing with the carotid tumor. So MRI gives you amazing, details when tumor goes beyond the confines of the jugular foramen, particularly to involve the deeper areas, brain, surrounding areas, carotid artery, all those things. So MRI is useful. We always order, not for tympanic. Tympanic, you can get away with the contrast CT scan and clinical finding, but for jugular, we always add along with the CT scan a contrast MRI with MR angiogram. And if carotid is involved at any point of time, it is always good to get a DSA done, digital subtraction angiography, because once you are dealing with a tumor involving the carotid artery, you need to have a full information about the cross flow studies at the level of the brain. You need to have a full information about the vessels supplying the feeders from the carotid artery internal system, because more and more feeders from the internal system makes the life more and more difficult for the surgeon. And cross flow at the level of the brain, that determination is very, very important. Reason being, if you are dealing with a carotid and in any given situation, the carotid is, lacerated and need to take a call of something, some intervention, the cross flow studies are useful in any given unfortunate situation. If your cross flow is not good, you cannot sacrifice the carotid artery. So that is very, very important. So, to deal with the carotid artery and have this information beforehand. Nowadays, with the advancement in the surgical thing, there are a lot of maneuvers you can do to preserve the carotid artery. You can mobilize the carotid artery, transpose the carotid artery. Like I had shown the carotid artery as a vertical and horizontal course. Horizontal is laterally, lateral relation with the TM joint. If you do an infratemporal fossa B approach, you can entire, this tumor, if involves the petrous apex and deeper, you can transpose the carotid artery completely, the vertical and horizontal segment anteriorly, and drill away the bone underneath the petrous apex bone completely to remove the tumor from that area and going a deeper one. So transposition can be done. That's a major advancement in the surgical technique, but angiography is must, because in any given situation, you may have to sacrifice the carotid artery to save the patient, and then this information of cross flow is very, very important.
Hello, sir.
Yes.
Sir, any experience of yourself or somebody else missed the diagnosis and taken a biopsy?
This should never be done. Yes, your question is valid, but yes, we have seen, we got some patients. The effort was a surgeon. It was I would say, a surprise diagnosis wherein the biopsy was taken, not a planned biopsy. So like mastoid surgery was done and discovered a glomus tumor, vascular lesion, and the surgeon biopsy turned out to be paraganglioma. So that was a surprise biopsy, not a planned biopsy, because this diagnosis is based on the radiology and presentation and, extension. This is a classic, presentation and pathway of extension for these tumors. And the characteristic vascularity and all these things on MRI and MRI angiogram will diagnose it most of the time. So you don't need, or you never need, I would say, biopsy for diagnosing these tumors, to be very specific.
Actually, in Mariosana courses, he always quotes an example where a student biopsied a carotid aneurysm which is bulging through the ear canal, and the patient died on table.
Oh,
and he always says that he was never biopsy a mass in the ear canal without taking a scan.
Yes. So never take a biopsy from any, such masses without having a complete information about that. And obviously, radiology is life-saving. Radiologists must, before taking biopsy from such vascular looking like tumor, particularly from the deeper areas. We have seen carotid aneurysm, a chance finding in a patient with a CSOM or the petrous carotid aneurysm that was not so big, but finding aneurysm in the case of, CSOM was terrifying, and you are not supposed to do anything but to refer such patient to the intervention radiologist. This is their domain, but obviously never ever take a biopsy. Dr. Vinod Felix is right, from such vascular looking like masses from the depth without a complete radiological background information. Any other question for a minute or so?
Sir, can we show surgery today or postpone to tomorrow?
Let's see, because of 6 o'clock is approaching for that meeting and the medical college.
That's why. Only 20 minutes now. Now, even if you start,
So do we cover both the tympanicum and the jugular tomorrow?
Yeah. We'll show surgery only tomorrow, right? By 9 o'clock?
We can do that if you are okay.
Yeah. That will be better, I believe. Now, only 20 minutes you have to go. And
So we have 20 minutes. We can make it a question answer or some kind of a session for what we have discussed today, for all the cases.
Okay.
Stepidotomy, tympanoplasty, and sinus surgery. We can discuss those important things, and I wanted to throw light on certain issues on sinusitis as well. Which are rarely discussed, which a surgeon must know, because it's not a surgical part. The decision making is equally important.
So one doubt, sir. Today morning we discussed so many investigations before proceeding with stapedectomy.
Yes.
So how do you approach a patient who comes to you with conductive hearing loss and intact tympanic membrane?
Yes. So audiogram, tympanogram, and the clinical findings, the history and all that. If it is a pure conductive loss with a intact tympanic membrane, it obviously the first line diagnosis goes in favor of otosclerosis, particularly more confirmative, particularly if it is a female patient with bilateral loss. It is more corroborative, In case any difficult otological, audiological or vestibular symptoms in general, you can get a scan done. Our policy is always to get a scan done nowadays once you suspect otosclerosis, conductive hearing loss of unknown origin. CT scan will rule out other diagnosis, and you can assume otosclerosis more, confirming, I would say. It's not the CT scan is required to diagnose otosclerosis, but it will rule out other causes of conductive hearing loss to diagnose the case as otosclerosis.
is there any difference in the way if it is unilateral and especially a younger child?
See, it is bilateral. Still, the etiology is not known, but sometimes one side is more progressive and become clinically manifesting as compared to the other side. But it is mostly bilateral. Unilateral cases, yes, do come. Can't explain the reason behind that, but yes, unilateral autosclerosis is not uncommon, I would say. And there could be cases of autosclerosis in spite of having other ear absolutely normal. We can't rule out.
There are a lot of comments in the website, around 66 comments about today's program. One person asked about doing MRI in stapes autosclerosis. He was asking, will you do MRI in all patients, or how do you select patient for MRI pre-op? That was his question.
Yes. So there are various reasons to dictate MRI. First of all, any patient presenting with any vestibular symptom, it is better to get MRI done because there could be some subclinical hydrops going on. Number one. Secondly, more demanding patients. Because there's a standard consent, uniform consent for autosclerosis surgery that in spite of the best efforts, up to 1% patient may develop sensory neural loss. Your hearing can worsen or even dead ear. You have to tell every patient sound and clear, absolutely clear, that up to 1% is beyond your control. Still, patient wants to know, don't want to get surgery done, you can give them option to get MRI done to rule out subclinical hydrops. That will clear that the chances are there or not. I mean, you can cover up to some extent. Number two, any abnormal audiological vestibular symptoms. Number three, for patients with sensory neural hearing loss. Patients with sensory neural hearing loss who had already got CT scan done with cochlear autosclerosis, to be kept on medical therapy, your MRI can be a useful tool to initiate and monitor the medical therapy, whether it is working or not. So the 3D flare sequence and the contrast one of the MRI can be the most useful investigation to initiate and monitor the medical therapy for those patients.
So you did a good stapedectomy. Put piston, everything went on very well. Unfortunately, post-operatively, you find that there is SNHL. How do you go about it?
It depends upon the timing. It depends upon the timing, the immediate audiovestibular symptoms and the late appearing symptoms. There are varieties of the ways it presents. Like, for example, you operate and patient develops severe vertigo and sensory neural loss immediately after the surgery in a day or two. And there could be reasons behind it. First, always is a conservative treatment. Always is a conservative treatment with the vestibular suppressant and all that, steroid, antibiotics. And if it doesn't come under control, then is the indication for imaging to rule out perilimb fistula, to rule out overlong piston, to rule out any labyrinthitis which is set in. And in late appearance of the sensory neural loss, the causes are generally different than these immediate causes. There could be a reparative granuloma setting in. There could be a persistent perilymphatic fistula, or that could be an autosclerotic foci involving the progressive autosclerosis foci or whatever. So for delayed hearing loss is a different scenario, or immediate hearing loss is different scenario. Similarly, the indications for explorations are different for both the things. For immediate region, the only indication for surgery is an overlong piston. Remove the piston, seal the fistula, and put a appropriate size fistula. For delayed, such sensory neural hearing loss is never an indication for a revision surgery in delayed setting. Only if it is progressive sensory neural hearing loss and vestibular symptoms along with, then only the indication, because with revision surgery, you are not going to improve the sensory neural loss. You can stabilize it or you can stabilize the vestibular symptoms. So in revision surgery, in a delayed, presentation of sensory neural hearing loss, the indications of surgery are there if there is a confirmed perilimb fistula or if there is associated vertigo, dizziness, whatever. For alone sensory neural hearing loss, no reoperation is indicated because it's not overall going to improve the hearing. We have case ready to demonstrate tympanicum, but time is 10 minutes only.
We don't have any problem, but for you,
I know. Time is the limitation. And another thing I wanted to discuss, we had two questions. We are also getting online questions here.
Okay.
So Dinesh, so one was asking about the details of the topical therapy. After the sinus surgery, a lot of people have confusion about it. What kind of topical steroid and how you can introduce, what is the dynamics, how you can improve this overall topical therapy. So topical therapy, see, the aim is to deliver the steroids deep into the sinuses so that it obviates the need of oral steroids and yet without systemic side effects. That is the goal. Now, for proper introduction of topical therapy, optimal introduction, there's so many factors involved, the delivery techniques, how you deliver, the delivery device, what you use, then how much volume do you need to use, how much pressure, position of the patient, this is very important to allow the steroid to penetrate everywhere in all sinuses, then what kind of a cavity you have given post-operatively, and what is the anatomy of that region, how the openings are narrow, wide, DNS, so many things. So everything has an impact on the overall optimum topical therapy delivered post-operatively to the sinus cavity. Now, first of all, position. The position should be that the solution should reach, the challenge is always to the frontal sinus and the olfactory region. So there are two positions which have been advised, which allow the solution to reach effectively to the frontal sinus and olfactory region. Because whatever position otherwise you use, it reaches the maxillary and the sphenoid sinus. The challenge is to deliver to the frontal and the olfactory region, which is strategically located at some angle, difficult angle. So this is head down forward position. You can easily train your patient. This is also called as a Namaz position, wherein the patient has to bend down on the knees and put the head down on the floor, and then you deliver your solution. It reaches to the olfactory region and the frontal sinus much better. And another position is a head down, lying head back position with some extension, so it allows you to reach high up into the frontal sinus and olfaction. Depending upon the patient age and other factors and the comfort and all, you can advise any of these situations which allows the penetration of the topical steroids better into the solution. Now the device, literature shows so many devices, you'll find the neti port, collapsing these vessels, tubes and all that to deliver. Actually, it should be a high volume, high pressure device. And what we simply use for the poor man is a rubber bulb. You can fill up the rubber bulb by negative pressure and push the rubber bulb with the nozzle inside the nose, and in a particular position, it goes everywhere. So high volume, high pressure device is needed to allow it to penetrate deeply into all sinuses. That is number two. Then the surgical state of the cavity. This is very important. As I discussed, variety of endotypes of the sinusitis. In the more severe inflammatory form of sinusitis, you need a bigger cavity like this to allow the solution to reach everywhere, really. If you have a AFRS, AERD kind of a condition, If you have a AFRS, AERD kind of a condition and this kind of a narrow cavity, small cavity, limited phase done, it is not going to work. It is not going to allow the solution to reach effectively deep into the sinuses. So the surgical state of the cavity determines the effectiveness of the douching, the effectiveness of the topical steroid to reach effectively into the sinuses. So that is another important factor we must keep in mind. So once you have a massive disease, make sure you do a full house fast with complete, correction of the nasal septum, turbinates, anything coming in the way, so as to allow the solution deeply, effectively, and easily, like AFRS and all those situations. That one should not think of a limited phase, but rather, wide cavity. Then the off level. What kind of steroids you use? These are off level. These are not mometasone, fluticasone. They can't reach deep into the. So what we use is the off level steroids, and this is important to prevent further complication in massive eosinophilic disease, particularly AERD, AFRs, all these, to prevent. If you leave raw areas, to prevent osteitis, stenosis, and reducing the need of the systemic steroids. So what we use, our preferred, there are lots of steroids have been advised. What we use is a budenoside. Budenoside is what? Budenoside we use as respules to treat the asthma by means of nebulizations. What we can advocate to mix the budenoside in the saline. Like everyday patient requires on an average 250 ml of douching solution. If you do twice a day, 60 to 70 ml with a rubber bulb on one side. So four sides, 2 times a day, both nostrils will require an average 250 ml of saline as a douching material solution, and you can mix budenoside 0.5 ml. So 0.5 ml, only 0.5 ml milligram of steroid, that too topical, has hardly any systemic absorption and systemic side effect, and it has been discovered, proven by a lot of studies done after long-term steroid douching of this strength of the budenoside. After 2 years of douching with no effect on the HP axis has been studied well, and so it can be advised safely to all our patients that budenoside can be used as an irrigation material safely as an off-label steroid to prevent the need of oral steroids after the sinus surgery is done. For those patients who require steroid solution, steroid solution therapy post-operatively, particularly in massive eosinophilic diseases. You have seen those endotypes which require long-term massive steroid irrigations. Any other questions? We have 5 minutes.
Sir, what is the role of immunotherapy in AFRS?
Yes, it is optional, I would say, because it has an allergic background. This disease has an allergic background, and these patients are allergic to fungal antigen. We have got, after post-operatively, after the surgery, once the cavity is healing up, and we get those patients skin prick allergic testing, and we have found in certain patients allergic to alternaria and other fungus, aspergillus and all that. And if the patient is found, proven to be allergic to in some particular fungal antigen, you can introduce or you can, advise immunotherapy, maybe sublingual or subcutaneous immunotherapy, those patients, and then it can be effective. So there is no harm if the fungal antigen is identified to introduce immunotherapy to those patients. But definitely no role of antifungals, I would say.
Sir, one more question. Hello, sir.
Yes, please.
Sir, what is the use of this Manuka honey? Is it effective in this nasal topical therapy?
Manuka honey is a different thing. Let me tell you, Manuka honey is a very, very potent, bactericidal agent. Manuka honey is different, and we advocate that for the biofilms. Biofilms anywhere, not only in the sinuses, Biofilms everywhere, let me tell you. Biofilms. So Manuka honey is used for the biofilms. We have salvaged many cochlear implants who developed biofilms with the help of Manuka honey. So biofilms are common in sinuses, particularly after revision surgery, particularly after massive osteitis. And these are most difficult to treat situations because your regular antibiotics do not work. And most of the time in the sinuses, the most difficult are the Staph aureus biofilms. So they require high concentration of antibiotics, which is not possible clinically. So you have to resort on a safer side on the topical therapies. So for biofilms, there are a lot of things to be done before determining biofilms because there are no clinically available tests to identify the biofilms. There are indirect ways to diagnose the biofilms. So the biofilms is one of the biofilms are what? These are the aggregates of the bacterial colonies encased in the proteoglycan sheath, which protects from the patient's immune response of the host as well as the antibiotics. So those are difficult to treat patients, difficult to eradicate the infection, and these intermittently release the virulent bacteria to spread the infection, to initiate and spread the infection. So all these cases, when you suspect, rule out immunodeficiency. Up to 10% of the recalcitrant CRS patients are immunodeficient. That is something which undergoes undetermined, uninvestigated, and these patients are difficult to deal. That's an immune complex disease, and the patient has some underlying immunodeficiency problem, and if that is not treated, how can you expect a good result of a overall CRS patient? So you must rule out immunodeficiency, Staph aureus biofilms and pseudomonas, and out of the Staph aureus are most virulent biofilms, I would say, in the sinuses. One thing which we have identified, which we believe is something which can work as a medical side, is the macrolides. These biofilms, when you go to the pathophysiology of the biofilm, how the biofilm forms, when the bacterial colonies gather together, they have a quorum sensing mechanism to come together and develop that proteoglycan sheath. So that quorum sensing mechanism that works when some minimum quorum of the bacterial colony is filled. And once that quorum is over, the biofilms are formed. Macrolides have been identified as an agent to prevent quorum sensing mechanism for the biofilm formation. So we always give, irrespective of the biofilm, kind of biofilm diagnosis, whatever, we start macrolides to those patients to prevent further biofilm formation. This is something very, very important. And this we have worked on. Many of the cochlear implant patients came to us with the implant infected biofilms all over. We clean the biofilms completely with a Manuka honey wash, with the other topical therapy wash and everything, and then started the patient on macrolides to prevent further biofilm, and it worked like a magic. And we could salvage many of the cochlear implants wherein otherwise they need to be otherwise explanted. So there are many ways. As I said, you need topical therapies. High dose topical therapy yet without systemic treatment is the only or the best way to combat biofilms. If there are pseudomonas biofilms, you can give tobramycin wash. If it is a Staph aureus biofilm, you can give mupirocin wash. Colloidal silver is another agent which is good for all biofilms. And Manuka honey, what we discovered, we have been acquiring for last many years from New Zealand. The true Manuka honey is produced in New Zealand, and the only company which has been approved to detect the medical Manuka honey, the concentration is the Watson and Hill laboratories, and where we acquire this Manuka honey is a real thing which is lethal to any biofilm, irrespective of the diagnosis of particular biofilm. It's lethal to all biofilms. We apply topically, and this is one of the most important agent, I would say, to combat biofilms. Biofilms at any place, biofilm can form on any foreign material or any persisting infection, and this is the Manuka honey, which is active agent is methyl glyoxal. So this is very, very important for any patient suspected of biofilm. If you give 2 or 3 days washes of methyl glyphosate, it disappears like a magic. You know, any kind of infection can be controlled so effectively in no time with the Manuka honey washes. So biofilms, you need to identify, suspect. If it is recalcitrant infection not coming under control in spite of the culture directed antibiotics, and in a post-operative setting, in a prosthetic setting, when once you have used some process around, Manuka honey is one of the best treatment to deal with these biofilms, and we have been doing this.
How would you apply it in a cochlear implant patient?
Hmm?
How would you apply it in cochlear implant patient? You
Explore. Yeah. See the receiver stimulator, which is enveloped in biofilm most of the time. These patients, we have so many patients now come to us. Clean all the biofilm like a jelly, like a jelly from all around. Clean everything. Make the bed completely free of all biofilms. Wash the bed thoroughly with the Manuka honey. Wash the implant thoroughly with the Manuka honey. We submerge the implant in Manuka honey for half an hour or so, and then apply Manuka honey everywhere in the bed and place the implant back, and we start the clarithromycin and the broad spectrum antibiotic covering the Pseudomonas and Staphylococcus both, and amazing results we have once you do all this. So you can salvage many of the implants. Otherwise, that's dangerous to give meningitis, because we have already opened the avenues for the inner ear to the brain, and such persistent infection can be lethal. So we have to do something, and explantation is the only alternative otherwise.
If there is any no more question, we will wind up today's session. So thank you, sir. From 9 o'clock to 6 o'clock, you are continuously, I know it's nothing for you, but big thank you from our side.
Thanks to you for giving this opportunity for this interaction. Thank you once again for bearing with me, I would say.
And tomorrow, 9 o'clock, we'll start Glomus,
yes.
Sir.
Yes.
Okay.
Yes, definitely.
Okay. After that, what are you planning?
Some JNA or something.
Okay. Okay.
Okay, boss.
Okay, thank you.
Thank you all. Thank you once again.
We'll discuss after national anthem.
Yes.
जय गणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, sir. Bye.
Thank you once again.